Dear colleagues, good morning again. I'm really pleased to introduce this very important scientific event organized by Dr. Spargas, Dr. Patakos, and a number of well-known persons, peers at the GIA Hospital in Greece, with a marvelous faculty. And okay, it is now just 9, and it is a little bit difficult time for Athens at the moment, but we have to start on time, of course. My job here, together with Doctors Patakos and Professor Alexopoulos, is easy indeed, because we have to introduce so well-known peers, so much experience in this field. And the first session has the title Transcatheter Aortic Valve Implantation, TAVI or TAVR, 20 years of achievements. On my right is the co-director of the structural department at the GIA Hospital, Stratis Patakos, senior, because in the faculty is Grigoris Patakos, junior. On my left is Professor Dimitris Alexopoulos, senior professor in cardiology here in Athens, in the University of Athens Medical School. Myself is Panos Vardas, a cardiologist from Greece. I have the pleasure to introduce the first speaker, who is Professor Kassel from Zurich University Hospital, head of structural heart interventions at the cardiology department there. The title of his presentation is Lifetime Management of Aortic Stenosis Patients. So let's go ahead, Professor Kassel.
Yes, thank you first for the invitation here. It's every year a pleasure to come. So can I get to my first slide? I have to. Okay, let's go one back. So the title of my talk is Lifetime Management. It becomes an important topic now as we move to younger patients, and we have to understand that patient is perhaps needs not only one treatment. Some patients, the younger patients, they need more than one treatments when we treat them with bioprosthetic valves. So let's look at the incidence of severe aortic stenosis in Europe. Astonishingly, only 50% of patients are still diagnosed with this important diagnosis. Until now, we treated intermediate risk and high risk, more or less, all patients over 75 years old. In the US, now it moves to 65. The future is the low-risk patients, and that are the patients who have a long life expectancy. That are the topics I want to speak about. Low-risk patients, hemodynamics, pacemaker, coronary access, very important topic. And then in the future, valve-in-valve and also TAVI-in-TAVI. And then my idea for the best strategy in the future of these patients. So let's have a look at the guidelines. There are new guidelines from 20 and 21 in Europe and in the US. And what does the guideline say? For high and intermediate risk patients, TAVI and SAVA are co-equal treatment options. We speak about interventions only. And in the European guidelines, every patient over 75, in the US guidelines now, every patient over 65 has to be discussed and offered the option for transcatheter valve treatment. But what is with the evidence for low-risk patients? Also here is very good evidence. We have good studies here for SAPIEN and also for Evolut. And for SAPIEN, the results were even better than surgery. But bicuspid valves were excluded from all these randomized trials. But we have a long, and me personally, I started 2014 to offer routinely transcatheter valve treatment for bicuspid patients also. Here an example. This is a Raphe type. Bicuspid valve is a Raphe in between right and left cusp. Here you see the result with the SAPIEN valve. We use the SAPIEN Ultra here and also an echo. It's a very good result without relevant paravalvular insufficiency. So when we look back and we compared our treated patients, this was out of my time in Munich. As I told you, we started in 2014, and we compared the treatment of bicuspid with tricuspid valves at this time, and with SAPIEN 3, and we could show that the results were very similar. There was not a big difference in outcomes. Yes, perhaps very few patients we sent to surgery. We had to send to surgery because of their difficult anatomy, but most patients could be treated also effective with a transcatheter valve. So let's speak about hemodynamics and gradients in paravalvular leak. I think when we compare transcatheter valves with surgical valves, there is not a big difference in gradients, but still we see with transcatheter valves in 1/3 of patients a mild paravalvular leak in most cases, but we don't see it in surgery. So here surgery is a bit better, but the newer devices are better, TAVR devices are better than the older ones, so there's hope that it becomes better in the future. Pacemaker has a big impact of outcome, especially for young patients. They have to live very long then with a pacemaker. And when they need a pacemaker, it's accompanied by higher mortality, heart failure, and worsening of the LV function. And here there's a big difference in between the valve types what we have on the market. SAPIEN valve here has more or less the same pacemaker rate than surgery, but the other valves have a higher pacemaker rate. Coronary access. So most of 80%, depending on their age of patients, they have both coronary artery disease and severe aortic stenosis. And we have this situation very often, and we have to take care of the coronary access in the future. So there are, as you know, there are different valve types, transcatheter valve types, but also surgical valve types, supra and intra-annular valves. As it is shown here, intra-annular valve, balloon expandable SAPIEN, portico or Navitor, and then supraannular valve types like Evolut or Accurat. And especially for the supraannular valve types, it becomes very important that they are commissural aligned, because when they are not, then a future coronary access could be very difficult. Also, this study showed that you can get really into trouble in the future with supraannular valves. Here, in this study, there was every patient got a heart cath afterwards, and it was not possible in around about 8% to have access to the coronaries, and most of this 8% were supraannular valves. So, but is it possible to do commissural alignment with SAPIEN? We tried also. It's very difficult to predict the commissures, even you crimp it in a special direction. With Evolut and Accurat, it is, thanks God, feasible. In the future, also with balloon expandable valve, perhaps commissural alignment is possible. Here's X4, what is now in a trial. So, what is? Let's look at the patients who we treat with degenerated surgical valves, and so here is the question always: what is better? Do a second surgery, open heart surgery, or do a valve in a surgical valve, valve-in-valve therapy? And here also there are a lot of studies, and I think most of these studies show that a valve-in-valve transcatheter therapy is safer, but has a higher chance of patient prosthesis mismatch afterwards. So when you treat a small valve, then you have a very high risk with the transcatheter valve to get a patient prosthesis mismatch afterwards. And this has also an impact on the future of these patients. They have a worse outcome when there is a patient prosthesis mismatch. So the therapy then is not this effective. You change a high degree stenosis against perhaps a moderate degree stenosis. There are different concepts. Yes, you can treat with an intra-annular valve like the SAPIEN valve. Here, perhaps the gradients are higher, but you have still a coronary access, or you can choose a supraannular valve, very common, the Evolut, and here the gradient perhaps is lower, but then the coronary access is more difficult. But we have also the option to fracture surgical valves. Most of these valves they have a plastic frame, and you can burst this frame with a high-pressure balloon, as is shown here. A small surgical valve perimount with a plastic frame, easy to fracture, inner diameter 19. Here, implantation of a 20 SAPIEN valve. And then post-dilatation with high pressure with a 20 millimeter true dilatation balloon with a pressure above 20 atmospheres. And here in this situation, you stretch most of the valve, and some also you fracture. In this case, we fractured. And we could show that the nominal diameter of the SAPIEN valve, implanted SAPIEN valve, had afterwards nearly 20 millimeters. And so we lost with this treatment not space, because the surgical valve had 90 millimeters also beforehand. And the gradient showed also the same. What's about coronary access? There are also techniques available to prevent coronary occlusion, especially in tight anatomy and when you have low coronary arteries after surgical valve implant. Here is shown basilica technique. So it is feasible on the left side. In most cases, it's difficult on the right side when you do. It's a complex treatment, but it works. So it's shown here. And then afterwards, even the coronaries are low, you did a safe treatment. So this is my last slide, or one before last slide. What's with TAVI in future? We see more and more patients coming back with now degenerated transcatheter valves. When I'm honest, the numbers, expected numbers are higher than the reality. We don't see this many patients. I don't know how it is in your country. But what makes it difficult to treat in the future this patient is when they got as first valve a supraannular valve type, and when the anatomy, the root anatomy is very tight in this patient's narrow aortic sinus is very difficult later to treat with the second valve because of the risk of coronary occlusion. So what is my idea? What is the best treatment for this kind of patients in the future? So conventional strategy for these young patients is they get offered a mechanical surgical valve. But there are also alternatives like homograft or Ross procedure. Homograft, the results were not this promising. Ross procedure, very complex treatment. Not everybody can do this. Same with Ozaki treatment. So, but a lot of these patients, they say, no, I don't want a mechanical valve. That's in our country because of lifestyle. We don't want to have anticoagulants for a long time. And so they want to have a bioprosthetic valve. And then, in my opinion, it becomes open. It is unclear what is the better strategy, surgical way or a transcatheter way. And so I think we need another, we need a help here. We need information about the anatomy of the patient. We need a CT. And based on the CT, when it has a suitable anatomy for TAVI, why not starting with the TAVI first? When you start with the TAVI first, then, in my opinion, you have to start with the intraannular valve, and because then, when the patient coming back, you have a second option without a big influence with the coronary access. When a patient has not a good anatomy for TAVA, then sure, they need some of difficult bicuspid valves, especially. They need a surgical treatment. But when a surgical treatment with the valve, that we really later can treat easy with the transcatheter valve. And there are not a lot of good valves on the market. And there are a lot of bad valves, what makes us trouble. And I think here, then, for example, here is Inspirus valves, but there are other valves also, but you can treat easy. But there are really valves, it becomes very difficult for us. This is my last slide. Thank you for your attention.
Thank you very much, Professor Kassel, for your very constructive presentation. No doubt, there is a huge area for discussion here, a lot of questions and comments possibly around this very fast evolving area. But my humble proposal is to ask the next two speakers to present, and by the end, to have a discussion of around 15 to 20 minutes,
okay,
if possible. So I'm here. Like kindly to ask Professor Patakos to introduce the next speaker, please.
Okay. It's a privilege to introduce the next speaker, Professor Theodore Kofidis, who is a Greek well-known heart surgeon who is thriving in the Far East. He is in Singapore, in the university. He is the head of the Department of Cardiac, Thoracic, and Vascular Surgery in a trust of university hospitals. It's really a big opportunity to have him. He's pioneering in a lot of different ways in cardiovascular surgery. Recently, we had the opportunity to have one of his residents as part of our team at the GEA Hospital. So it's very nice to see you here, Theodore, and we're looking forward to hear your topic, which is progress in the aortic valve replacement in the last 20 years.
Thank you, Chairman, for the kind introduction. It's entirely my privilege and my pleasure to be here on the way back from the Mitral Conclave in New York and the AATS in LA. I must say that the stopover in my native Greece is a bit like a cherry on the cake. But I also bring certain new conclusions that I had the pleasure to win over there in those two conferences, which I will briefly share with you. Now, the evolution or progress that was achieved in the last 20 years in surgical aortic valve replacement happened to exactly coincide with my time as a specialist cardiac surgeon. And so by surveying upon these accomplishments in the last 20 years, I'll take you through my personal journey as well. I would say the biggest evolution in this time of transcatheter procedures, let's face it, the big milestone here was the development of transcatheter procedures in the last 20 years. The biggest evolution from my perspective, and I say that entirely non-emotionally and dispassionately, was the way we do aortic valve replacement, which is now finding its place within the portfolio of cardiologists and heart surgeons. These are my disclosures. So in my short presentation, I will go through the progress, eventually also regress in some areas in aortic valve replacement, starting with better valve prosthesis, better prosthesis treatments, therefore better durability, better surgical techniques, better regulations and guidelines, or not, better doctors, the multidisciplinary teams, better outcomes eventually, and what about some failures that need to be mentioned as well? Now, there is a plethora of prostheses out there in our armamentarium, and some of them have been mentioned by my esteemed predecessor in the podium, including the Osaki procedure, which I did not include in my slides, which is indeed very interesting. One of the conclusions drawn in AATS was that the Osaki procedure presents very promising 11-year follow-up results, over 1,600 patients so far. So promising. Let's see how that develops. The neo-cuspidalization, otherwise known as AV-neo, with the patient's autologous pericardium. Now, again, from my perspective as a surgeon, I think surgeons must think more laterally. The procedures we put in the heart, both aortic as well as mitral, are in a way mechanical in their function. In the aortic valve, not that far from the biomimicry nature of the native aortic valve. In the mitral prosthesis, far away from that. They look rather than washing machine valves, and we accept them because they work, but they are not optimal. Please hold that thought for eventually the next presentation tomorrow. So better prosthesis. Indeed, let's take the ONX, for example, mechanical valves. The ONX has a higher collar. I personally like it in redo cases. It protects the LVOT, and it can go with a much lower INR because the leaflets are hinged. They are flotating. They are levitating within the ring. Therefore, they allow for less anticoagulation. They are not so thrombogenic as others. Now, you'd be eventually surprised to know, in a recent paper that I reviewed, it's still in press, so I must keep it confidential, over a retrospective. Over the years of TAVR, how did SAVR develop? It's interesting to see that it's the mechanical prostheses that almost doubled in their frequency of implantation, not the biological prostheses that are good and eligible for later valve-in-valve. The mechanical prostheses have doubled. So then we can mention the rapid deployment mechanisms such as the Intuiti as well as the Percival valves, which, to be honest, didn't reach wide popularity worldwide, even though we have done the first in Asia in 2012, and quite a number of those. We basically use them in small annuli, most of the time, to basically get out of the operation theater without complex enlargement techniques, root enlargement techniques, with the least possible, with the best possible impunity. That's the rapid deployment procedures. Better raw material treatments. Inspiris was mentioned before. By stable capping, industry promises a better durability of the valve prosthesis. That remains to be seen. Better prosthesis designs. Now, particularly for those of us who indulge in minimal invasive and endoscopic cardiac surgery, you want to have a valve that has a forgiving annulus, forgiving stents, flexible stents which you can grab or cinch for the better, easier experience of implantation, and one-cut release mechanism, and certain other aspects that are important for an easy implantation of the heart valve, as you see here in a endoscopic aortic valve procedure. Now, better surgical techniques and tools have entered the market, which require mention. For example, we started doing robotic aortic valve replacements right now. On the left upper side of the slides, you appreciate our full minimal invasive program that covers the entire spectrum of pathologies. And they're devices like this, automated knot tying devices, as simple as it sounds. On a lighthearted note, I keep saying that the best and most important invention of the 20th century in heart surgery, without doubt, was the introduction of the heart-lung machine. In the 21st century, people expect us to say it's the Da Vinci robot. I believe, no, it's not. It's this simple device here, core knot, okay, which wins you quite some time during the procedure and facilitates easy, minimal invasive access procedures. Now, the introduction or 3D cameras down here. The introduction of new technology facilitates things, may make them easier, but it also, in often cases, it raises the bar for us surgeons, the bar and the learning curve. Better perioperative treatment protocols. For example, take the ERAS, Enhanced Recovery After Surgery protocols, whereby patients receive a certain treatment before surgery, intraoperative anesthesia, and postoperative care, so that they can be discharged from the hospital in no time, in 3 to 4 days or 3 days, and enjoy a better patient journey altogether. How about multidisciplinary teams? The way that we work together in deploying aortic valve replacement, in delivery of aortic valve replacement to our patients has changed entirely by the formation of the multidisciplinary teams. Of course, we surgeons, and again on a lighthearted note, I let you guess who is the cardiologist here and who is the surgeon up here. So very easy to guess, I assume. We surgeons hope that we will all develop to something like a hybrid chimera kind of being here, but I think what we have today is more of this, let's face it. Now, another news from the AATS is that we formed an inter-society leadership task force under the guidance of Yolanda Colson, the current president of the AATS, and we are forming a task force, a group, to define our own cardiac surgery guidelines, away from the traditional guidelines. And let's wait and see what this means in specific. Now, better outcomes. In the time that TAVR has been conquering the field, surgeons have not been idling. The outcomes are becoming better during this time through better perioperative protocols, better surgical techniques, better experience, and so forth. Now, the regress. We also have failures to report, the so-called wrapped valves, the valves with an internal stent and external leaflets, for example, the mitral flow or the trifecta. All of us surgeons have encountered cases of redo aortic valve replacements with these prostheses when these prostheses were implanted in the first case. And from what I understand, they are also difficult for our cardiologists to treat. They have to break leaflets and stents and go through quite some effort to implant a valve-in-valve without jeopardizing the coronary in such prostheses. They tend to calcify faster and cause the patient to come for a redo. Now, and I come to the second part of my presentation, which relates to the way we implant our valves, which I believe is the biggest breakthrough. Not only from a personal perspective, but minimal invasive and endoscopic cardiac surgery tends to develop a life of its own in a gray zone between SAVR and TAVR, because let's face it, many of the TAVR implantations around the world, of course, no doubt with great benefits, are because the patient doesn't want an open procedure, and not only by, let's say, tangible criteria. So eventually minimal invasive and aortic valve surgery, which has never been truly prospectively and randomized controlled compared to the TAVR procedures, may hold its own in the interspace between TAVR and SAVR. Now, most of us heart surgeons go through the mini J stenotomy when we start our experience with minimal invasive, such as this case, which I've done many years ago. This is not the way we do it nowadays, but a mini J gives you optimal access to the aortic root. You can do simple dissections from there, root replacements, David's aortic valve replacements, and other procedures. Very good access to the operative situs, as you can appreciate here. I've even done combined cases here with bypass on the right coronary artery and so forth, which are all very easy. Again, perfect access with the mini J stenotomy. There are some things that you can do. For example, a very long, big, and elongated aortas. The heart is pushed to the lower, to the costodiaphragmatic angle on the left side, and then you don't have very good access. These cases are to be avoided, as defined by pre-op CT scan. Now, from the mini J stenotomy, surgery of the aortic valve replacement has moved on to the RAT procedure, right mini thoracotomy, right anterior mini thoracotomy, which usually involves a luxation of the third rib, which we put back together. Many surgeons will dissect or clip the rima, which is not a big crime, so to speak, unlike what many people would think, because what would you guess is the rate of people who come from an aortic valve replacement who will need a bypass later on in their lives? So it's less than 1%. So sacrificing the rima from here is not the end of the world. There are some criteria that apply for this type of procedure. For example, the aorta must be rather on the right side of the border of the sternum at the height of the pulmonary bifurcation and less than 10 centimeters from the interior chest wall, as you will appreciate here. That's the RAT procedure. I have to switch over here to play the video. And you see that with following the principle of progressive exposure, you can get the aorta nicely towards the surgeon on the right side of the patient with beautiful exposure of the aortic root. And that's the end result. This being a chest tube, this is a JP drain, intrapericardial JP drain for the drainage of the patient. And you can do younger patient, older patients, obese patients. This patient of mine, 150 kilograms, you can still proceed with the RAT procedure. And the last part of my presentation refers to the total endoscopic aortic valve replacement, which now constitutes about 90–95% of my own practice and gains ground across the world in the way we do aortic valve replacement. So now the indications, the topographical indications are a bit more lax here because the rule of the aorta having to be on the right side of the sternum doesn't really apply anymore by the convenience of the camera. The moment you insert a camera, the camera will get you right on the spot and you can do the procedure even if the aorta is behind the sternum. Central contraindications, relative and absolute, major annular calcification, severely calcified ascending aorta, therefore, concomitant procedures, of course, chest wall deformities, anatomical position of the aorta, severe obesity, redo aortic valve surgery, and so forth, irradiation, cancer treatments, and so forth may constitute contraindications. Fem-fem cannulation, this is the way we do it. Let's not forget there is another groin if we run into spasms and low flows and problems like that. This is our setup in the operation theater. I usually put the vent in the same intercostal space. The camera goes one intercostal space below. It's a 30-degree scope that gets you right on the spot when you need to be. I'll show you a bit of a procedure. This one I've done with the help of a Greek fellow who visited us for a year. So you see the setup here. In the interest of time, I'm jumping through the video. You don't need to open the pericardium too far when you do the endoscopic procedure, just 5 to 7 centimeters, cross-clamping the aorta. The opening of the aorta itself has to be a bit wider when you do the endoscopic procedure. Exposure is key, retraction of the aortic wall. Application of cardioplegia. Here you see the retraction of the aortic wall. Insertion of the flagellated sutures. Here we're implanting an O-nix mechanical prosthesis or an avalus. Both is possible. It doesn't have to be a rapid deployable valve. Quality controlled by check for paravalvular leaks and the patency of the ostia, and then closure of the aorta in 2 layers. The cardioplegia we choose is the del nido cardioplegia for known reasons. It gives us less arrhythmia after removal of the cross clamp. I'm not going to go into the detail, and this is what the patient walks home with. A 2.5, 3 centimeter incision. Sometimes we have to insert the retractor just for the time that we need to pass the valve through and parachute it down. In the interest of time, I'm going to skip through this video. Implantation of the valve, parachuting down of the biological procedures. This is an avalus by electronic, enclosure of the aorta, the airing procedures, release of the clamp, and that's it. And that's the way more and more surgeons perform aortic valve replacement. Good result over here. Now, we go for a limited dissection of the femoral vessels. We work together with our anesthetist to guide the wires and the cannulation, of course. Pericardial stage sutures as well as the aortic wall sutures, and exposure is key. No extensive opening. The 3D video, yes, it can speed up the procedure, but a 3D camera is double the size of the 2D camera. Let's not forget that, and you must keep in mind also that the patients we deal with in Southeast Asia are half the size, very, very small compared to the American or the average European patient. So if you insert a 1 centimeter scope right over here and create a hole that you don't need even for a chest tube, it's a bit of an issue. Now, they say that there are some caveat and controversies, morbidity of peripheral cannulation. We didn't have one loss of leg or ischemia. We consider it a bit of an exaggeration if you do it right. And somewhat longer operative times compared to standard stenotomy, which doesn't really fall into significance. What's wrong here? Something's wrong here. Excellent. So it's a situs inversus, a complete situs inversus with dextrocardia. Is this case amenable for minimal invasive endoscopic procedure? Yes, it is. It's a complete situs inversus with the pulmonary veins on that side as well, so easy to access. You can still do a perfect endoscopic procedure and replacement of the valve. And I will finish by a bit of a cherry on the cake. We've done the first in the world about 1.5 years ago. The holographic guided minimal invasive endoscopic aortic valve replacements. We take the pre-op CT scan, produce a holographic image using Microsoft HoloLens software, and we take this image, we superimpose it over the patient in the operation theater, 1-to-1 exactly, and that tells me what to anticipate, what to put in my vent, the clamp, everything, and where to do my incision. So now you may say, yeah, that's not necessary, it's a gadget. Yes, it is a gadget, but what is a gadget in 2023 may be routine in 2035. So it's a good thing to have. And once you have strategized your procedure and you know where you're going to deploy your instruments and your incision, then you can basically pinch it and take it away. Here, for example, if I didn't have the holography, I would have opened perhaps one intercostal space too high. So new technologies are conquering the field. As I said, make the operation more facile, but at the same time raise the bar for the user. So one intercostal space lower, and once you are happy with the access, you can literally pinch it and toss it away and continue with your procedure. All of this and more you can find in our book, a dedicated book of minimal invasive cardiac surgery, written by a consortium of top cardiologists and heart surgeons around the world. And in this book, the particularity is that it's the first book in history that employs QR codes. As you read along, you read the practical tips and you scan the QR code and can see basically how the procedure is done on the spot. With that, I came to the end of my presentation today, and I'll thank you for your attention.
Thank you very much for your presentation, Professor Kofidis. You really illustrated all the progress, and we were very happy to see that we're approaching to be quite minimally invasive as surgeons as well. After the presentation of Professor Erdon, then we'll have questions from our colleagues. Professor Alexopoulos.
Dear colleagues, it is my very great pleasure to present the next speaker. who is going to talk about a very interesting topic. Actually, it's one of the major evolutions in practicing the management of severe aortic stenosis recent years has been the change from operative risk assessment to age criterion to select who is the appropriate mode of treatment for which patient. Professor Michael Reardon from Houston Methodist Hospital at Houston, Texas, is the most appropriate person to give this talk as he is world pioneer in the research around this field. Dr. Reardon.
Well, thank you. I want to thank the organizers for inviting me back to this meeting. It's always a great pleasure to come to Athens. And if I can get my slides up, please. So we're going to talk a little bit about how confident are we that the TAVI guidelines are really appropriate as we switch to age rather than risk. And these are kind of my conflict of interest across the TAVI field, but my biggest conflict of interest is I'm a cardiac surgeon. I like doing aortic valve surgery. I really enjoyed the first two talks. In fact, I did my first aortic valve replacement in 1983 with Denton Cooley. And in 40 years, it's really interesting to see how it's progressed. And most of the progress has come really over the last 20 years as TAVI has forced us as surgeons to do a better and better job. So if you look at the US guidelines, you saw this very briefly. The US guidelines really divided into three groups. If you're 65 or less, you're going to live 20 years or more, they still recommend that you have surgery. If you're 80, you're going to live 10 years or less, they recommend, as long as you're appropriate for a transfemoral TAVR, so that means, to me, not necessarily transfemoral, but any access that doesn't put a hole in your chest, you should still have TAVR. Between 65 and 80, you look at the physiologic risk of surgery, the anatomic risk of TAVR, and the patient's wishes. The European guidelines are a little more conservative. What the European guidelines say is that if you're 75 or less and your risk STS or Euroscore 2 is 4 or less, then you should probably still have surgery as long as you're operable and really unsuitable for transcatheter TAVI. If you're 75 or older, or your STS or Euroscore 2 is above 8, then you should have TAVI instead of surgery. So a little more conservative. So what we're going to do is, I think, try to look at where we fall between these two. And in fact, at PCR, we're going to present the low-risk data from the randomized Evolute trial for patients less than 75 as one way of kind of look at this, and Tommy Modine will be presenting that. So how did we get to where we are with our current guidelines? We did it mainly through the randomized trials. And the first two randomized trials were the PARTNER 1A trial for high risk and the core valve high risk trial. In these trials, the primary endpoint was all-cause mortality. And in the PARTNER 1A, there was non-inferior all the way through 5 years. In the core valve, it was actually superior for TAVR in years 1 and 2 and non-inferior by year 5. In fact, I was so shocked as I was the lead surgeon in core valve high risk that we didn't beat TAVR, that I went back and looked at every death, when they occurred and why. It was really interesting that between 0 and 30 days, there was no difference in the mortality between TAVR and SAVR. And after 120 days, there was no difference. And the only difference between 30 days and 120 days where TAVR actually was superior statistically to surgery. So why would that be? Well, how do we define mortality in surgery? 30 days are in hospital. We kept all these very old, sick patients who were mean age of 84 alive, and then they went to long-term care, and they died in long-term care. But if you survived 4 months, you got better. So as you look at higher risk patients, it's this physiology and ability to recover, not so much the operative mortality that matters. Then we went to intermediate risk. Now, intermediate risk, the FDA changed the endpoints because in PARTNER 1A, there were statistically more strokes in the TAVR arm than there was in the surgery arm, and that worried everybody. And so at high risk, that primary endpoint for both trials became all-cause mortality or disabling strokes. And if you see in the PARTNER 2A trial, it was non-inferior, but the lines cross at 3 years, and they're unfortunately heading in the wrong direction. Now, we're going to get 10-year data, and it's going to be very interesting to see if this is much like Excel and other trials, where as you go from 5 to 10 years, surgery actually starts to look a little bit better. In the SURTAVI trial, it was non-inferior all the way through 5 years, and it really hasn't changed. So then we went to low-risk trials. In low risk, you're going to have less events, so you have to do something. You have to add patients, you have to add time, or you add events. Patients can cost more money. These were already expensive trials, and time can cost more money depending on how you do it. So Marty Leon and Michael Mack decided they'd add events, so they have a primary endpoint of all-cause mortality, all stroke, or hospitalizations. And they were statistically positive for TAVR, but a lot of this was driven by hospitalizations. Jeff Pop and I, when we ran low risk, said, well, listen, we're going to be low risk, we're going to have to convince surgeons. If you use hospitalization, surgeons may not be convinced by that because it can be a subjective thing about who you hospitalize and who you don't. So We stayed with all-cause mortality or disabling stroke, but we used a Bayesian analysis, which lets you predict the two-year endpoint before you actually get to 2 years, although we've gone back and validated that with full 2-year data. And it was non-inferior. So when you look at one as superior and one non-inferior, remember, these are completely different endpoints. In fact, when I added hospitalization in, the low-risk trial for Evolut became superior too. That's one reason why Gene Brunwald, when he discussed this, said this was such amazing data for low risk. And so we got that approved. Now, there are some Kaplan-Meier curves that we can get out of the low-risk trials that I think are important for us to look at. If you look at 30 days, the TAVR mortality was 0.4% in both trials, surgery 1.1 and 1.2%. TAVR always has had an early advantage over surgery. The question has always been, is it going to last, particularly as we go to younger patients? You go to 1 year, you notice that both TAVI and surgery are lower risk in the partner trial than the lower numbers in partner trial than Evolut, and that's because they brought in a lower risk group of patients, and we can talk about that later, about why we know they're lower risk. A big part of it was that over 1/3 of the patients who were deemed appropriate locally were then screened out by the National Screening Committee. If we look at stroke, stroke was statistically positive for TAVR, less stroke in TAVR than surgery, and both these trials kind of reverse of the partner 1A. And remember that the embolic protective device, the Sentinel protection device, only became commercially available in the US halfway through this trial. And Marty, Leon, Mike Mack, myself, and Jeff talked about this. We decided we weren't going to allow them. We couldn't ban them, but only a few percent had embolic protection device. But even without embolic protection devices, you see the stroke rate was very low. And then you went to hospitalization. Hospitalization was statistically positive for TAVR in both trials. So we know that low risk at 1 year looks pretty good, but how does it go further on if we're going to have if we're going to change our guidelines to less than 75 or down to 65? Well, this is the 2-year partner data. You can see that the primary endpoint of all-cause mortality, all-stroke hospitalization is starting to narrow from a delta of 7.1 to a delta of 5.9. And if you look at mortality, it narrows even further, a delta of 1.5 to about 0.8. It's half the delta. And even in stroke, it's starting to narrow to about half that. Unfortunately, this is starting to look like the partner 2A data that crossed at 3 years. We should get the partner 5-year data this year, and it's going to be interesting to see. Hopefully, these don't cross like that, but they're certainly heading in the wrong direction at 2 years. We published a 2-year all-cause mortality disabling stroke from the low-risk trial, and you can see that it hasn't changed at all. The early advantage of TAVR maintains, and this is true for both mortality and for stroke. And in fact, this year, John Forrest presented our 3-year low-risk data, and this recently we published this in JACC. And what you see is the delta at 30 days, which is 1.8% in favor of TAVR, was 1.8% at 1 year. It was 2% at 2 years. It's now gone to 2.9%. So now this is the first time we've actually seen the early advantage of TAVR is actually widening with time rather than staying stable. We're going to look at the 4-year data this year. We probably won't publish that, but the 5-year data is going to be out a little bit later than the partner data. Again, we got our data on the podium at ACC when I gave this with Marty, only because we used a Bayesian analysis, so we're running a little bit behind. But certainly with this early data, it would suggest that things are moving in the right direction for TAVR, at least with the self-expanding valve. And this is true, mainly driven by mortality. Again, something that's very important is your mortality was actually better using TAVR with the self-expanding valve. Now we have some longer-term data. This is the NOTION trial, which is the Nordic trial, the Finland, Norway, Sweden trial that looked at people 70 or above. It was a very early trial with the original core valve designed as a superiority trial. And we're out to 8 years now, and you see there's no difference in all-cause mortality out to 8 years. The last person in NOTION crossed a 10-year endpoint in April. So we're going to get 10-year data pretty soon for the NOTION trial, which would be, of course, the longest follow-up we have up to date. How about less than 65? That's one of the things that we're asking about. Well, if you look at the two trials, in the partner trial and the Evolut trial, only 7% were less than 65 in the partner trial, and only 6% were less than 65 in the Evolut trial, and only 1.3% were less than 60. Now, I ran the screening committee for Evolut, so I can talk about that. I can't really talk about the partner because I wasn't part of that trial. But if you were less than 65, you didn't get into this trial unless you were not a normal less than 65. There was always something else going on with you. So these weren't really robust 65-year-olds. So how about how people were randomized in this trial and what was the risk level? Well, again, all these patients were seen at a local heart team which deemed that they met all the inclusion, had no exclusion, and they were anatomically appropriate for TAVR with the valve chosen and surgery. One would think then it went up to the National Screening Committee, virtually everybody would be accepted. In the partner trial, 34% of the patients were screened out at the national level. 34%, a third. If you're screening out 1/3 after the local team has said, this is not an all-comers trial, and 14.8% were screened out in the Medtronic trial. So as we do this and we look at this data, remember, these are pretty highly selected people. These are not all comers. How about bioprosthetic valve dysfunction? This is David Capodanno's work from Europe, and what David has said is that bioprosthetic valve dysfunction is divided into 4 broad buckets. There's structural valve deterioration when there's something wrong with the valve itself. Non-structural, there's something wrong around the valve, thrombosis, and endocarditis. Now, there's a lot written about early failure of surgical valves. We wrote our first paper on early trifecta failures in 2017. Trifecta was then owned by St. Jude. The St. Jude people I knew very well told me I shouldn't publish my paper because they had better data. I said, well, publish your paper. We saw a lot of early failure in trifectas. Since then, both Cleveland Clinic and the University of Michigan have published studies looking at over 1,000 trifectas compared to 1,000 Carpentier-Edwards, and both have shown trifectas fail early. So when we start talking about structural valve failures, you have to remember it's not just a class of valve, either bioprosthetic versus TAVR. Each valve has its own failure rate. Valve failure is valve design and tissue science. And so we can't compare surgical valve to surgical valve and think they're going to be the same. We can't compare TAVR valve to TAVR valve and think they're going to be the same. So what do we know about TAVR durability? Well, we have 5-year durability from the high-risk trials, but remember the high-risk trials were mean age of 84. We don't expect these valves to wear out in these patients' lifetime. They're going to die. We went to intermediate risk. The mean age was 81. We're still not going to learn much. And we've gone now to low risk where the mean age was 73.5 to 74. We may learn a little bit more, but that's still a relatively elderly population compared to what some of the ages are where people are putting in surgical biologic valves. And we also have some durability at 8 years from the Notion trial, again showing really good durability of TAVR valves and surgical valves. Now, one of the things that Lars Sondergaard did was Lars went in there and said, well, most surgical trials, and there was recently at AATS a thing on the resilient 7 years, use Aitken's definition. And Aitken's definition was basically saying when your valve fails and you come back to surgery, it's a failure. Well, a lot of these people just don't come back. That's a very poor definition. So most of us have gone to the VARC definition. And what VARC says is if you, from your discharge or 30-day echo to your current echo, if you have an increase of the mean gradient at 10 millimeters of mercury or more, and a final mean gradient of 20 millimeters of mercury or more, then you have moderate structural valve dysfunction. And if it goes up by 20 and ends up at 30 or more, then it's severe. Well, what Lars found was that there was double the risk of moderate structural valve deterioration for surgery as opposed to TAVR. Again, somewhat different than what we think, because as a surgeon, I always told people you should do surgery because we have the durability data. And if you look at for severe, numerically a little lower for TAVR, but no statistical difference. So we were very interested in this, and I presented this at ACC, I don't know, 2 years ago, I guess, and published this in JAMA Cardiology. And what we wanted to do is we looked out there and said there was limited data that existed on the incidence and factors that were associated with structural valve deterioration after TAVI surgery from large-scale, multi-center randomized trials. Now this is Pibro's work from the Partner 2A trial, which we already talked about. Partner 2A, remember, was XT, an earlier generation, randomized against surgery with a non-randomized continued access arm of S3. And XT had statistically more structural valve dysfunction than surgery. S3 was 3.9 versus 3.5, so it was no difference. This was considered a win. But if you read the paper and go back and look at when they really did some matching, in years 4 and 5, S3 actually had more structural valve deterioration than surgery. So we really wanted to go, based on some of our prior analysis, to see what was going to be the 5-year incidence, outcomes, and predictors of hemodynamic valve dysfunction in patients that had a core valve evolute versus surgery from our high-risk and intermediate-risk trials. So the way we did this is we took the high-risk and the SURTAVI randomized cohorts, and we used the randomized cohorts to compare the differences in structural valve deterioration. We then add in the non-randomized continued access, because they're not going to be the same. They never are when they're non-randomized. And we used that greater number, going now from 2,000 to 4,700 patients, to look at the clinical outcomes and the predictors of structural valve deterioration, use the definition I told you about. And we had an independent core lab, JO's Mayo Lab, and I went over this with Steve Yakubov and Kendra Grubb, and we looked at every single one of these to validate what the core lab said. And what we found is that at 8 years, the structural valve deterioration rate between surgery and TAVR was statistically less in TAVR. This was really the first time this was shown. In fact, when we presented this at ACC, this was actually got more buzz than when I presented low risk or presented intermediate risk, because this really was a little unexpected and somewhat turned a discussion on its head about what had the best durability. If you look at small annus defined as annus of 23 or less on CT, the difference was even wider for the self-expanding valve over surgery. And at 23 or more, it was still numerically better for TAVR, but it didn't reach statistical significance. Now, the money slide is this. If you had moderate or greater structural valve deterioration, whether you had surgery or TAVR, it doubled your risk of all-cause mortality, it doubled your risk of cardiovascular mortality, and it doubled your risk of being rehospitalized. It is not a good thing to have even moderate structural valve dysfunction. Who did not get structural valve deterioration? Men, older patients, those with atrial fibrillation and those with prior PCI. Who got it? Those with larger body surface area. Now, the converse of that is who does get it? Younger women who are healthier. Why did PCI and AFib not get structural valve deterioration? Could be the competing risk of death, or it could be their own anticoagulation. I don't have an answer for that yet, but we're looking into it. So the conclusion was if you had surgery, you're going to have a higher risk of structural valve deterioration in this randomized trial compared to the Evolut core valve. And if you got it, it was going to double your risk of dying and double your risk of being rehospitalized. Steve Yakubov then went and looked at from structural valve deterioration to all structural valve dysfunction. We did a similar analysis looking at the randomized and the non-randomized cohorts. And what Steve showed is for all structural valve dysfunction, it was statistically higher for surgery than it was in TAVR. And this was mainly driven by two things: the higher structural valve deterioration in surgery and the higher rate of patient prosthetic mismatch in surgery. Thrombosis and endocarditis were no different. So when I look at this, I kind of do this in my age when I'm thinking about the guidelines. The orange bars here are U.S. life table analysis. I will ask you to remember that when we put in a biologic valve, unless it's a Ross procedure, you will lose life years off your life. The Ross is the only operation that keeps you on a normal survival curve. So these are normal survival curves, so you actually have to subtract a little bit to get it. And the box up here is Carpentier-Edwards, which is where the supraannular valve seems to be following, and it's our best surgical long-term data. So if you're 80, you're going to live about a little less than 10 years in the U.S. Europe is about the same. And your risk of valve deterioration that time is about 4 or 5%. That's a pretty good thing. You're unlikely to need anything in your lifetime. If you do, you're only going to need one more thing. 75, you're going to live about 13 years, maybe a little less. The risk now is about 8%. Still a pretty good thing. I think the European guidelines are very conservative. Move down to 65, now you're going to live about 20 years, and the risk goes up to about 18%. And we can argue about how good that is and whether or not that's right or not, but you're still probably only going to need one lifetime thing. Now, when I choose for a lifetime valve, one thing I ask myself is, who has the best hemodynamics and the best durability, which is what you're going to live with every single day? And then I think, secondly, about coronary access and valve, because those are only theoretical things in the future. And as you heard from the biologic, the surgeons only think there's going to be a 1% chance you're going to have your coronaries done later on. So it's not a very high-risk thing. But hemodynamics and durability is something your patient lives with every single day. And we have some pretty good data that if you don't get to an EOA of at least 2 when you're younger, you cannot increase your flow without increasing your gradient. Remember, the mean EOA from Becky Hahn's work for a Evolut valve was 2.03, for an S3 valve is 1.66. And these are going to be important as we move to younger patients. It's not important if you're 80 and you're sitting on the sofa, but if you're a young 70-year-old like me who gets up every day and runs, it's going to be important. Thank you very much. I enjoyed the opportunity to talk to you.
Thank you very much, Professor Reardon.
Thank you very much indeed, sir. So, dear colleagues, we had the opportunity to listen 3 marvelous presentations, and now I would like kindly to invite the three speakers to come here at the stage to have a short, but I think important discussion with the audience. Great. Thank you very much. So,
if I can start with Professor Kofidis. There is no question that all those innovations in cardiac surgery, they promise and they offer better care to the patients. The thing that we don't have the experience, and you have seen that, and I would like to have your comments, 2 things. in the real thoracoscopic, how you manage the LV vent? And second, how is the internationally being everywhere and seeing the results and the effort? How is the learning curve problems? Because it's, of course, it's a very nice thing to have my valve replaced with minimally invasive technique, but if I have to have with a very well-known expert. If I'm going to have my valve with somebody who is evolving, I would like to have another 3 centimeters opening of the sternum and be sure that I'm going to have a safe result.
Thanks for the very reasonable question. I guess that applies for any kind of surgery, any kind of innovation. So we can't change it, of course. Procedure takes time to establish itself. We had this discussion in earlier years with the open versus laparoscopic abdominal surgery. It went on with open lung surgery, which nullified VATS procedures initially, and now there is not a single thoracic surgeon I know that doesn't do VATS or even uniport procedures. So it's a matter of evolution and part of human nature to evolve. Let's face it, minimally invasive and endoscopic aortic valve surgery is conquering the planet right now. And there are some barriers, of course, and this can be multifold, one of which is entropy, as we say in Greece, comfort zone. We're used to do things, and if we do them well, why not proceed to do median stenotomy? Now, the learning curve is somewhat dramatized. If you have a very structured program and a structured way to teach, you'll be surprised how fast we can turn a traditional surgeon into a minimal invasive surgeon. I can speak from my humble experience because I've been teaching over 10 years now and proctoring across Asia, Pacific, and in Europe. And we have a syllabus, a very structured way to teach this even young surgeon how to transit into minimal invasive heart surgery. And it's absolutely plausible within only a few procedures. Having said that, it's important how you select your patients. You don't go into the very difficult procedures right from the beginning, calcified aortas, topography questionable, borderline, and very small annuli. So it's a stage progress, so to speak, but absolutely feasible. You definitely don't need 2 years of fellowship in any of the big centers in the world or in ours. It requires good proctorship and a good communication with the receiving team.
Thank you very much. Questions? Gregory.
So thank you very much to all of our speakers, and thanks for being here with us today. Outstanding talks. I think that, when we discuss transcatheter aortic valve replacement and surgical aortic valve replacement, I think one of the impediments to the wider adoption of TAVR perhaps is us as cardiac surgeons. And I think one of the reasons of that is, we have to discuss politics as well as healthcare. And so the politics of transcatheter aortic valve replacements in many centers is that the surgeons, are standby or are not participating actively in the procedure. Now, I don't know about Dr. Kofidi's center and Dr. Cassell's center, but I know obviously Dr. Reardon himself is, spearheading the way for what we can do as cardiac surgeons. But, I think there needs to be greater discussion amongst cardiologists and cardiac surgeons. I would like to hear, if we have just a few seconds from each speaker, how do the politics work at your center? Are all cardiac surgeons performing TAVR? And what do you think we can do globally? Because I think we are the impediment, and the reason some of us are the impediment is because we are left out. I can tell you, I'm certified as an independent operator for, both Sapien and Medtronic. But I think that in this country, and somebody can correct me if I'm wrong, the number of surgeons that are independently certified to place transfemoral valves, you can count them on one hand in a country of 10 million. Dr. Reardon, if you want to start.
Well, so in my place, I'm fortunate. I have 17 cardiovascular operating rooms, 3 of them are hybrid rooms. All the TAVRs are posted in my room in my name, which is a little bit of an anomaly. But I got into this very early, and I'm just an old guy, so I get to control a lot of stuff. I have one surgeon that does this with me. We're recruiting another one. Our surgeons are deeply involved. If my cardiologists are tied up doing a STEMI, we'll essentially get everything ready, cross the valve, say, come on down there real quick while we implant, and then you can go back and finish your STEMI. But that's not the norm. It just happens to be something that we developed at our place. I'm fortunate that I've worked with the same cardiologist for 35 years, who actually is generally shoving people towards surgery more often because we've worked together for a long time, and he trusts the results that we get. You know, TAVI's made us better. We do a lot of, 40% of my patients get an annular enlargement with a Y annuloplasty. I'll never let a woman leave with less than 23 or a man leave with less than 25. So when they do come back for TAVR, they're going to be a better setup for you guys. So I think it depends on how you get it set up, but even in the US, I'd say that 10% of the sites have surgeons who are deeply involved. I have a surgical and a cardiology structural fellow that work with us every year, and I won't let either one of them do TAVI until they can sit down and show me that they can do the 3-Mentio, pick a valve, and why they're going to pick the valve. Because just implanting the valve doesn't make you a TAVR surgeon, that the valve's easy to implant. Understanding how you do it and doing the workup is what I think is important. And surgeons need to understand that if they want to do this, they need to learn enough that they can stand with their cardiologist and have an intelligent discussion about this, not just walk in and hope to implant a valve.
Position here, I'm a bit in a sandwich position in between two surgeons, so I think what I can tell you best. So my experience is I worked long in Munich until 4 years ago, and in Munich we had two separate teams, a surgical team and a cardiology team, working side by side with respect. It worked. We had a high volume. And more or less it's the same in Zurich also at the moment. So who should do the case? Who can do it best? And who is best educated in this? And Transcatheter is, I think, it's a domain of cardiologist education. We start with, when you do interventional cardiology, you do coronaries, you know, you have a lot of skills with different materials and wires. Yes, it is easy to do a simple TAVR for everybody, but it becomes difficult when the procedure is not this easy anymore. And then perhaps we have, because of our education, more skills. But there are some surgeons that could do it good, and why not? The best who has a good education for this, the knowledge, why not? But he has to invest in this. I don't need a surgeon to do a TAVR. And the complication rate now is very low, very, very low. A lot of things are predictable. Most is predictable. Most complications are predicted by CT and also by discussion beforehand. The role of good surgery, in my opinion, is the way on my left side prefer. It's focusing on really minimal invasive surgery in the future, because for this I need a surgeon.
Professor Kofidis, and we have to move on. Okay. Please.
Quick one. I'm very privileged to sit here with my esteemed colleagues, which seem to be an alumni session here. Did my internship with Denton Cooley 25 years ago and a sabbatical in Zurich. But anyway, so as a surgeon who is certified in both as well, Greg, I think you have raised a very important political debate, and it's indeed a political issue that no doubt TAVR is producing excellent results, but it's a bit of a balance between strong surgeon, strong cardiologists, and how the balance shifts with each and every clinic. The way that platform works, of course, varies from place to place. In our place, in Singapore, it's shared. The decision-making is more on the cardiology side, I must confess, but we have surgeons embedded who are doing TAVR procedures. To put it, however, in a global perspective, the TAVR for aortic valve, which is a much easier valve to implant compared to transfemoral transcatheter mitral valves, is there since 2001, Alain Cribier. The adoption in Europe is big, in the United States growing, over 30%, Germany 45% and growing. In the rest of the world, however, it's a small percentage, one must confess, because you need trained team, you need a special equipment and resources like a hybrid theater and so on. And for the mitral valve is even a longer process, but the procedures are here to stay and grow.
So it's clear that there is such much interest around these evolving issues and so much well solidified experience during the last 20 years that we could discuss a lot. Unfortunately, again, is the time. So I would like to thank you. I'm sure that during the day we will have the opportunity to discuss again special issues around these evolving techniques and technologies. And now we have to start discussing two important cases, case 1 and case 2. I will pass the microphone to my co-chairpersons, Professor Patrakos and Professor Alexopoulos, but I would like to remind you that we have for both these cases 45 minutes, which means about 20 minutes each, correct? So the first is case 1 is for you, sir, or for, what do you prefer? You to start? Okay, yes. Great. And then...
Κώστας Σταθογιάννης θα παρουσιάσει το πρώτο περιστατικό, the first case, as discussed with the President, Kostas Spargias, would be 5 minutes presentation and 15 minutes the video presentation. We'll try to catch up a little bit with time because a little bit late, but looks like we're going to be okay. Ο κύριος Σταθογιάννης.
Thank you very much, Chairman. From this year on, so thank you very much. From this year on, we're starting a different kind of format to present our cases. So we start with a patient presentation, and we're going to have some specialists from the imaging sector and interventionalists to discuss the case with us. And then we will present the case as to what we planned and what we did. So it's important to know that we like to have interaction, and all you are kindly requested to ask any kind of question you want about the case. So for some reason, sorry about that. Okay, so this is our first patient. She's a 77-year-old female and a BMI of around 27. She's been complaining of shortness of breath and dyspnea on exertion, minimal exertion, and around NIHA 3 heart failure symptoms. And she's been having hospitalizations for orthopnea. And when we first saw her, this was her TT. Basically, we diagnosed a severe aortic stenosis and mild aortic regurgitation, maximal velocity of 4.1, a mean gradient of 41, and an AVA of 0.8. Pertinent history, she had bilateral hip replacement, osteoarthritis, depression, and anemia. And we've just put down the Euroscore and the STS score for the heart team meeting. Just her initial X-ray. So here's a initial echo image where we have outlined our CW wave. It's, as we said, a maximal velocity of 4.1 and a mean gradient of 41. And this is a live image of a parasternal long axis. You see highly calcified aortic valve and some mild regurgitant jet. And this is a very short zoom parasternal short axis image, very tight opening, calcified, all leaflets are calcified. calcified. Okay, so I can just hand it over now to Dr. Murmuris. He's a cardiac CT imaging specialist, and he can offer us his insight.
Okay, good morning, everyone. This is the oblique axial view of the aortic valve. As you can see here, there's a severe calcification in the aortic valve. And also there is severe calcification in the STJ. No calcification in the subvalvular area. The Agatston score was 2,274. You can see here the amount of the calcification in the aortic valve and the calcification in STJ. This is the measurements. The area is 466. Perimeter is 78 millimeters. The distance of the coronary origin from the annulus is more than 1 centimeter, and sinus heights are more than 50 millimeters. And you can see here okay. You can see here calcium on STJ. This is VRT image of the peripheral vessels. You can see that we have a moderate calcification in this infrarenal aorta and in the common iliac arteries. And you can see here the axial views of the vessel. You can see that we have circumferential calcification in this infrarenal aorta and eccentric calcification in right iliac artery and also in the left iliac artery. The minimum diameter was more than 77 millimeter. That's it. So this is the coronary. I think someone else have to talk about the coronary angiogram.
Thank you very much, Dr. Murmuris. I think Dr. Latsios is online.
Yes, hi. Hi, hello. Can you hear me? Hello.
Yes, oh, hi. Yes, we can hear you and we can see you, Dr.
Okay, okay, I'll be brief because I've had very interesting talks. First of all, thanks Kostas Parias, Stratis Patakos and Kostas Athangianis for the invite. And second, my warmest congratulations for picking a national art gallery because medicine and especially TAVI is a form of art and I couldn't find a better place to present art than in an art gallery. Very, very brief, I will share with you the questions we all have when we start a TAVI case. It's a standard, more or less standard case. Middle-old lady with severe aortic stenosis, pulmonary hypertension, and some comorbidities. Questions. First question, should we refer to Stratis Patakos or Greg Patakos? I'm sure they've done hundreds of cases successfully. Or should we do TAVI? Based on Greek, based on the STS score that predicts mortality, but most of all based on our Greek data, we have better results with TAVI. All of Greece is 2.4, and especially in our center it's 1% mortality, which is better than the estimate. And let alone the guidelines that says even if it's above 75, we should go ahead with TAVI. So, problem solved. Second problem, my wife is an anesthetist. Should we intubate the patient as we used to do, or should we have her awake? Same results, and we have data to prove that. So conscious sedation is better for the patient, is equally safe as we've done during the last 10 years, as we've published, as we've shared our experience. Third, should we have surgeons on board? Should we have surgeons in-house? Yes, we should, but not to deal with the complications. The complications are being dealt by us, and this is historical data, 1 in 100 needed surgery. That's not the case anymore. A, because when they fail TAVI and they go emergency surgery, 50 to 70% die. And second, because some of the companies helped us by reposition of valves, and because most of the cases that needed urgent surgery were due to valve misplacement, if you take out the valve and replace it correctly, you solve the problem. So keep calm and reposition with some of the cases. Third, as said, in the guidelines in the 2023, when we say TAVI, we mean transfemoral TAVI. This is a perfect case with transfemoral TAVI, a little bit of calcium with good diameters, no tortuosity, no nothing. We should cut down the legs. The surgeons, we think it's better. It is not better. The surgeons, the vascular surgeons say it is not better. It's equally safe. Also from the trials, almost 100% are being done by us, and also some data by Greece, Kostas took part in it, that say we have equally good results when we use toys. How do we puncture? There's this thing, let's use echo. Okay, it's a great idea, and it started with some promising results. The results were promising after we've learned how to do it, but then when we've increased numbers, and in statistics, as you increase your numbers, you approach the truth, there are no significance. So what you do what you do best. You do what you know. How do you close? We close with whichever way you think you know. So either vascular plugs or vascular sutures, they're equally best, but please do again, learn how to use them. You know how to use your toes in order to be successful, to be complication-free. Please do not forget that almost 1/3 of the major vascular complications come from this small 6 French femoral sheath. Some say put a 7 French sheath and put a crossover wire. That causes complications. If you do a transradial second access, you reduce by half your complications, your vascular complications. That's interesting and important in a 77-year-old lady. What are you going to do after your TAVI? If you have some contraindication on some GI problems, you can, and you have to think about it. You can go to single therapy with antiplatelet, just clopidogrel or just NOC, and be equally safe. Regarding the wires, most of the cases we use a very, very stiff Lunderquist wire, and also there is data that if you use a Lunderquist wire, you are able to put your stroke. Unfortunately, we don't have data to say that we have to use stroke embolic protection in all patients, so I would not use embolic protection in all patients. What about valvuloplasty? Also, there are data from Kostas Toutouza's multi-center trial and myself that say you can avoid, but this is this formula, this algorithm that says in this case you could avoid valvuloplasty, but if you just check again, and this is the CT kindly sent to me to analyze, if you see where the calcium is, I would go for a pre-TAVI valvuloplasty to optimize my post-TAVI result. And please do not forget, we get better, and I'm sure I'll see that in the live case, better result if you plant the valve in a more modern projection plane in a cusp overlap view. We can really estimate, assess where your implantation depth is, and there are results to prove that. And also with balloon expandable valves, there are results to prove that if you go in another plane, I think everybody nowadays uses that, you go for same results. So good luck, Kostas Parias and the team, with TAVI, with predilation, transfemoral, with whatever suture device you want to pick, no protection device, with a small wire in an NCC in a correct plane. Thank you a lot.
So the next commentator is Dr. Spagis.
Good morning for me. Thank you for all being here. And we now start the video of the case. So if we can turn the lights a little down to make the room darker, and start slowly to make comments. Everybody is welcome to ask questions. This is the procedure. It's of course edited, so the whole video lasts about 10 minutes. We're not going to stop it, and you see all the procedure from beginning to the end. So all these cases we're going to show today and tomorrow are not selected. It's just cases that we did on 4 consecutive days in our daily practice. That's why some of them will probably appear to be boring, but I think you'll learn even from boring cases. So as you notice, we use a combination of ultrasound guided, but also angiography for the puncture, and then two proglides that you've noticed earlier. And this is an E6 14 French that we advanced, and you probably now guessed
Recording in progress.
What valve we're going to use. Although sometimes we use the E6 and then we can go with an Evolut or a Navitor valve through the E6. So it's not exclusively for sapien, but of course it's in the box of a sapien. So this is the simultaneous recording of this patient. So you can see an invasive gradient which is certainly less than the echo gradient, typical. Usually the invasive gradient is 20 to 30 millimeters lower than the echo gradient. And you see here is the pacemaker, the pacemaker lead, the temporary in the right ventricle. This was the valvuloplasty. This is the valvuloplasty with a 20 millimeter balloon, the Edwards balloon. And we always do the simultaneous aortography. And this helps us to find where the leaflets go and what spaces are left in the sinuses, how the corneostea appear and the distance from the leaflets. So we use this in almost all cases, pre-dilatation, and sometimes it's helpful for the sizing. So what you can see here, as Marcus has published in the past, is the distance from the balloon to the LVOT, so you can see large gaps on either side of the valve of the balloon. So certainly 20 millimeter, which is the diameter of this balloon, will be small and will get a lot of regurgitation, PVL. So that's why we go with CT scanning measurements that suggest a 26 millimeter valve, a balloon expandable valve. The wire we use is Safari, extra small in most cases. And the positioning of the pigtail is in the non-coronary sinus, but for this kind of valve, this is not crucial. So it can be in other places too, as long as you can visualize the aortic root. You've just seen the alignment that we do of the valve on the balloon. So we pull back the balloon to position the valve in the center of the balloon before advancing the entire system around the apex. It is flexible, so we always try to avoid to touch the aortic arch wall by flexing and by also pulling back the wire. So in most of the cases, we avoid to come in contact with the aortic wall in the aortic arch. And this is the positioning. So this valve, as you probably know, is foreshortening from below to above. So although it appears to be almost 50-50 at the annulus now, just notice here how the lower part, when the balloon inflates, moves upwards. So this is because of the design of the cells of the scaffolding of the stent. So you have more cells, more lines of cells below. That's why you get more foreshortening from there. And as you've seen, the positioning was like 90% above the annulus and 10% below the annulus. This is now what we see. The initial volume of the balloon was minus enough because we had the calcium, if you notice, in the mitral valve leaflet, in the anterior mitral valve leaflet of the sinus. So we were very careful not to overexpand that area, although that is the most expandable area of the annulus of the aortic valve. And so we did the post-dilatation here with more volume inside the balloon. So the final result, I guess, is this, with very minor regurgitation, probably through the wire. We'll see what happens when we remove the wire. Actually, you can see above that the color is from within the valve that you see of the regurgitation. And then you see the hemodynamics, the diastolic pressure, which is almost 60. So this is the assessment we always do. We rely on hemodynamics, we rely on aortography, angiography, and also on echo. If we're happy with two of these criteria, then we are happy with the case. And so this is the final result, is about 20% of the valve below the annulus and 80% above. So actually that was the result before the post-dilatation with more volume in the balloon. So we advance again the balloon there. We're using the flex again to avoid touching the wall. So this is with the extra volume. And if I remember well, Kostas, the final ballooning was with -2 ml of contrast. So the initial was -3 and the final one was -2. Remember, for this valve we go with area, and the area was 460. And the 26 millimeter ultra valve, this is Sapien Ultra, has an area of 530 approximately. So we had this margin not to inflate it 100% because the area was smaller. So this is actually the final result. Forgive me for saying earlier that that was the final result. And here you can see 0 paravalvular or intervalvular regurgitation. And this is the final result in the, after the closure of the 2 proglides of the right common femoral artery. So has anybody noticed something that he does differently? Would you do something differently in this case? I guess Dr. Latsios said that he would probably use a Medtronic and Evolut valve. George, are you here with us?
Yes, I'm here. First of all, it's a tremendously good result. Second, I tried very hard not to take parts on which valve I would use. I just said would be the pitfalls in every valve you'd use. So it's a great result, and it's a great topic which valve to use in each patient. So there are pros and cons in each case.
I missed the hemodynamics at the end, Kostas. You remember the hemodynamics at the end? Because the comment of Dr. Reardon about the aortic valve area is well noted and respected, so we want to achieve the maximum effective orifice, and that was a large valve, 26 millimeters, for this relatively small-sized lady.
I think when you have a woman, the 26 is plenty big for a woman. Either valve will be okay. The one thing I worry about is I worry about underexpanding my balloon expandable valves. I would rather overexpand than underexpand a balloon expander because they don't fully come out and they do pinwheel a little bit, and there's some growing data that if they don't circularize, there's an increased risk of halt. So you have to worry about the STJ, but I do get a little nervous when it's underexpanded by 2 cc's. But the result turned out just great, and I would have been happy with I do about 30-70 balloon and self-expanding, but a 26 for a woman's great. For a small woman, a 23 is okay. I never use a 20. The area of a 20 is 1.22. Becky Hahn showed us that. And then for a man, 26 or 29 works out fine. I think you made a good choice. Either one would be absolutely fine with this lady.
I completely agree about the undersizing of the balloon expandable valve. I think it has to do with the size. If you just take 2 ml volume out of a 29 millimeter valve or a 26 millimeter valve, I don't think it has a great impact. But if you take 2 ml out of a 23 millimeter valve, or even more of a 20 millimeter valve, because the total volume, I think, in the 20 millimeter sapien valve is 11 ml. So if you take 2 mLs out, you take like 20% out of the volume of the balloon. We have another question.
Yeah.
Yes, please go ahead.
Dr. Spergas, congratulations for this case. The annular oversizing is also another problem, especially for the balloon expandable valves. If you do much oversize, it means this result annular rupture. This is the most important complication of the balloon expandable valves, as you know. Some new valves are changing the game, as you know. There is a new valve, MyVol valve, which have intermediate size. So, for example, for this lady, the area was calculated as 460. And in that case, for example, you can prefer 24.5 valve. So this is an important issue when you look at the published trials of the MyVol also. 40% of the cases were done by intermediate cases. So this is another option, maybe re-examination of the current balloon expandable valves. This is my opinion. Thank you very much.
Thank you for this comment. And now for valve-in-valve, because this lady is in the 70s, I think if you see how we finished, it will be possible to go and do valve-in-valve in this valve in the future. Hopefully she will survive long enough to need it. And you may, if we can go slightly back on the video, we may have to protect the left main with the wire here, right? A little back to see the orthography. Because the valve reaches at the STJ, but there is some space there to advance a wire and a stent to protect if she needs in the future and valve-in-valve procedure. So I think we should stop here. Oh, here, yes, you can see it here. And proceed with the next case. So I would like to invite the commentators, the imaging and the procedure commentators here with us. And Dr. Katsianos, our colleague, will start presenting the case. So Dr. Murmuris and Dr. Triadafilou, please.
Yes, good morning, dear colleagues. I'm very happy to present the next patient. I'm waiting for the first slide. Our patient is a 70-year-old male with a BMI of 39.8, refers severe dyspnea in the last 6 months, and has been O2 dependent in the last 2 years. NIHA stadium 4. Last month, he has frequent hospitalizations for dyspnea. In the transthoracic echo, has a severe aortic stenosis and a mild AR, Vmax 4.85. We see a high gradient, peak and mean gradient, AVF 0.7. The good LV ejection fraction and RVSP 66 millimeter of mercury. The coronary angiography, no atheroma. And the medical history has a chronic atrial fibrillation, COAD, has a morbid obesity, and also hemoptysis requiring coil embolism, a prostate hypertrophy, and he's a smoker. Euroscore 2, 3.35%, STS mortality score 2.35%, and morbidity and mortality score 14.6%. You see the X-ray of the patient, the transthoracic echo. We see the high gradient of the patient. And I pass Dr. Murmuris for the imaging commentation.
Okay, this is the axial view of as you can see here, it's a bicuspid valve with calcified rough. The rough is between right and non-coronary sinus. Small amount of calcification on STJ, and there is mild calcification below the annulus. Calcium score was 3,764. This is the distribution of the calcium, and this is the measurements. So in the annulus, the area was 534, and perimeter was 83 millimeters. Mean diameter was 26 millimeter. This is the diameter, 4 millimeters above annulus is 27 millimeter. The distance of the coronaries from the annulus is larger than 10 millimeter. And also the sinus height is more than 50 millimeters. This is the VRT of the peripheral vessels. You can see there is a moderate degree of calcification in the suprarenal aorta. And here is the axial images of the vessels. You can see we have eccentric calcification in the suprarenal aorta and circumferential calcification in common iliac artery, but the minimum diameter is more than 7 millimeter. Okay.
Good morning. I have some slides. I don't know if I can go to the podium to show them off, or if, okay. I would like to start by thanking the heart team of Aegeia Hospital for the invitation, Dr. Sparias and Dr. Patakos. I will try to be fast. Okay. Thank you. Thank you. It's a patient who is morbidly obese, and he has a severe COPD. So the first thing that I would do with this patient is to do a correct informed consent process. I should tell the family and the patient that what is expected is less than what is expected for patients that are not morbidly obese and with severe COPD. And he is also oxygen dependent and with pulmonary hypertension. These are factors that may limit the best outcome after a TAVI. Obviously, he is not a surgical candidate because of his severe COPD. We must have in mind that the kind of pulmonary hypertension plays a role. Patients who have post-capillary pulmonary hypertension fare as well as patients who do not have pulmonary hypertension after TAVI. But patients who do not, who have mixed or pre-capillary pulmonary hypertension have not as good outcomes after even a successful TAVI. And patients with COPD, we must have in mind that have less functional improvement after TAVI than patients who do not have this condition. And there is also a cut-off point of functional status, a 6-minute walk distance less than 170 meters that may show that the patient does not have much to gain even after a successful TAVI. And there are patients who have events for non-cardiac reasons after the procedure. So he has some points of concern regarding a good outcome, but his best option is TAVI. So for this kind of patient who is relatively young with a bicuspid, quite calcified valve, we should try to have the optimal result, avoid paravalvular leak, avoid pacemaker, have the option of future coronary access if hopefully everything goes okay and lives a long life, and have in mind valve durability. We should also think even for the possibility of the necessity of a valve-in-valve in the future. And to conclude, I would approach this patient in our center with this strategy. I would search for informed consent after an exhaustive discussion about risk and expected benefit in detail. Conscious sedation should be the way to go. An echo-guided puncture should be very, very, very meticulous. I would choose the right common femoral. As I saw, there is no problem with the axis, the iliofemoral axis, provided that you have a good puncture. Special focus regarding the puncture would be about depth, angle, tunnel preparation, and I would use 2 proglides. As secondary axis, to avoid any possible complications from the secondary axis, I would choose the right radial artery for the pigtail. I would have a femoral vein ready in order to, and a temporary pacemaker to have a stable pacing in order to predilate the valve. I would use a safari small wire and predilate with a 22 or 24 millimeter balloon. And for this case, who has a circular annulus of 26 millimeter, and I would like a fast implantation, I would select more, probably an S3 26 millimeter valve than an Evolut R. The perimeter I show is at the gray zone under between 29 and 34, but I would like a faster implantation for this kind of patient, so I would rather select an S3. And I should have a special attention at the closure point and have a bailout strategy in case the proglides do not work well with a peripheral balloon ready. I thank you.
Thank you, Dr. Zirafili. So I think this is a patient, we can start the video. This is a patient that the main problem, he's young, he's 70, so retreatability here will be important, although he has morbid obesity and COED, mainly restrictive type of COED. So that was the reason we decided to go ahead with TAVI. And certainly the access in these obese patients sometimes is very difficult, so it's very important to be successful. So you see the combination again of echo-guided and angiography-guided access in this patient on the right side. And we always check with a small injection to see where exactly we enter. The proglides now. The anatomy of this patient's valve is bicuspid, functional bicuspid, with fused non-coronary and right coronary leaflets. And there is calcium in the raphe. I would say moderate calcium. It's not extreme calcium, but it's not mild calcium in the raphe. You remember the Agerson score was quite high. And as Costa said earlier, if you choose a self-expanding valve with a perimeter of 82 or 83, you're between sizing 29 or 34. And in these cases, usually when we have bicuspid anatomy, we go for the smaller size. So if it was an evolute, it would be a 29 millimeter more than likely. And if it is sapient, then it will almost certainly be a 26 millimeter valve. So you can see the hemodynamics of the patient, about 120 blood pressure, systolic blood pressure. And again, you see an ECIF, 14 friends coming up, Nablat's extra stiff wire. This is the wire we use to have the stiffness to advance these large bore sheaths. And then we always put a suture on these large sheaths because if they're inadvertently moved, we may have a serious injury in the aorta. And this is the crossing, which was quite easy. Sometimes in this type of bicuspid anatomy, crossing the valve becomes challenging. And you can see the gradient, the hemodynamic gradient there that was big, so similar to the echo gradient in this case. And here you see again Safari extra small wire, the pre-dilatation. What size was that balloon? 23? 23 balloon with simultaneous autography. You saw that the valve was open, but the balloon at the end moved up, but certainly did pre-dilatation. And here is a 26 millimeter valve getting ready, crimped. Now the valve is up, and here you'll see again the alignment, pulling back the balloon over the valve. And then we're ready. It's an ultra 26 millimeter sapien valve. We cross the arch with very carefully and slowly using flex and pulling back the wire to avoid touching the walls of the aorta, the aortic arch, especially when we have calcium there, but essentially in all cases. So you see how by pulling the wire back and flexing, we move away from the aorta wall. I don't know if this has any effect in reducing strokes, but theoretically it might. So calcium is very visible there. Crossing there. And then getting the pusher back. So we have the balloon free to inflate. The injection to see the positioning. The positioning in bicuspid valves is interesting because you always have to go higher than the annulus, what we expect the annulus to be, because the tending of the leaflets, they take you higher. So if you go to position at the annulus, you may end up to go into the ventricle. So here is the inflation. You see the foreshortening from the lower side. Removing the system. And this is the result with 0 paravalvular leak with this valve. apparently we were minus some volume. That's why we decided to go to nominal and do a post-dilatation. So you saw how the frame of the valve expanded a little bit more, and the result is excellent, again, as it was before. And you can see that treatability won't be a problem because there is distance from the coronary ostia to the valve, and also you had a chance to see the hemodynamics. We had no gradient and very good separation of the diastolic pressures of the ventricle and the aorta. And so that was the result in this bicuspid valve with enough calcium. And here is the closing of the proglides, removing of everything. So I guess we follow your advice for a quick implantation, and we decided to go for a sapient valve, which is just a second to a few seconds inflation, predictable positioning, attaining a circular frame always, even in bicuspid cases like this, and also having this great result. Can we go a bit forward to see the final result in the leg in this obese patient? Can we move forward the video, please? Okay, let's take this opportunity to have a discussion. Professor Killis, do you have any comment on this case? Microphone, please.
Congratulations about these patients, especially bicuspid aorta. It is very important for bicuspid aorta patients before the procedure. The multi-slide CT evaluation is very, very important. And there are new measurements, as you know, like the compared to the conventional measurements, supraannular measurements and rapid length and Casper algorithm and Bowert algorithms like you use in the supraannular measurements in this patient. But I get a little bit concerned when you, for example, again select 26 millimeter valve for this area when we look at the conventional measurements. And any other advantage of the new valve may be to use 27, for example, any intermediate size for a balloon expandable valve. And as we know, also usage of a supraannular valve, the evolutor in bicuspid patients also another option because it's a retrievable, recapturable when you don't like the position. But another comment that, for example, I saw some posterior calcification in the common femoral arteries, and this is another problem for the proglide rupture. So I would prefer, for example, a safety guide wire in the common femoral artery. But the result was excellent, and congratulations.
Right. Professor Hughes.
One thing I would say about this guy, if he doesn't have coronary disease now, you don't need to worry about him getting coronary disease. This guy's not going to live 10 years. I mean, he's morbidly obese. He's got functional class 4, a marker for morbidity. He's got pulmonary hypertension, a marker for mortality. He's got atrial fibrillation, a marker for mortality. If this guy lives 10 years, he's going to be lucky. And so the chance of this valve wearing out in his lifetime or getting coronary disease, if he doesn't have it now or is minuscule, you should pick whatever valve you want to use. I think you did a great job. The only other thing I'll point out as a surgeon is there's no such thing as a functional bicuspid valve. We made that up to try to get people into the high-risk trials that had symmetric bicuspids. Either you have a congenital bicuspid or you don't have a congenital bicuspid. Functional bicuspid is something we made up. If you look at the high-risk trials, probably 10% of both of them were functional bicuspids because we just wanted to get them in the trial.
Dr. Cassel, you have any comment on this case?
No, it's a nice case. I would use also SAPIEN. I have long experience in treatment of bicuspid valves in SAPIEN. Here in this case, RAFE in between non and right cusp. Sometimes it's a bit a problem because the valve is pushed to the left side. You have to take care of the left main. On the other side, very nice, and the most common RAFE type is left and right RAFE type, and this is very preventive for coronary occlusion. So bicuspid valves are not always bad for transcatheter treatment. And yeah, so my experience more is SAPIEN. Congratulations, good case. I would do the same. I do also in every bicuspid valve a pre-dilatation with a balloon. I do balloon sizing to understand in which direction the balloon shifts, and then it's the same the valve does. I can predict a bit better how to deploy, and so, but no other comments. We use one ProGlide. Try it.
Right.
So one other comment I will make about this is that with these bicuspids, I would always roll over RAO and take an RAO look and make sure your valve's not pancaked. Sometimes in your LAO view they look great, and you go over an RAO, they're pancaked, and if you see that, I would post-dilate those, particularly with a self-expanding valve. I mean, we did the low-risk bicuspid trial, and the results from bicuspid valves were actually every bit as good as the tricuspid valves. We've become very aggressive in treating bicuspid valves. Yoon and Makar have shown us the anatomy that we can't treat well. Those that have a heavily calcified RAFE and heavily calcified opposite leaflet and subvalvular calcium, those will give us trouble. But most of these, we've become very aggressive in treating these and find that we get, you know, really excellent results. And just like this is a really nice case.
Okay, great. So it's true that this morning we had the opportunity to enjoy 3 marvelous talks plus 2 important cases. This is a very nice opportunity now to have the opening addresses. I would like to thank the speakers, every one of you. Okay, great, thank you very much. And now I would like to invite here to sit with us the Chairman and CEO of the whole hospital's Hygiea group, Professor Mr. Kartapanis, please.
So we welcome you all in this meeting. This is the 11th consecutive year that we are blessed to organize this meeting. And we started in 2011. That was a long time ago. It was the first such meeting in Greece. We're very happy to see the development, education in this field, and how all these treatments are expanding and penetrating for the better of our patients' treatment. As you notice, this year's program is a little different from other years because almost every session is built around cases. So sometimes to have continuous lectures becomes a little dry. So we have in each session 1 or 2 videoed cases, live in the box cases, and with this new format of presentation. And as I said earlier, we haven't chosen these cases. They were just our regular, everyday volume of cases that we're doing in our lab. We just had the recording equipment and the people with us on 4 days of our work, and these are the cases you're going to see today. So, having said that, I'd like to invite now the co-president of the meeting, Dr. Patakos, for his greeting.
Thank you very much, Dr. Spargias. Mr. Kartapanis, Professor Vardas, dear esteemed colleagues, especially professors that you came across the world to join us here this morning. Unfortunately, the COVID virus emptied a little bit our environment, but increased at the other time the screen participants, people, colleagues that are watching us from everywhere. It's a very interesting meeting. It's a very interesting Congress, and we're looking forward to increase that in capacity and in every aspect. As I look at this conference, as I look at these developments, it's obvious here, especially in Greece, that this effort needs support. And the support is not only with congresses and scientists. The evolving techniques need also economic support. And it's about time the country, the governments everywhere in the world, and especially in us that we have more problems, to try to assist in a little bit more in terms of that each and every technique that is developing requires more economic support. Otherwise, the patients are happy, the physicians that participate in learning every day are happy, and it looks like it's a very promising area. The good thing also is that these techniques, they brought us together, the cardiac surgery and the cardiology. We used to have different approaches and different opinions. These days, the hybrid room that in Ygea Hospital we have the opportunity to have it as a main operating room is the room that brings us together in technology, in opinions, in cooperation. So the cooperation of cardiac surgery and cardiology is more evident in these kind of cases, and we really are very, very optimistic about the future. So I would like to thank everybody, the support of Mr. Kartapanis, who is the CEO and supports all those efforts, the esteemed colleagues and professors, and looking forward for the continuous progress and support of this event. Thank you very much.
Ευχαριστούμε πολύ. Και τώρα παρακαλώ θα μας απευθύνει χαιρετισμό διαδικτυακά ο κύριος Σιούφης Κωνσταντίνος, καθηγητής καρδιολογίας στο Πανεπιστήμιο Αθηνών. Να πάμε παρακάτω. Παρακαλώ, κύριος Κανακάκης Ιωάννης, τέος πρόεδρος της Ελληνικής Καρδιολογικής Εταιρείας και διευθυντής στο Γενικό Νοσοκομείο Αλεξάνδρας. Παρακαλώ να μας απευθύνει χαιρετισμό. Ευχαριστώ πολύ.
Ευχαριστώ πολύ για την πρόσκληση. Εκ μέρους του Προέδρου και του Διοικητικού Συμβουλίου της Ελληνικής Καρδιολογικής Εταιρείας, χαιρετίζουμε τις εργασίες του συνεδρίου Transcatheter Heart Valves 2023 και ευχόμαστε καλή επιτυχία στις εργασίες του. Το συνέδριο αυτό βρίσκεται ανάμεσα στα κορυφαία συνέδρια όχι μόνο στον ελλαδικό χώρο αλλά και διεθνώς και έχει συμβάλει στην εκπαίδευση της καρδιολογικής κοινότητας στο συνεχώς εξελισσόμενο τοπίο και πεδίο των βαλιοπαθειών και δομικών καρδιοπαθειών. Κοσμούν με την παρουσία τους διεθνείς προσωπικότητες με πρωτοποριακό κλινικό και ερευνητικό έργο στο πεδίο της επεμβατικής καρδιολογίας. Συγχρόνως εκπροσωπούνται τα περισσότερα επεμβατικά κέντρα στον τομέα των βαλβιδοπαθειών και η καρδιολογική κοινότητα στηρίζει αυτή την προσπάθεια και συμμετέχει στις νέες τεχνικές και είναι αρρωγός σε αυτή την προσπάθεια των διαδερμικών επεμβάσεων στις βαλβίδες. Οι ανάγκες στη χώρα μας, σε αυτό το επεμβατικό τοπίο, είναι συνεχώς αυξανόμενες και οι υπηρεσίες υγείας θα πρέπει να ανταποκριθούν σε αυτές τις αυξανόμενες ανάγκες χωρίς καθυστερήσεις, ιδιαίτερα στον τομέα των επεμβατικών κέντρων στα δημόσια νοσοκομεία. Σε αυτό το θέμα η ΕΚΕ με το θεσμικό τους ρόλο θα συμβάλλει σημαντικά. Το κεντρικό άξονας είναι το κόστος, αλλά με την αυξανόμενη χρήση αυτών των επεμβάσεων και τους κεντρικούς διαγωνισμούς που δρομολογούνται, πιστεύω ότι θα έχουμε χαμηλότερο κόστος σε αυτές τις επεμβάσεις και θα λυθεί ένα μεγάλο πρόβλημα καθυστερήσεων. Η χώρα μας είχε μια αυξανόμενη χρήση των διαδερμικών επεμβάσεων. Αν πάρουμε τον τομέα της ΤΑΒΗ, ξεκίνησε με 250 επεμβάσεις το χρόνο και το Σεπτέμβριο του 2022 είχαμε φτάσει σε 875 επεμβάσεις ΤΑΒΗ στη χώρα μας. Πιστεύω ότι θα ξεπεράσουμε τις 1000. Όμως, αν συμπεριλάβουμε τους ασθενείς χαμηλού κινδύνου, οι ανάγκες για διαδρομικές επεμβάσεις ΤΑΒΗ στη χώρα μας φτάνουν στις 4.000. Καταλαβαίνετε λοιπόν ότι υπάρχει αδύρυτος ανάγκη να προχωρήσουμε σε μια διευκόλυνση αυτής της προσπάθειας Και σε αυτό θα συμβάλλει και η Ελληνική Καρδιολογική Εταιρεία και οι επεμβατικοί καρδιολόγοι σε μια συνεννόηση με το Υπουργείο Υγείας. Με αυτές τις σκέψεις θα ήθελα ξανά να συγχαρώ την Οργανωτική Επιτροπή, τον κύριο Σπάρια που βρίσκεται στην πρωτοπορία αυτών των επεμβάσεων, τον κύριο Πατακό, όλη την Οργανωτική Επιτροπή, τον κύριο Βάρδα, και να συγχαρώ τους διοργανωτές και να ευχηθώ ένα παραγωγικό συνέδριο που θα είναι σίγουρα παραγωγικό και θα μας δώσει νέες γνώσεις. Ευχαριστώ πολύ.
Ευχαριστούμε πολύ, κύριε Κανακάκη. Ο επόμενος, ο κύριος Τσιούφης, τον έχουμε τώρα κοντά μας. Ο κύριος Τσιούφης Κωνσταντίνος, καθηγητής καρδιολογίας στο Πανεπιστήμιο Αθηνών. Καλημέρα σας. Σας ακούμε.
Καλή σας ημέρα. Καλημέρα σε όλους τους εκλεκτούς προσκεκλημένους και συνέδρους. Καταρχάς, θα ήθελα να εκφράσω τις θερμές μου ευχαριστίες στην Οργανωτική Επιτροπή και ιδιαίτερα στον καθηγητή τον κύριο Βάρδα και στην ψυχή του συνεδρίου τον κύριο Σπάρια και τον κύριο Πατακό για την πολύ ευγενική τους πρόσκληση και να ζητήσω την κατανόησή τους που δεν μπορώ να είμαι φυσική παρουσία λόγω ηλυμένης υποχρέωσης σε ένα meeting για τις guidelines που έπρεπε να είμαι στο Μιλάνο εκτός Αθηνών. Δύο λόγια, γιατί πραγματικά ο χρόνος είναι πολύ πολύτιμος. Πρώτον, θερμές ευχαριστίες και πολλά συγχαρητήρια στην ομάδα του κ. Σπάρια και του κ. Πατακού για την τεράστια συνεισφορά του στον τομέα της θεραπείας των δομικών παθήσεων της καρδιάς με όλους τους σύγχρονους τρόπους. Είναι πραγματικά πρωτοποριακή η δουλειά τους και άνοιξαν το δρόμο για να ακολουθήσουν και τα άλλα τα κέντρα. Και το δεύτερο σημείο που θα ήθελα να πω, συγχαρητήρια για το εξαιρετικά ποιοτικό τους πρόγραμμα. Είδα με πολύ προσοχή και τη θεματολογία και τους ομιλητές και πραγματικά τέτοια συνέδρια κοσμούν την εκπαιδευτική δραστηριότητα και πρέπει να είναι παράδειγμα προς μίμηση. Και το τρίτο σημείο που θα ήθελα να επισημάνω είναι ότι τέτοια εκπαιδευτικά γεγονότα δίνουν την ευκαιρία και πρέπει να είναι το έναυσμα για περισσότερη συνεργασία μεταξύ των ακαδημαϊκών Ινστιτούτων, των πανεπιστημίων, των ιδιωτικών κέντρων, σε μια προσπάθεια να προσφέρουμε με την αρρωγή της πολιτείας αυτές τις σημαντικές καινοτόμες θεραπείες σε όλους και περισσότερους ασθενείς που την έχουν ανάγκη και μέσα από τέτοια προγράμματα συνεργασιών, και τα συνέδρια είναι ένα φόρουμ για να προωθηθούν αυτές τις συνεργασίες, μπορούμε να οδηγηθούμε σε καλύτερα αποτελέσματα. Συγχαρητήρια, καλή συνέχεια στο συνέδριο και πάντα επιτυχίες.
Σας ευχαριστούμε πολύ, κύριε Τσιούφη. Και τώρα θα μας απευθύνει χαιρετισμό ο κύριος Βάρδας Παναγιώτης, ομότιμος καθηγητής καρδιολογίας Πανεπιστημίου Κρήτης και εταίος πρόεδρος της Ευρωπαϊκής Καρδιολογικής Εταιρείας.
Καλημέρα σας, κύριε Πρόεδρε του Ομίλου Υγεία, εκλεκτοί συνάδελφοι. Είναι πραγματικά για μένα εύκολο το έργο σήμερα να χαιρετίζω αυτό το συνέδριο που έχει οργανώσει το Τμήμα Δομικών Καρδιοπαθειών του Νοσοκομείου Υγεία και που συμπίπτει με την 20ετία της ιστορίας TAVI, Transcatheter Aortic Valve Implantations, or Replacements. Δύο λόγια μόνο για τον Όμιλο Υγεία, που περιλαμβάνει τα νοσοκομεία ασφαλώς Υγεία, Μητέρα και Λιτό. Από την αρχή, δεκαετίες τώρα, το νοσοκομείο Υγεία έχει φροντίσει να αναδείξει την καινοτομία και την καλή κλινική πράξη ως κεντρικές θεματικές ενότητες της διαδρομής του. Τα τελευταία 5,5 χρόνια μου έκανε την εξαιρετική τιμή ο κύριος Καρταπάνης να ηγηθώ του ομίλου στον τομέα καρδιάς, γνωρίζοντας ότι θα συναντήσω εκλεκτούς συνεργάτες. Τα τελευταία 5 χρόνια έχω την ικανοποίηση να αναγνωρίζω συνεχώς μία εξελικτική, θα έλεγα εκθετική ανάδειξη των δραστηριοτήτων του ομίλου, η καινοτομία, η πρωτοπορία, η καλή κλινική πράξη, αλλά αν θέλετε και το μέγεθος των συντελουμένων πράξεων είναι κάτι το οποίο με ικανοποιεί εξαιρετικά. Ο Όμιλος Υγεία με τους πρωταγωνιστές του, τους γιατρούς, τους τεχνικούς, το νοσηλευτικό προσωπικό, αναδεικνύεται πλέον ως το μεγαλύτερο επιστημονικό ίδρυμα στην Ελλάδα στον τομέα καρδιάς, σε μεγέθη αλλά και σε πρωτοπορία, μετά το Νάσιο Καρδιοχειρουργικό Κέντρο. Τα μεγέθη, όπως σας είπα, είναι εκθετικά και η ποιότητα είναι ουσιαστική. Δεν θα μπω σε λεπτομέρειες. Θέλω να ευχαριστήσω τη διοίκηση, θέλω να ευχαριστήσω τους συντελεστές αυτής της προσπάθειας και κυρίως να σας πω ότι η στρατηγική μας είναι να συνεχίσουμε με αφιέρωση και πείσμα στην ποιότητα και στην καινοτομία. Just in very, very brief, I would like to honor the excellent peers from abroad, saying that it's really my honor and privilege to be the chairperson, the head of the whole heart sector of the Hygeia Hospitals Group. Hygeia Hospitals Group, for your information, includes at least 3 hospitals. 2 of those very well known in the Greek society, but not only in the Greek society, even internationally. Hygeia and Mitera. Just for your information, during the last 5 years, we had the opportunity to support and to continue the tradition of the Hygeia Hospitals Group around quality indicators and innovation. And just for your information, at the moment, Hygeia Hospitals Group, with the number of the procedures run, is ranked second in whole Greece after Onassis Cardiovascular Center, not only in quality indicators, in quality practice, not only in innovation, but also, as I said, focusing on the numbers of the procedures run in all these hospitals. It's really a privilege for me to serve such a marvelous team. I have nothing else to say apart to congratulate Dr. Spargias, Dr. Patakos, and anyone who has contributed not only for the organization of this event today, but also and especially in promoting such innovative techniques like TAVI, like mitral valve procedures and clips, and even tricuspids. So again, thank you very much, Mr. Kartapanis, for this marvelous support. Thank you. Please.
Ευχαριστούμε πολύ, κύριε Βάρδα. Και τώρα θα μας απευθύνει χαιρετισμό ο κύριος Καρταπάνης Ανδρέας, πρόεδρος και διευθύνων σύμβουλος του Νοσοκομείου Υγεία.
Καλημέρα και από μένα. Επιτέλους, μετά από αρκετά χρόνια λόγω της πανδημίας, κάνουμε πάλι ανοιχτή αυτή την εκδήλωση. Νομίζω τα προηγούμενα χρόνια την κάνατε διαδικτυακά, έτσι δεν είναι, κύριε Σπάρια? Ναι. Τώρα είναι και τα δύο μαζί. Εν πάση περιπτώσει, αυτό που ήθελα να πω είναι ότι η εξέλιξη είναι τρομακτική σε αυτό το τομέα, όπως βέβαια και σε όλους τους τομείς της ιατρικής, ραγδαίες και μάλιστα με την επερχόμενη καταιγίδα της τεχνητής νοημοσύνης. Θα δείξει αν είναι καλή ή κακή, θα τα δούμε σε μερικά χρόνια, ίσως οι νεότεροι από εμάς. Σίγουρα οι εξελίξεις θα είναι ακόμα πιο γρήγορες και θα πρέπει να μάθουμε να τις απορροφούμε γρήγορα. Άρα, αυτές οι μερίδες που ανταλλάσσεται απόψεις και εμπειρίες καταξιωμένοι επιστήμονες του χώρου που ασχολούνται με συγκεκριμένα αντικείμενα, τώρα μιλάμε για τις βαλβίδες καρδιάς, είναι όχι μόνο χρήσιμες αλλά και αναγκαίες, γιατί έτσι νομίζω ότι προάγεται και η γνώση με την ανταλλαγή εμπειριών από όλους σας, από προβλήματα που και όχι μόνο προβλήματα, από περιπτώσεις που έχουν αντιμετωπίσει. Νομίζω ότι το φανταζόμασταν, κύριε Σπάρια, πριν από 15 χρόνια όταν ξεκίνησε αυτή η προσπάθεια στο Υγεία. όταν ήρθε και με βρήκε ο κύριος Πάριας και του υποσχέθηκα ότι θα πάμε μαζί και μέχρι τώρα πηγαίνουμε εξαιρετικά μαζί. Φανταζόμασταν ότι θα έχει αυτή την εξέλιξη. Μάλιστα έλεγα στους καρδιοχειρουργούς, προσέξτε, κύριε Πατακία, το θυμάσαι, θα σας πάρουν τη δουλειά. Αλήθεια είναι αυτό δηλαδή, αλλά εν πάση περιπτώσει ο καθένας έχει πάντα το ρόλο του μέσα στην εξέλιξη και ούτε πρέπει να κρυβόμαστε από την εξέλιξη, ούτε να την αγνοούμε, ούτε να την πολεμάμε. Γιατί είναι ένα ποτάμι που είναι τρομακτικά, με τρομακτική δύναμη που δεν γυρίζει πίσω. Χαίρομαι λοιπόν ιδιαίτερα που βρισκόμαστε σήμερα μετά από 15 χρόνια να συζητάμε νέες εξελίξεις. Παρακολουθώ τις εξελίξεις που υπάρχουν και τεχνολογικά στον τομέα αυτό. Είναι ραγδαίες, είναι πολύ μεγάλες, γίνονται πράγματα που πριν όταν ξεκινήσαμε ούτε φανταζόμασταν ότι μπορούσαν να γίνουν. Ήταν ελάχιστα τα είδη που μπορούσαν να εφαρμοστεί αυτή η καινούργια πρακτική και τεχνολογία. Τώρα όμως νομίζω ότι σε λίγα χρόνια θα είναι μια γενικευμένη πρακτική. Να μην κάνω τον πολιτικό μια που είμαστε και πριν τις εκλογές. Φτάνει μέχρι εδώ. Σας εύχομαι καλή επιτυχία και καλή ανταλλαγή απόψεων για ωφέλεια ημών των μη γιατρών. Ευχαριστώ πολύ.
Εδώ τελειώνει το πρώτο μέρος. Εμείς παραδίδουμε τη σκητάλη και προχωρούμε στο επόμενο. Να καλέσουμε τον πρόεδρο, τον κύριο Πιπίλη. Σας ευχαριστούμε.
Hello. Hello, everybody. Good morning. I welcome you to the next session. Together with my co-chair, Professor Vardas, who is from Thessaloniki, and he's watching us, I think.
Yes.
We invite
Hello.
you to, the topic of this session is mitral transdermal edge-to-edge repair, and it's already 15 years of achievement with this technique. The first presentation will be done by Konstantinos Koulogiannis from New Jersey in the States. He's an interventional cardiologist, an investigator in the CLASP trials. We have a pre-recorded video with his presentation, and we thank him very much for his participation.
Good morning, and thank you to the meeting organizers for the invitation. Kalimera σας. My name is Konstantinos Koulogiannis. I'm a cardiologist in Morristown Medical Center in the United States, and I'm excited to be here virtually with you today for this great session. As you know, we've had nearly 15 years of incredible achievements in the mitral transcatheter edge-to-edge repair space. This morning, I will talk to you about the maturation of this technology and review some of the mitral valve anatomies that we are now able to treat. These are my disclosures. From where we stand in 2023, we can look back and see over a decade of impressive achievements in mitral TEER. To quickly review, here are some of the seminal papers that have come out during this time. First and foremost, the Everest II trial results that were first published in 2011 and paved the way for commercial approval of the MitraClip device. Moving ahead to 2018, we saw back-to-back publications of landmark papers in the field of functional mitral regurgitation. The MITRA-FR study results were quickly followed by the COAP study results. These were important trials in the field that really paved the way for our contemporary management of heart failure and functional mitral regurgitation treatment. More recently, in 2022, we saw the publication of the CLASP-2D trial results. This was the first pivotal trial looking at a head-to-head comparison of the new Pascal TEER devices versus commercial MitraClip in the treatment of degenerative mitral regurgitation. By this point, Pascal had already received CE mark. However, these results are what ultimately led to FDA approval of a second type of TEER device in the U.S. for treatment of degenerative mitral regurgitation. Looking from left to right on this figure, we can see the evolution of the MitraClip devices over time. All the way on the left side of the image, we have the first generation classic MitraClip, which was then followed by the introduction of the second generation device that had iterative changes to the grip or drop angle to allow for more efficient leaflet capture. By the time we get to the right side of the image, we have the two third generation devices, which allowed for major improvements in what we do. This was the MitraClip NTR system and the longer clip arm XTR devices. Just of note, as a reminder, all of the historical trials, Everest II, COAP trial, were completed with the early generation devices. This is what the current mitral TEER landscape looks like. We now have two families of commercially approved devices, the fourth generation MitraClips and the two Pascals. Although there are important technical differences between them, they both represent a major development in the field. With both sets of devices, we now have the ability to grasp leaflets independently. This represents a huge technical step forward in the field in terms of allowing us to treat a much broader range of challenging mitral valve anatomies. Just to briefly highlight, on the left we have the four MitraClips. We have the NT and the wider NTW, along with the longer arm XT and its wider counterpart, the XTW. This gives us a nice range of devices to choose from to kind of tailor our approach to treatment. And there have been expert consensus recommendations developed to help guide us. To the right, we have the newer Pascal and the Pascal ACE TEER devices that have been approved both in the EU and North America at this point. Pascal is the wider of the two, and the ACE is the thinner device. There are some technological differentiators from MitraClip. There's a central spacer, and just also of note, these devices have a single row of gripper elements at the top compared to the 4 or 6 rows that the MitraClips have. Just irrespective of these differences, though, these are both a major advance in the field. They allow us to capture leaflets independently, and really we can now treat safely and effectively more types of disease. So, what types of mitral valve anatomy can we now treat? The classic MitraClip label recommended tier for A2P2 pathology, mitral valve area of 4 or more centimeters squared, little calcium in the grasping region, and adequate leaflet lengths. This type of straightforward anatomy is what we call as a green zone in terms of tier complexity. However, as technology has continued to improve and as operator experience has also increased, we're now better able to safely and effectively treat more complex anatomy. This includes patients with non-A2P2 pathology, commissural disease, multiple jets, smaller valve areas, and shorter leaflet lengths. I've been fortunate to be part of the Heart Valve Collaboratory Group, where we've outlined some of the consensus criteria to better describe tier complexity and suitability. We've now spoken about our ability to successfully treat increased mitral disease complexity with newer tier devices. Here are some real-world data that were recently published and presented. The MitraClip Expand and Expand G4 are two large mitral tier registries. In both sets of groups, we see excellent MR reduction to 1+ or less. Of note, 30-day data from Expand G4, which utilizes the most recent family of 4th-generation MitraClip devices, shows even better MR reduction to 1+ or less. In the original Expand, we saw MR of 1 or less at 83%. In Expand G4 at 30 days, we saw MR reduction of 1+ or less at 89%. So really, these are excellent results, and these are data that were presented at TCT, the most recent TCT in Boston. Another exciting set of data comes from the very recently published PASCAL 2D registry. This was a prospective single-arm registry that was run as part of the larger Class 2D randomized trial that we already spoke about. These were patients that had increased anatomic complexity and deemed suitable for PASCAL tier therapy by a central screening committee. Our hospital's Echo Core Lab was a major part of this trial, and I can tell you from firsthand experience that these were truly patients with challenging mitral valve anatomy. Some examples include as follows: multiple significant MR jets. So these are, for a jet to be considered significant, had to be moderate or greater in severity. Barlow's valves, commissural mitral valve disease, small mitral valve areas, very large flails. So the results for this difficult patient population were very positive. 92% of patients had MR reduced to 2+ or less, and 56% were actually reduced to 1+ or less. NYHA functional classification was also significantly improved. Importantly, this trial was performed prospectively to rigorous standards and therefore highlights our ability to safely and effectively treat even these complex mitral tier patients. So how do we define mitral tier success in 2023? Ideally, we'd like to aim for surgical results of MR 1+ or less. With current tier technology and properly selected patient anatomy, recent data have shown that this can be largely accomplished. Now, as we all know, achievable MR result will depend on many factors such as baseline pathology, MR severity, and the starting mitral valve area. We want to reduce MR as much as possible. However, we want to make sure that this does not come at the expense of significant mitral stenosis. It's also important for us to acknowledge that what is acceptable MR reduction, i.e. success, will vary depending on the patient, their age, their risk, and of course their anatomy. With that in mind, by way of example, I'll say that an MR result of 2+ in a high-risk surgical patient that's 85 years old with MAC and a valve area less than 4 is both acceptable and successful. I will now jump into a few brief cases. The first case is a patient with severe atrial functional MR. There is atrial enlargement resulting in annular dilatation and leaflet malcoaptation. If you look all the way to the right, you'll notice the presence of significant coaptation gap between the anterior and posterior mitral leaflets. 2 G4 late-generation MitraClip devices were implanted, one XTW and one XT. The independent leaflet capture feature was utilized to grab leaflets one at a time in a valve that would otherwise be very difficult to grasp simultaneously. This is the final result following device implantation. There is mild residual mitral regurgitation. Here's another case example. This is a patient with a lateral commissural flail. A single Pascal ACE device was implanted in the lateral commissure with mild residual MR. The last case is someone that we treated very recently. There is a very large P2 flail. The flail gap is 12 millimeters, the flail width is 20 millimeters. There is loss of secondary chordal support and very severe mitral regurgitation. Fortunately, this valve is large with a mitral valve area of 7.8 centimeters squared. Treatment of A2P2 disease is a sweet spot for TEER, however, this is an extreme example. Fortunately, our current device technology allows us to approach even difficult anatomy such as this. We knew this would likely be a 3-device case. Starting on the medial edge of A2P2, we proceeded to systematically implant one ACE device at a time. This was a patient that was in shock. Following the second device implant, MR was now reduced to moderate and LA pressures dramatically improved. Blood pressure normalized and vasopressors were discontinued. The residual valve area was about 3 centimeters squared, the mean gradient was 4, therefore we were able to safely implant a third device. Given the size of the flail gap, we expected that we'd have to grasp the leaflets independently, but fortunately we were able to grab them at the same time, simultaneously with all 3 device implants. This is the final result. 3 ACE devices were safely implanted and there was trace residual mitral regurgitation. The transmitral mean gradient was 5 millimeters mercury, and by planimetry, the residual mitral valve area was 1.8 centimeters squared. Pulmonary vein flow and left atrial tracings were completely normalized. To summarize, I hope that I've given you a good sense of how far we've come with mitral TEER in the last decade. With that in mind, I'd like to very briefly add that there's more excitement to come in the mitral TEER research space in the coming years. There are several ongoing important prospective trials that we'll hear more about in the near future. Repair MR is looking at intermediate risk degenerative MR patients being randomized to surgery versus MitraClip. The NIH-sponsored primary trial is also looking at DMR patients randomized to surgery or clip. However, they're doing it irrespective of surgical risks. So really, it's an all-comers trial. And lastly, we should also expect to hear from the ongoing CLASP-2F trial that's looking at Pascal versus MitraClip in the treatment of functional MR patients. Thank you very much for your time. Σας ευχαριστώ πάρα πολύ. I hope you have a great conference, and I look forward to being there with you in person next year.
Okay, that was a very interesting presentation. Unfortunately, we don't have
Thank you very much.
A live participation to ask questions, but we've seen how technology now enables the procedure to be done in a very broad spectrum of anatomies which previously were not easy to treat with the first devices. And perhaps I would like to ask Dr. Sparias, perhaps you can help us in a question. With the new devices, do they have a downside? Is they more bulky? I mean, if a patient has a very suitable anatomy for the old devices, do we use them or they are obsolete now?
It's a rule when you have a new technology to use the new technology because it's improved, the newer iterations. So the new iterations of the devices come in different sizes to cover more anatomies and to have, they have optimized features like the independent clasping or grasping that facilitates higher successes in these kind of procedures. So we're all very happy to see all these improvements that they're coming over the last years, and I'm sure there will be more, much more in the future.
Okay. Now I'll hand over to Professor Filipatos. Professor Filipatos.
Thank you, Dr. Pipilis. Yes, thank you so much, and thank you, Dr. Sparias, for the kind invitation. It's a great pleasure and honor to introduce the next speaker. I see that she's online, head of the heart failure clinic at Cardiothoracic Hospital, who is going to tell us about the difficult heart failure patient with FMR. Christina, kindly keep the time so we'll have some time for discussion. in the first lecture, we were already 2 or 3 minutes late. Thank you, Christina.
Hello, good morning. I'm sorry for, I have some problem with sharing the screen. Let's see what is happening. Sorry, something's happening. I cannot share the... Can you see it now? Can you see the presentation? Can you see the presentation? Dr. Dardas, can you see the presentation?
Yes,
as well?
we can see. We can see the
Χριστίνα, μπορεί να
presentation.
πατήσεις
Sorry.
την
Thank you very much.
παρουσίαση.
I would like to thank the organizing committee for this honorary invitation.
Just put the full screen.
This is the full screen. You see it in the next slide as well?
Ναι, μπορείς να πατήσεις την πλήρη παρουσίαση, νομίζω.
Έχω πατήσει, είμαι στην πλήρη παρουσίαση. Αυτό δεν θέλω να κάνω πρόβα.
Νομίζω ότι πρέπει να την κλείσεις και να ξανακάνεις...
Το έχω κάνει 100 φορές. I think now it's fine. Now it's fine, I believe.
Yeah, that's fine.
Τώρα είμαστε εντάξει.
Okay, that's fine. Okay. The last 10 years we had a very close collaboration with the team of IGEA because it was the first team that started the edge-to-edge transdermal mitral repair. And we also entered many patients that had that we wanted to see also this solution, especially to the clinical trials that the team of Dr. Spargas was involved. This is a rather difficult case of a 76-year-old man. He also worked in the medical field. He had a coronary disease with a myocardial infarction, rather extended, and he underwent the coronary artery bypass procedure in 2005. Soon afterwards, he was in a heart failure with reduced ejection fraction. He had an ejection fraction of 20-25%. And he was also, afterwards, some years, he was also implanted in CRTD in 2014. In 2019, when we met him, he was under the medication of ramipril, aspirin, atorvastatin, and perinol carvedilol. And he had in low doses because his blood pressure was not very well tolerated. He had a blood pressure 100, 105. We see the recommendations. It's well known about the SCD and the CRTD, and this patient has also LVP block, and he was also a coronary patient, so he had all the recommended, I believe, clinical characteristics to have inserted and CRTD in this case. Furthermore, CRTD, as he had already a functional MR, which is rather severe, we believe that it was the first stage that could reduce the synchrony, and it's also providing better reducing tethering forces and correct the diastolic MR, and in that case, even the systolic regurgitation volume would be reduced. It had a very good, of course, CRTD work. Furthermore, this patient had MR reduction after the CRT implantation because we also saw that the MR was reduced from severe to moderate for the first months, and he would tolerate the medications as well. And what we did, we tried to improve the response rate of CRT, and I believe this is the best procedure, the first procedure that one should always think has a CRT implantation. So first we had to control the rhythm in order to have the patients to be paced all the time, and also we have the very high levels of CRT pacing. And second, we did some alterations in AV delay optimizations, looking also at the filling corresponding with the longest LV filling time, and trying to see the best cardiac output that we could manage to have by modifying the AV delay. We had done all this, and the patients was improved in having them in NYHA, New York Heart Association, stage 3. But 2 years afterwards, all these modifications, he also had some, he started to have also hospitalizations for the compensations of heart failure, and we had severe mitral regurgitation. We had also functional character as well. So he underwent 2 times of edge-to-edge mitral repair, transdermal, in 2016 and 2017. I believe that this, we see down the post-transdermal echocardiography evaluation. As we see, he had a rather enlarged left ventricular. Also, the right ventricle was rather enlarged, and he was diminished right ventricular function as well. We see that the left atrium is also enlarged, so it was not the best case of having a transdermal edge-to-edge repair. But in this patient, I believe it was successful, as Dr. Kologiannis presented before, because we managed to reduce the regurgitation volume and have a moderate mitral regurgitation. And furthermore, we didn't have any mitral stenosis, although it was inserted with 2 mitral clips in this case. You can see also here the mitral regurgitation, which is moderate. He had also a mild atrial regurgitation. We can see that we have an enlarged right ventricle and we have this systolic desynchrony due to the tricuspid regurgitation as well. And we can see the 2 mitral clips in the 3D imaging. His clinical course was more involved with severe tricuspid regurgitation, as you can see. And at the time, we don't have any dry clip in certain clinical practice. Furthermore, the clinical course of this patient was also presented with atrial fibrillation, renal failure, and that's why we started to have some courses of ultrafiltration. His blood pressure was not very good to tolerate any titration of the medical treatment he was taking. He was taking low doses of pramipryl, aspirin, and atorvastatin, as I told you, and of course, furosemide in larger doses. But as he was starting to have a diuretic resistance, we had to first to switch loop diuretic and then to put him in ultrafiltration. Although the clinical studies of ultrafiltration have not given the beneficial effects that we were supposed to have, we have a 10 years experience with ultrafiltration. It's for the Jefferson Medical Center that has shown that in the clinical world, we can have reductions in hospitalization, I believe, and also they believe that this is a very good target point because we can reduce also the cost of therapy in patients with acute decompensation. So this patient started first ultrafiltration, and then we put it in peritoneal dialysis for heart failure. Thus, we managed to keep some of his daily diuresis, and also to keep the creatinine levels in adorable stages. So in 2020, when we had started to have recent admissions to hospital due to acute decompensation heart failure, we started ultrafiltration. And after 14 courses of ultrafiltration, he initiated peritoneal dialysis. This is the medication that it was taken at the time, and it is good to know that when we put in the peritoneal dialysis, he can take all the medications of heart failure in the doses that he can adapt. The problem with peritoneal dilutions was that we had some peritoneal infections, and also we have chemical peritonitis to ecodextrin, which is used in the peritoneal infection, which is rather rare. And this problem that caused him deterioration of his clinical status, and we had many admissions in the hospital. Finally, the last admission was 1 month ago, and this is the echocardiography about 4 months ago, where we see that the mitral clip is well tolerated with moderate mitral insufficiency, but the problems comes from the right heart failure and the kidney dysfunction and all the infections they had with the peritoneal dialysis. We see that after this large course of the patient, he finally, and we've also used Aquadex for by-side ultrafiltration in order during the severe course that we had with hospitalizations. Finally, this patient deceased 1 month ago. What I would like to finally give as a message for this patient is that
Christina.
Yes,
Christina.
I'm finished now. I will have around to tell 1 sentence. We try with this very difficult patient with an ischemic heart disease in a young age to do everything from a mitral clip to titration to medical therapy and also to renal support with ultrafiltration, peritoneal dialysis, and I believe that we managed to extend his lifetime and reduce the hospitalization that he may had all these 14 years of his course of heart failure.
Thank you so much, Christina. Thank you so much. Excellent presentation. I think I just want to comment and then I'll ask Dr. Dardas to continue. I think that it was clear that the problem of the patients are not solved. Can you
in a way, yes. In a way,
so
but the mitral clip reduced the recurrence of acute pulmonary edema that we had at the first stages of admissions.
Of course. What I want to point it out is that many of the problems that we have, they are still there, and this collaboration and these meetings help us to understand better the situation, because most of the parts of the algorithm for resistance to diuretics that you showed us, they have proved that they cannot help the patients. I think that you are one of the few centers that you use with success peritoneal dialysis. This has started by the late Oreopoulos, and you showed nicely how this could help the patient. And also something that I think is very important, don't use it very often at the right moment, is the new, the easier to use devices for ultrafiltration. And also you pointed out how this could help patients. So thank you very much for your presentation. And I'll ask Dr. Dardas to present the next lecture.
Thank you very much, and thank you, Dr. Spargias, for your very kind invitation, and congratulations for your meeting. Just 1 point to add for the last talk, and ask Dr. Chrysochou, do you think that with the current treatments, if we add TriClip in this patient in an earlier stage, would benefit him more? What is your opinion on this? Hello, can you hear me? Can you hear me?
Έχει αποσυνδεθεί.
Okay. Dr. Chrysochou, could you hear my question?
I think she's not connected, Petros.
Okay. So let's go on to move on to the next talk, and now we're going to see. Okay, fine. Now my question was,
Here, I had the problem with connections with the internet. Sorry.
Okay, I just asked the question. Do you think with the current evidence, an earlier tricuspid treatment, percutaneous, would benefit him more? I mean, with the current data too, and the Triluminate study, do you think that it would be an option for this patient?
Yes. Yes, you're right. I believe with the current evidence that we have, yes, thank you, Dr. Dardas. I believe with the current evidence that we have, maybe a tricuspid percutaneous implementation could be beneficial for this patient in early stages, because
Yeah, that's right.
afterwards we have put the mitral clip, the right ventricle was not very enlarged. And I believe at that time, a tri-clip would be rather beneficial for him, because all the clinical course that he had was due to the severe tricuspid regurgitation that he was progressing to have.
Okay, okay, thank you very much.
And,
now,
I think we should all agree that a heart failure specialist must be part of the heart team, and before for the decisions and afterwards.
That's right. Now, let's move on to the next talk. We'll be given by Dr. Samarkandi and explain to us some more extreme, the treatment of severe mitral annular calcification with something that we're going to listen with a lot of interest, because it's an area that has not been very clear so far. So, Dr. Samarkandi.
Good morning, everyone. Thank you for the invitation. So my talk is a bit brief, it's not much. We're going to talk about the boundaries of severe MAC and mixed mitral valve diseases. I have no disclosure. So a quick introduction. MAC is observed in 18% of the patient, up to 23 who are going for mitral surgery. Operative mortality is high in those patients and has its own risk of complication as annular rupture, coronary artery impairment, or reoperation and bleeding, or paravalvular leak. The MAC poses a unique technical challenges, and several surgical techniques have been proposed to overcome this technical constraint associated with MAC. As we know, there is a pathophysiology going with this MAC. Either you can go with a mitral stenosis or mitral regurgitation. We're going to focus today more on the MR. It can go with the subvalvular calcification, restriction of the leaflet closure, and posterior leaflet distortion, and of course, atrial and annular dilatation. As we know, the prognosis, unfortunately, is poor outcome, as those patients usually carries more comorbids than the usual patients. In addition to that, still we don't get much of the etiology of the MAC, and we're still learning. Management-wise, usually upfront the diuretics, and we had a nice talk just a while ago, rate control, heart failure preserved ejection fraction therapy, and then valve intervention, either surgically or percutaneously. There are many suggestions to grade the mitral annular calcification, going from mild to moderate. To make it simple and easy, if it's less than 1/3 of the circumference of the mitral, you can say it is mild. If it's more than a third and less than a 2/3, it's a moderate, and more than 2/3 or a horseshoe, well, it's more severe. So if you have a severe MAC-related mitral valve and a patient is symptomatic, the first direction in the algorithm, you go for medical therapy. And if the symptom persisted, you then approach the patient with more referral to comprehensive center who has a mitral valve experience, and then you go for the heart team. And in the heart team, you decide if the patient is suitable to go for mitral repair or replacement, or even a surgical valve in MAC. And if not suitable, then you have two options, unfortunately, left for you. Either you accept your losses and go with medical therapy, or you have a percutaneous TMVR. So what are the treatment options? One of the earliest options that has been depicted from registry, which is valve in MAC, but unfortunately, as we can see from multiple registry, they didn't do very well. It has a challenging of the procedure it's associated with itself and complication, and those patients who are already high risk, and the survival rate in the follow-up wasn't that great. Anyway, outcomes are improving now with better patient selection and techniques, and further efforts are needed to improve the overall outcomes, and the long-term effect is still unknown. The other way was going for transapical valve replacement and using a Tendine system. It's a 35 French, and still it's a very invasive procedure, going transapical, almost a surgical access. And as you can see in B, patients who have failed clip still is not like a contraindication to go for that procedure. But what the caveat of this procedure is the multiple screen failure. And finally, when it went to the trials and the evaluation, it has a technical success very high, despite the anatomical variation, and very significant improvement in the symptoms and sustainable results of MR reduction. But again, expands the catheter-based treatment, this therapy. But as we know from the last few trials, they have 35 to 37% mortality rate in 2 years, possibly related to the patient selection and the comorbids. Finally, we'll more focus in the last 10 minutes on the TEER in MAC. As we know, it's been established as an alternative for surgery in high-risk cases, and we have this been delineated in the first presentation. Yet still we are uncertain with the MAC because the data and the poor outcome still has been observed in the Alfury surgical technique in this setting. So it's a chronic degenerative process and increasing the prevalence in developed countries, and we have to do something about it. So this is a nice cohort study done on almost, let's say, 800 patients. 61 patients were been redeemed to be MAC group, which is more than moderate to severe MAC. And 791 patients were non-the MAC group, all comer from 24 European centers. And they observe the patient up to 1 year and see how things are going. They have excluded any patient with a posterior mitral leaflet less than 7. They excluded any mitral valve area less than 4, and they excluded any mean gradient less than 5 as a baseline. They found there was a similar peri-procedural success, but higher rate of conversion to surgery with the MAC group. But again, those are 60 compared to 800. But from the clinical perspective, there was similar improvement in the symptoms, sustainability of the MR results was less than 2 grades, and similar cardiovascular mortality and similar decrease in hospital failure, hospitalization for heart failure. The only thing that was noticed in the follow-up for 1 year, as you can see in the top one in A, in the right part, which is the 1-year follow-up, that the patient who in the MAC group had an increase in their gradient more than 5, reaching 6 to 7, but less than 8. And there was some speculation about the reason. They said maybe because the LV started to get better, or the anatomy and the dilatation and responding get better, so that's why you had the more gradient. But nevertheless, it's still like speculation. In terms of the classification of their symptoms and MR, we have just covered that up. So as you can see, freedom from all causes of mortality or cardiovascular mortality and from rehospitalization were they're all similar. So let's go for a case quickly. We had some good news, so okay, everything is great, but let's go into real life. So this is a 72-year-old lady, hypertensive, end-stage renal disease. She has a severe degenerative MR, what we can say a mild and less than moderate MAC. She's been having very symptomatic despite multiple sessions of dialysis across the week. Her ejection fraction is good, her PA pressure is 55, and she has significant MR and moderate TR. She was discussed in the combined meeting in the heart team, and we said, okay, let's make it an attempt to go for a clip because she's very frail, she's in a wheelchair, and she has lots of comorbids, and we didn't think that she's a surgical candidate. So as you can see here in the bicommissural view, when you explain it, there is a significant MR and some calcification, but is not extending to the subvalvular area. And our posterior mitral leaflet looked nice, but you can see in the annulus there is some calcification, and there is spicle of calcium on the anterior mitral leaflet. The standard or baseline under sedation was a mean gradient of 3. And you can see there is the area looks a bit smallish, but we have a significant jet in the center to the lateral. We took the area, and it was 3.8, so everyone winced inside of the OR and said, okay, fine, let's give it a try. And we took a smaller clip size, and this was explained very nicely in the first presentation, with that having multiple sizes of clip sizes in your toolbox give you an extra edge. So we took an NT, went straight, as you can see, above the jet, and you can see we have excellent lying of the posterior and the anterior leaflet. We did some amendment, and you can see the grippers here dropping on the right-sided picture very nicely. We have a good reduction of the MR, but at the same time, we have to check the gradient. And behold, we have a significant gradient of 11. We thought maybe we're distorting the valve, or we are not in a clocking or perpendicular position. So we recheck the clocking, and you can see out of the back, it's a very clear, good clocking, because you can see both arms in the LVOT and no arms in the bicommissural view. Number 2, we made sure we are not distorting the valve. We made sure we're not pulling any cords with us, and we started to move the clip a bit of a medial perspective and tried to lessen the tension on the posterior mitral leaflet. But of course, we opened straight ahead the medial jet, and still our gradient was high. We spent 45 minutes after that moving the clips right and left, trying to get lesser tissue, more tissue, but we were not successful. So despite there was a reduction of MR, the mean gradient increased up to 11 and 12. And the LA pressure, which is a prognostic element, we found it to get up to 40 from the baseline, which was around the 25 at this. So we said this is not compatible with this patient. She cannot tolerate this. And this is under sedation and intubation. So this is not going to work. And unfortunately, we took the clip out. So you might have some predictor for MR gradient after the tear. In our case, our patient was in the yellow box. Her area was 3.8. But we managed, the hope was we will go for, it's a moderate risk, let's go for one clip, and she cannot tolerate more than that, but 11 is too much of a stretch. And again, that was a kind of a primary MR, number one. In contrast to the co-op study, when they have a sub-study checking the gradient, they found they have a 4 quartile patients. Some of them were reached the gradient up to 7, but again, their area were more than 4, and it was a functional MR. So keep that in consideration. What is the allowed gradient in these patients? So in summary, I'm just going to brief up in the last couple of slides. Number one, ask yourself when the patient presents to you, is this intervention warrant for the given patient based on the balance of symptoms, quality of life impairment, and comorbids, and the life expectancy? Is there a rule for prior optimization with medical therapy or functional status of this patient, i.e. we're going with cardiac rehab? Is there a valve anatomy is suitable for conventional mitral surgery or not? If not suitable for surgery, is THV implantation anatomically feasible at acceptable procedural risk? By that, you'd have multimodality imaging going from transthoracic, TEE, and CT. Once you have your answer ready, then start to think about what you have. MAC is a more frequently encountered in an aging population, provided a unique challenge to the heart team. Advanced and comprehensive peri-procedural imaging has quickly become the cornerstone of all heart team decisions regarding these patients. And despite a limited evidence base, surgical valve remains still the gold standard of treatment because they see what they're doing. And surgical and transcatheter valve in MAC procedure are still associated with some high of 30-day mortality, maybe because of the patient selection. And at the end, I final my presentation with heart team evolution is not about a surgeon, an image expert, or just interventionist. You have to have a heart failure specialist, a dedicated coordinator, and multidisciplinary consultants from different specialty, nephrology, chest people, and also the cardiac anesthesia have a very major role in your procedure. And finally, a valve cardiologist who will follow the patient afterward and before he is referred to you. With that, I thank you.
Well, thank you very much. That was an excellent presentation. Of course, it's a very difficult subject, and I think it's one of the subjects that we mainly don't know what to do most of the times. And I agree with you that the cornerstone of MAC is the medical treatment. I wanted to ask you whether you got some experience in your center with what some centers tend to do is to do a hybrid procedure. That means approach the valve endoscopically from a lateral position and cut the anterior leaflet in order to avoid the alveolar obstruction, and then implant a percutaneous sapien valve and stitch this valve around. Do you have any ideas on that and any experience on that?
So in my center, we're not doing the valve in MAC, like a sapien in a MAC, or doing this thing, because so far either the patients are completely asurgical and non-operable, and even non-percutaneously. And the way to go with it in my center, we're going to either medical therapy or refer them for a Tendyne, if they are their CT is suitable. But as we said, unfortunately, in these cases, the failure screening rate is very high. We've been doing in Saudi Arabia now Tendyne in the last, let's say, 2 years, and we have been, because of the good selection, they are very meticulous with the selection, they have been having good cases outcome. But the valve in MAC per se, as in Saudi Arabia, we don't have much of a cases, if any, because of, limitation of the number one, possibly experience, number two, having the best patients or the good patient selection. And in terms of leaflet modification, in terms of to avoid the LVOT, unfortunately, again, because we're not doing the procedure, we're not extending to that point.
Yeah, okay, fine. Because I agree with you, and this shows actually the difficulty in managing this patient. But this is an option. I mean, some centers do that, a hybrid approach. So this could be an option for these patients, but it's very difficult to decide about that.
Yes, true. As you said, CT, you have to look at the CT, the LVOT, the areas, the degree of the calcium, if there's something to hold in it. It's very difficult, to be honest with you. It's not an easy subject to a patient to come to you with it.
I agree.
Okay, we have a question from the floor.
Regarding the question of the moderator and regarding this important case, I want to underline and comment about the length of the anterior leaflet in patients with mitral interventions. This is very important because we did in the first lampoon case in Turkey, and the lampoon is very, very important in that kind of patients regarding the question. Laceration of the transcatheter laceration of anterior mitral leaflet, and put, for example, a balloon expandable valve. Like in the case we put a 29 millimeter MyVol valve in that case. And the other option compared to the lampoon is to do, for example, alcohol septal ablation for the prominent septum, but there are some risks of doing alcohol septal ablation in that kind of patients, since these patients are very sick. So I think, like in Tendyne or valve in MEC interventions or transcatheter mitral valve implantations, every interventionist had to learn lampoon techniques. There are some also investigational simple devices to do transcatheter cutting of the anterior mitral leaflet. Not this case also suitable, but I really congratulate you. But what is your comment also about lampoon techniques?
So I haven't done it, so I cannot have much of a comment on it, but I think it's dedicated, it had to depend a lot on your CT and understanding the CT and the new LVOT and how long it is it. I haven't done it, so I cannot much explain on it, but again, if we're talking about Transcat TMVR, well, we have the interpreted, which is now ongoing, the Apollo trial, transfemoral access. I mean, I think it's more forgiving in compared to having a sapien in a MAC or having a Tendyne, which is a transapical approach. So, and they have, I think, 3 or 4 sizes, and one size is under process to have a bigger one, and it has its own anchoring in the 2 anchoring technique. So if you have a good CT imager and you have a good team with you, I think why not to go with it, especially if the patient is non-surgical and you're already failing medical therapy, optimized medical therapy, and you have a good CT which is not constraining any risk on the patient. But how long will that take us, or how much of a future projection are we looking after 5 years? I don't know. What will happen after 5, especially with the septal ablation? What is the long-term effect of these procedures that we're doing after 5 years? Are they going to have gradient effect? Are they going to have a remodeling effect? Are we going to have a pouch or an aneurysmal after 5, 7 years? It's very hard to say because usually these patients have lots of comorbid that they don't give you the time to see the long-term follow-up for these patients. Yes, Doctor.
Okay, Dr. Sparias.
Dr. Samagadi, really thankful for joining us, for traveling to join us. Thank you. I think these are the most difficult cases we encounter in our daily practice. They're not so rare. We see them very often. And this is probably the area where the transcatheter valves for the mitral valve will have a space to develop more, because we've seen in your case the limitations of clipping in those cases. Just a brief question. Do you think that Pascal would behave a little different because the design of this clip is different?
The moment we pull everything out, my imager came to me and said, what if we used Pascal? So he told me the same thing. I said, okay, I don't know if we can subject this patient again for another trial with the Pascal, but if we're gonna do it, we're just gonna go, we compared the NT, because in the first presentation, they put the NT and the ACE and the P10 all together. They are basically the same size in a way, in terms of the clip arms or the arms and in terms of the width. So are we really gonna be far away or not? It's very hard to tell, number one. Number two, I told him the gradient was 12. It's not like 6 or 7 that I can play around and accept. This was 12. Even if I took it by 2 grades or 3 grades, I'm still gonna be 9. And this is under complete intubation, and the heart rate was in the 70s and the blood pressure was in the 90s. The moment she wakes up, I think it's gonna be 16. So I don't know, but from our experience comparing devices head-to-head, clip versus Pascal, we have noticed that Pascal has more predictable gradient next day. After the patient are sober and they are extubated, when we look into that, we find that more. If you are intraoperatively 3 or 4, next day most likely will be 4, 3, the same, or maybe 5 sometimes, depending on your heart rate. Whereas in Abbott, which is just an observational, it's not like written on stone or anything, we found sometimes you come within 3, and then next day you find yourself 7. And then you say, what's going on? I think possibly the spacer has a major role in that. Number 2, we know the Abbott mitral clip is an active locking mechanism, whereas in the Pascal, it's a passive one. So I think it goes, the Pascal or Edward, it goes more with the tension in the system, so that's why you have more relaxed, let's say, gradient across the time. And also in terms of the predictability of the residual MR in the long follow-up, we have noticed, again, that's an observation, the persistency of the results is more predictable with the Pascal. Again, these are small numbers, you cannot judge, maybe the patient selection or something, maybe that patient has, because again, whenever we see some calcification or we need a really good grasp, usually we go with the Abbott because thinking that you need to cinch everything. And when we see a relatively small area, less than 4, we go with an ACE in a way, but for technicality at that day, we went with an Abbott.
Okay, thank you. We will move now to the case. And please, Dr. Dardas, you can take the coordination since you are an invasive cardiologist while I'm not.
Okay, thank you very much. Now, we're going to have the case with the with mitral regurgitation. And I would ask Dr. Kurtvelli to present the case to us and then discuss all the rest.
So, good afternoon. Thank you all for being here today. We're going to present a case of a 21-year-old gentleman who reported having shortness of breath for the last couple of years and worsening symptoms in the past few months. The patient was also newly diagnosed with atrial fibrillation, and he had a history of arterial hypertension hololithiasis. He had a normal coronary angiogram in the past, and his echocardiogram, when we first saw the gentleman, had severe degenerative mitral regurgitation, dilated left ventricle with impaired systolic function, and normal right ventricular function. The patient had an echo back in 2015, which reported only mild mitral regurgitation. The ECG showed atrial fibrillation in the left anterior fascicular block. The chest X-ray showed prominent vascular markings, no pleural effusion. He had normal renal function and a BNP of 500, and he was on heart failure medication, the tolerated doses. So this is the transthoracic echo of the patient, showing dilated left ventricle with reduced ejection fraction, and we can see the prolapse of the posterior mitral valve leaflet. So, and these are the dimensions, and the end diastole is almost 59 millimeters, and the end systole 48. Again, the strain rate, or the global strain rate of the left ventricle was calculated -11, which is profoundly reduced. And heart model knew more calculations showing the enlargement of the left ventricle with an end diastolic volume estimated above 200 ml and an estimated ejection fraction of 53%, but bear in mind that the patient had severe mitral regurgitation. And this is the mitral valve. And again, we can see the posterior mitral valve leaflet prolapse. And we have an estimated error of 55 square millimeters and the regurgitation volume of 71 ml. The right ventricular systolic function and size were normal, and we had an estimated RVSP around 35, which is mildly increased. More images and calculations of the right ventricle saying, confirming that it has the normal size and normal function. And now I welcome Dr. Chrysoheris to continue the presentation. He will give us like a TOE imaging analysis, which will be very, very interesting. Guys, thank you.
So we'll proceed with the TOE. And here we see a mid-esophageal 4 to 5 chamber view. With simultaneous color projection. We see a prolapse of the posterior leaflet with a ruptured cord. And we also see severe eccentric mitral regurgitation with an anterior direction of the jet. We see also the left ventricle being dilated with impaired systolic function. Here we see measurements of the ERO. As we saw before, the ERO measured at about 80 square millimeters. With an regurgitation volume of 70 ml. Here we have our bicommissural view with biplane imaging in order to scan through the area of the prolapse of the mitral valve. It's prolapse with flail of the P2 segment. And the cursor is right in the middle of the segment. Here we have a 3D en face view of the mitral valve. And we can see on the left image the prolapsing and flail segment at the center of the posterior leaflet. And on the right side, we see photorealistic imaging with color indicating that there is one severe jet at the center of the valve with eccentric jet headed anterior, as we see. On the left image, we have the live 3D view. We see the prolapsing and flail segment from a different perspective. On the right-hand image, we measure the flail width, which was estimated at 16 millimeters, and the flail gap was estimated at 5 millimeters. Here we have MVQ analysis of the mitral valve, indicating that we have dilatation of the annulus of the mitral valve. And here we have the modeling of the mitral valve indicating the exact area of malcoaptation at the center of the P2 leaflet. So in summary, we have degenerative mitral regurgitation, severe in severity. The jet is central, single, eccentric, and anteriorly directed. The morphology of the leaflets, we didn't see any clefts. There is no significant indentations or calcifications. The leaflet length is over 7 millimeters for both the posterior and anterior leaflets. The mitral valve area is adequate, over 4.5 square centimeters. The peak and mean mitral gradients are low. The left ventricular size and systolic function, we had dilated left ventricle with an ejection fraction of about 50%, which is low for a patient with severe mitral regurgitation. The intra-aortic septum was of adequate height for transeptal puncture as needed. There was mild pulmonary hypertension at 36 millimeters of mercury, and the right ventricular size and function were normal. And with that, I would like to pass it on to Dr. Niños for his comments. Thank you.
Hello from Thessaloniki. Dr. Spaghias, thank you very much for the kind invitation to participate in that fantastic event. I would like to share some thoughts about that case. If I may, I would share again give me some seconds. Okay, maybe there is some technical difficulty. First of all, the first question is how should this patient be treated? if we have to proceed to a surgical repair of the mitral valve, or if we have to proceed, or we should proceed with a edge-to-edge repair. He's 81 years old, and he has an impaired...
Elias, sorry to interrupt you, but you have to press on PowerPoint at the bottom line on your screen. Yes, this one. Okay. And now maximize down.
Thank you.
Full screen. Okay.
Now?
It's better now. Yeah, thanks.
Okay. He's 81 years old, and he's in NIHA 3 or 4, and he has an impaired LV function because the ejection fraction of 50 and the impaired strains show that the left ventricle is diseased. There is also an enlargement of the left ventricle. He has obviously no systolic hypertension. That's a good thing. We see here that the longitudinal strains are lower than 18%. And the ejection fraction of 50 or 45 is too low for a patient with severe mitral regurgitation. He has no pulmonary hypertension. That's good. And the right ventricle is also with normal dimensions and ejection fraction. That's also good. Technically, we see that there is a prolapse of the central part of the posterior leaflet. There are no calcifications, no stenosis, and the flail width is 16 millimeters, I think, here. Okay, it's maybe more than 15 millimeters, but it's not that bad. And the flail length is also not more than 10. I think that technically he can have a very good result with an edge-to-edge repair. We see also no clefts or no rheumatic stenosis on the valve. And I think it's a good case for a TEER procedure.
Great, thank you, Elias. So let's start the live in a box, Jota. So we'll just see the highlights of the procedure we undertook, and starting from echo-guided puncture, as you've seen. So what kind of device would you use in a case like this? Petros, are you with us?
Yes, well...
What would be your first choice here? What would be your strategy?
Well, he's an 81-year-old man, so I would definitely go for TER. And I would choose either a Pascal or an XTW because of the flail width is more than 16. So this is my first approach. Either Pascal or an XTW mitral clip, depends on the experience of the center.
So here you've seen the transeptal puncture, first with a safe sept wire through an SLO catheter. We always use the safe sept. It's an extra safety and easier to cross, especially when you have thick septums. Now you see the guide catheter Pascal system that is going through after pre-dilatation of the vein down in the leg. So the vena contracta, the measurement, the width of the prolapse was 16 millimeters. Would you go with the classic Pascal here, Sondus, or with an ACE?
So a couple of stuff here, so it was excellent transeptal puncture. That's a beautiful puncture. And maybe if I have seen more redundancy, I would go with the Baylis. But if you don't know, it's an excellent puncture. Number two, having Pascal or XTW also are good, but I will go with an ACE because usually flail segment, I need more strength to catch the flail part. So in this situation, although the area is very good, 4.5, I will still go with an ACE. So even it gives you a chance if you need to go more laterally or medially with another device, you have a space to do that. If you go with an mitral clip, I might go with an XCW, but here looks good. Third point, in terms of the transeptal, the beauty of Pascal system, the easy crossability in the transeptal in compared to the Abbott system. So you have a flimsy 81 years old gentleman, so maybe it was a good choice from the start, retrospectively. I mean, you made the decision. It gives you a smooth sealing inside of the LA.
Yeah, it's this, the guide catheter, it's much more user-friendly, I agree. Yeah. It's very easily, it's hydrophilic, and it's very rare to encounter problems to get it up and to cross the septum. So here on the right side, you see the echo imaging of the device into the left atrium and how it goes from the default position, from the extended position to the default position. And on the left side, I think there is a mix-up here in the editing. You see the device going in.
Is it a P10 or
So Yoda, you want to help us? What happened here? We don't remember. All right, yes, Kyriakos? All right. Thanks for reminding us.
So did the new one. It wasn't closing up when you go to capture, you wanted to close the clip after introduction, it didn't respond. That's why you keep the grippers or the clasp back to get it out.
It was a bailout. So yes, now I remember. And what happened was with the flexing of the system, we had a noise, right? Something, and then we couldn't flex or unflex. So because we're still early at the procedure, we bail out. So that's why you saw that alignment of the clasps half down, and then we elongate it and we put it back, and then we use the new one. So this is the new one. Thank you, Kyriakos. Strong memory.
So what is your strategy now here? You're going to go exactly A2, P2 for the flail segment, I'm assuming, correct?
Okay, and is this an ACE or a P10? I think this is an ACE.
An ACE, yes, when he flipped it.
Yep. So what happens here is this misconception that the ACE has a higher closing force than P10. After a lot of discussions with the engineers of the Pascal in Irvine, we discovered that it's vice versa, that the P10 has about 20 to 30% higher closing force than the ACE. But what happens is that the ACE, it has a smaller spacer. That's why when it closes, it brings the leaflets closer. Whereas the P10, because there's the spacer inside, when it closes, it doesn't bring the leaflets to complete contact because of the spacer. So this is the differences between the two. So here is the first device.
Another possibility that usually maybe putting a P10 from the image perspective, they see a bulky device, shadow, and then they think, where is the leaflet? Whereas in the ACE is smaller, more image friendly. So maybe.
I'm looking actually at the report from the case. We actually used the P10 device, and the reason was because of the width of the flail segment. We considered that it would be more appropriate to put a wide device to maybe with a single device capture the whole prolapsing segment.
So it's a good thing that the entire team is here, so we gather our minds and we remind ourselves of the procedure. Because of this width of 16 millimeters, we initially thought, let's try the classic P10 and see if we're lucky, because many times in the past we were lucky with one P10 to get out completely the prolapse and the MR. So we started with the P10.
And you're going for independent grasping, as I see here.
Yes. Okay. So Michael, probably you can describe here more. So you see that we got the anterior leaflet and then the posterior, but you see there is a lot of redundancy, the posterior leaflet, which means we're not very happy with this. We don't know if we have enough inside. That's why you see we're opening up the device again. So we go for a tighter clasping of the prolapsing segment. So here you saw we went the other way around. This is first clasping of the posterior.
Probably a bit rotated, that's why we don't
Maybe,
see the
yeah,
whole
we lost the
anterior paddle. So I think
it's not always straightforward as the case you demonstrated.
But in mitral, you have don't have a problem to capture the anterior or the posterior or vice versa. It's not like more delicate in the tricuspid. So both of them for you, is it equal, or because it's a flail segment you were aiming for it? So what are your thoughts about that?
Well, I think the rotation, because we're not exactly in the center, that's why we're not targeting to be 12-6 clocking, but rather like 11-5. And when you do this, you never know when you do the independent clasping, because you move the system. This slight torquing of the system anterior or posterior, it may also change your clocking. And I think this is what happened here. So this clasping here is independent. We first got the posterior, and we're happy with how much the posterior was in, as you've seen, and then we got the anterior. So, and this is now the system released.
Did you check the gradient or?
Everything should be here. So it's released
it's
here.
P10, yeah, it's a P10.
yeah, the final gradient was 2 millimeters of mercury.
There was no indication. MR reduction 80%, I'm assuming. Do you make it as a habit to check the pulmonary flow and the hemodynamic intra-atrial throughout the case?
Yeah, we do a full analysis before we release, and that includes multiplanar reconstruction of the device and scan it from medial to lateral. In addition, obviously, we'll look at the hemodynamics that we have in real time, and definitely look at the pulmonary veins and other markers of improvement.
Okay, that's great.
Okay. Any comments from the floor or from the panel?
Another excellent case. Congratulations. I think this meeting is a very good structural meeting, and congratulations again, the organizing committee. My question is related about transeptal puncture site. For example, do you change your transeptal puncture site according to the regurgitation of the jet? Sometimes it is not possible when you do anterior superior puncture, for example, if the jet, do you change in your, for example, your transeptal access point?
Yes, that's a good question. If the anatomy allows you, yes. Sometimes the anatomy just guides you to one particular point. In general, we try to be the higher possible, and certainly from the midline and posterior. But sometimes this is not possible if the inferior vena cava is much more posterior to the septum. So this gives you an anterior direction in most of the times. But initially, when you go with an SLO, which is a flimsy small catheter, even if you have an anterior direction, you should aim to the middle of the septum, because when you go with a stiffer guide catheter of either a mitral clip or a Pascal, by rotating the system, then you manage to direct in the middle or even posterior. But when you do this, especially with the stiff guide catheter, you may actually expand the iatrogenic ASD. So if you have to do all these maneuvers to go more posterior with a stiffer wire when your direction is anterior, then you may end up with a slit-like ASD that is longer than usual at the end of the procedure. So that's why you should avoid to do a lot of manipulation, if possible, on the guiding catheters. especially with the mitral guided catheter, which is much stiffer, it's metallic, than the Pascal catheter. But generally, you can predict somehow the anatomy if you have a CT scan, but we don't usually get CT scans for M tier or T tier, except some exemptions, cases that you have worries about the calcium and you want to be sure about the location of the calcium on the mitral leaflets or on the annulus. As you know, the transeptal puncture is like half of the procedure, because if you get it wrong, then the procedure may become like a nightmare and you may fail. So that's why you should spend a lot of time to get the transeptal right. So now in general, if you have a pathology which is lateral, you're allowed to be a little more anterior. But if you have a pathology that is medial, you have to go more posterior, because that is more posterior and also higher, to be able to have the space and the leeway to go there. I don't know, Santos, your comment on this?
Yeah, usually, as you said, if the transeptal allow you, I don't like to manipulate a lot going up or down. Let's gain more height because it's medial, or less because it's lateral, or vice versa. So I usually get as high as possible, not to exceed like 4, 5, or 5, because I know in this case, for example, elderly patient with redundant septum, we know there will be a drop. Even if you get a 5 height, there will be a drop, so maybe 4 or 5. The most crucial thing that avoid to be inferior, which is not in this case, because having an inferior puncture, even if you have a good height, may cast a shadow from your guide across your views, and you will not be able to see the posterior leaflet. So get it at least in the middle, 4, 5, 4, or as much as possible. Don't go flexing, pushing A into, because I had a case like that, as he was explaining, that we needed, it was a female small bed, and we had to really struggle with entering the guide inside of the LA. And after we finished the case, we can see like as if we torn the interatrial septal itself. And the beauty of Pascal, you don't have this. It's just very smooth sailing in the groin and also in the transeptal. Every device has its positive, and every device has its like negative or say out down stuff, but they are complementary. It's good to be versatile, have both in your toolbox. In case some cases need something, you go with choice A, and other cases you go with choice B.
Great. Other comments? Petros, you want to, Elias?
No, that was a really very good result. Congratulations. Don't have anything to comment on that. It was technically done very well. My only question would be, Kostas, what would you be, in a case like this, your strategy regarding the choice of the device? I mean, would you have any options or any indication for altering from Pascal to the mitral clip? Any particular point that it would drive you to change your strategy regarding the device?
Very good question, and this is a problem when you have both devices available. Sometimes to have just one device available makes things easier. But when you have access to both of them, you have to think a lot before. So I think this case will be executed perfectly well with the same result with an XTW, like Sandra said. From one point and after, it's an issue of habit, what you are used to using every day and how happy with your results. You know very well that when you have good results with one device, this it gives you the inclination to the next case to use the same device. And when you get a bad result with one device, then in the next case, you try to avoid and to move to another one. So now we have a big series of using the Pascal with good results. So I think that was the main reason we used the Pascal in this case. And I think that decision was verified and approved by the result, because we used just one device and we finished the case quickly and with safety. Because I believe, I'm a strong believer that every time you're forced to use a second device, you take some risk in the manipulation of the second device to have some problems and finally put a risk in your final result. And so I believe it's good if you can finish with an effective, acceptable result with one device. It makes the procedure shorter, quicker, and safer for the patient. And that was the reasoning behind this decision to use P10 here. But as you've seen, sometimes unexpected problems occur, like in this case, that we had the problem at the beginning because a tension line in the system apparently broke, and we had to remove. But that was an example of how easy and safe is to do this bailout with this device if you have to, because it's nitinol, so it transforms and takes any shape you want easily, so it's safe to remove it in case of problems. And I believe that the problem here with the broken line happened because probably we over-flexed the delivery catheter before going enough out of the guide catheter. So we're flexing and the guide catheter was preventing the flexion. That's why there was an extra tension on that line and it broke.
Yeah, thank you, Dr. Cosenti. I have just a question. Like in the old days, they used to say if you have a flail segment, stabilize it with another clip. But that was during the era of NT clip, like very old time. So do you think this strategy now is still applicable in flail segments to put another clip for stability in the era of having XTW and P10 and ACE? What do you think? What is your thoughts?
In the old days, we're targeting the flail, yes, the rhapsocodi. But I think now we're targeting the color, where the pathology, where the regurgitation is originating from, not just the flail. Now, if you have a good result with, let's say, a residual MR of close to 0 or mild, and you still see pathology of prolapsing, then I think you should go with a second device to get the pathology also stabilized, because there may be some remodeling of this leaflet. The tissue, usually in this case is prolapsing tissue, has some pathology, so you may have a relapse in the future. So I think if you have 0 like MR, probably you stop. But if you have some MR and you see still the prolapsing part there, even without color, then I think I would go and stabilize it with a second device. And probably that will be needed if you go with MitraClip here, because even the W MitraClip is 6 millimeters width, whereas the device we used here is 10 millimeters width. So it's almost twice the width of the MitraClip W. And Elias, can we have your comment if you are there? Okay, no comment from, no other comments. So if there are no other comments from the floor, Michalis?
I would like just the last comment that you made, that with DMR, we like to nail the pathology as possible. If you leave even a small amount of prolapse and a small jet, that finds its way over time to, have a relapse of MR. So it's important to stabilize the pathology as possible. I think it's very important.
Makes sense.
Okay, so I think we're reaching to the end of this session. It was a very interesting session. We missed on one presentation from the doctor, the surgeon, Thomas Modin, on degenerative MR in younger and low-risk patients with MR, which is a very interesting case, since in these patients we do not tolerate any regurgitation and we want durability. So we would like to ask Dr. Sparias to leave this topic for next year, because I think it's very interesting. So thank you very much all the participants, and we will move on after a few minutes to the main lecture.
And I think Professor Philippatos will stay to chair Professor Acker in the keynote lecture shortly. Thank you.
Thank you. for the nice program, for organizing this session and invite me to participate. And it's a great pleasure and honor for me to introduce the lecture of Professor Anke, one of the pioneers in this field of TER for FMR. And this is going to present TER for FMR in heart failure patients. He'll give us an update for what happens in 2023, and he will tell us where we are today with the ReShape Heart Failure 2 trial, where Greece and Dr. Sparia's department played an important role. And Professor Anke was the spirit behind this. Professor Anke, Stefan, welcome and looking forward to your presentation.
Gerasimos, thank you so much. It would be nice to get a short reassurance that you can actually see my slides. And
yes.
Perfect.
Yes.
Now, it's really an absolute pleasure. This time I cannot physically be at the meeting today, but as Kostas knows and Gerasimos knows, in only 12 days I will specifically come also to Athens to actually discuss the progress of the ReShape HF2 trial. I will then also go to Thessaloniki and meet also Blasis Niños. So this is really very close to my heart. And I thank Gerasimos also for saying that I supposedly should be considered a pioneer, but don't forget, I'm not doing the implantations, I'm organizing trials. And so really this is what I'm going to talk to you about, the evidence based on trials. We have, of course, many comorbidities in heart failure, and functional MR is one of them. And we basically have solutions developed over the last 20 years for this problem. And the MitraClip in its various derivations is, of course, an important part of this. You may also know about, for instance, the Cardiothoracic device, which is also undergoing currently testing, and trials are ongoing to see whether this is also an option for the future. Now, when it comes to what is going on with MitraClip, the first important statement has to be made. It's not 100% clear how the situation looks like, because the first trial reporting on this, and this was at the ESC meeting in 2018, was the MITRA-VAR trial from France. And you can see here death from any cause or unplanned heart failure hospitalization for the first 12 months. There was no difference whatsoever. And please note the little comment that there was a 23% mortality at 12 months in this trial. There was a 2-year follow-up report as well. So the results are really not getting much better with longer follow-up, at least in this study. We don't have yet the 5-year follow-up data. Then, luckily, only 2 months later at the THT meeting in 2018, we had the report from the co-op trial showing us how beautifully this treatment can work if done with somewhat longer follow-up, with basically in a bigger population and with a very rigorous design. And here you have the primary effectiveness endpoint, all hospitalizations for heart failure within 24 months, a 47% reduction of this endpoint, but also importantly, all-cause mortality went down. Now, I would like to emphasize also the point that if you take the trial's 12 months mortality, you also see here in the control group a 23% annual mortality rate at 12 months. That shows you that from a severity by mortality assessment, these two trials were somewhat similar in terms of having a very sick population, because 23% mortality in the control group is typically not seen in our heart failure trials. Now, we basically have a third population with a trial focusing there ongoing, and that's the ReShape HF2 trial, originally planned with 420 patients. There is still some degree of a hope to have more patients. I believe in the end it will be 500 patients. I will believe we will report towards the end of next year with a 3 to 3.5 year follow-up for all these patients. very important, this population has a 1-year mortality of about 11 to 12%, so half of what is seen in COAPT and MITRA-FR. And so we will see, this is truly a third population of moderate to severe, not only severe FMR. We shall see how this is going. I will come back to this at the end with a more detailed update. Now, the most important thing that happened in this field was the 5-year report at the ACC for COAPT, and I will very quickly show you some slides about what was going on there. Now, in terms of the results shown there, the key inclusion criteria are here: ejection fraction 20 to 50%, and they were symptomatic patients with 3+ or 4+ secondary FMR, and the patients had to have increased natriuretic peptide levels. So basically, when you look into these populations, for some reason, it is really not moving forward here. You see that the study flow is given here with 302 patients in the MitraClip group originally versus 312. And you see that the 5-year follow-up with 85% plus patient was very complete for this study. Now, I'm showing you now the baseline characteristics for this study, the 5-year follow-up, with some comparisons of what we have in Reshape. Age 72 years in Reshape, we have 69 to 70. The number of male patients in Reshape is a bit higher, more like 70-75%. You can see here all the usual comorbidities, diabetes, 1/3 of the patient, very similar in Reshape. For instance, creatinine clearance in COAPT 51, in our trial it's 56. The BNP and anti-BNP levels are about 30 to 40% lower in Reshape, so about 550 for BNP, about 3,000 for anti-BNP, giving you an idea that maybe the reason why I tell you that the mortality is lower at 1 year on average is really also the patients are a little bit less sick. You can see here the etiology, 60% ischemic, CRT in COAPT about 35 to 38%, very similar, by the way, in Reshape. The EROA is given here with 0.4. It's about 0.25 to 0.3 in Reshape, so a little bit lower. Ejection fraction in Reshape, very similar, about 30%. If you look into the treatment, that's quite interesting. Beta blocker therapy, 90% in COAPT. In our trial, it's actually 96%. ACE inhibitor and ARNI given here at 65%, 90% in Reshape, and mineralocorticoid receptor antagonist also 85 to 90% in Reshape, much lower in COAPT. Of course, 50% is not bad, but you can have patients tolerate more treatment, including MRAs, and then again, it may explain the somewhat lower mortality. So the COAPT 5-year results, then you see here the initial 2-year results basically show that over time you maintain the benefit. If you think of this as a 5-year assessment in terms of all heart failure hospitalizations, you have a 47% reduction, a very substantial reduction. And by the way, if you do this as a combined endpoint, very similar hazard ratio, 47% reduction also for death and heart failure hospitalization going down. If you look into subgroups, the COAPT trial is really consistently beneficial across the range of subgroups. I don't even want to highlight a single subgroup. You have benefit in the whole population of 3+ and 4+ FMR patients. And if you look here into the details and see the top curve there also for the mortality, 28% mortality also over this 5-year prolonged follow-up. This is clearly a symbol of a maintained, very, very beneficial treatment effect. Now, when you want to analyze all of this and put this in context with the Reshape trial, well, basically, you need to, of course, you need to have the slides forwarded, and you need to hope that you can show them the next slide. And so basically here, this was the New England paper, and then this is the ReShape trial now. The ReShape trial now, of course, has a very important final part to play. And this final part is actually played a lot by Greece. This is showing you the overall recruitment. It's my last slide, and this is why we are talking. Thessaloniki, and this is the previous site where Vlasis Niños was, and of course, Kostas Spargios in Athens. They are essentially 40–45%, these two sites of the whole trial. Poland also with a lot of very important contributions. You all know that Vlasis then moved to another place in Thessaloniki. There he had already recruited also 12 patients. So we now have in our two champion kind of recruiters, kind of centers, with Kostas, with Vlasis, we have each more than 100 patients. We will aim to finish the trial at 500 and a few patients. We aim to finish the recruitment during the summer this year, and then we will hope to report towards the ESC or AHA meeting next year with at least 500 patients. I'm really looking forward to all of this. Last not least, I would like to emphasize that Barcelona, Tony Baez-Ganes, is also recruiting. These are the only three really actively recruiting sites. It's not a spelling error. It's Badalona is a kind of a village and be nearby Barcelona, but really this is Barcelona for all intents and purposes. So I thank you all for your attention. I hope that you can help Kostas and Niños also to recruit these patients and maybe send some. We randomize them, and I'm very happy to entertain questions. And I look forward to meeting you all again very soon, also in person. Thank you so much.
Thank you very much, Stefan. Thank you very much for the presentation. I will ask Dr. Spargias to help me if there are any discussions from the audience. But let me start. Stefan, if we put this in perspective, what do you expect from ReShape 2 and how you will interpret the results if they are somewhere in the middle?
Well, thank you so much. This gives me the chance to speculate. And I have to absolutely say this trial, I have no idea about the results. I only know that the Safety Monitoring Committee has allowed us to continue the trial until now. So I should hope that at least we are kind of safe. Now, what I expect personally is actually something that is of significant benefit to patients, but maybe also something that is somewhere in the middle between COAPT and the MITRA-FR trial. And what I mean with this is, I actually believe that this treatment, and this is also our clinical experience, makes people better functionally, makes people better quality of life-wise, and makes people better stay out of hospital. I do not know really whether in this population we will also see a mortality benefit directly, maybe a small contribution, maybe not significant. But if you ask me personally, I expect personally a significant reduction in hospitalization, not necessarily in mortality. Can I ask what is your expectation?
Seeing the population that you presented, and I think that the results, I mean, also I speculate. I don't have, as you know, and none of us has any idea. I think that probably the results would be somewhere in the middle. You have more chances if you give a good treatment to have a mortality benefit if the mortality population is higher. Here is lower. Probably I hope that everything is in the right direction. And I suspect that we'll see a benefit in hospitalization and quality of life, as you suggested. And but these are just speculation. I don't know, maybe Kostas, Dr. Spargias could give us his perspective and also see if there is any other questions from the participants. This is a very experienced in this therapy audience and many heart failure experts and many implanters, many specialists in imaging. So any questions from the participants? Kostas?
Mike, thank you. I believe that there are still non-believers of mitral TEER. I remember about a couple of years ago in an online survey, about 30 to 40% of cardiologists were not convinced by the COAPT results, and they were still questioning this therapy. So if COAPT was so successful and was so successful with a remarkably positive result, you would expect these results to be replicated by other studies. If you don't replicate it, then it will be just a chance result. So I have the same expectations like you two guys have, to have a positive trial in some events. I'm not necessarily mortality, because the mortality events are lower. Stefan explained to us why, lower risk patients. But I would expect to see some effect on hospitalizations, quality of life, at least. And I'm optimistic in that, but of course, we have to finish now the extended part of the study, and like Stefan said, I would like to plead to all our colleagues who are here and they have patients they believe that they could be recruited and randomized in this final part of RESAPE to refer them for enrolling them into the study. I know now it's more difficult to do that because this treatment is very embarrassed in Greece, so it's not as it used to be a few years ago. But there are still patients that we are uncertain about what to do ourselves. So I think we should complete this trial successfully and have another attachment for this therapy.
Now, there's Kostas, maybe we should also add, with the plan of finishing the recruitment when we have at least 500 patients, and with the plan to report next year, it means if you recruit patients in the next 3 months, their time in the trial will be between 6 and 9 months. And you might say that almost means after 9 to 12 months, you have a permitted crossover if you still think it's necessary to treat. So the randomization for these patients will not be to get or not to get a mitral clip forever, but it will be to get a mitral clip now or to get it in 9 to 12 months if they need one.
I think that this gives also another idea what you, Stefan and Kostas just said, because as Kostas suggested, now it becomes more and more difficult because this treatment is getting reimbursed in Greece, and slowly but steadily the implantation rate increases. And I think that something, I don't know if it should be pre-specified or not, but it would be nice to see if the patients that have been recruited later have different characteristics from those recruited earlier, and if the results in this patient is different from those that have been recruited early in the trial.
That is definitely something we will do, not only from a time perspective, but also from a device perspective, because over time, of course, there was progress in the different generations of the mitral clip. So definitely the answer is we will do that.
Okay, any other questions, Kostas, from the participants, from the colleagues?
Any comments from the floor? Yes, Dr. Christoheris has a comment.
So Dr. Christoheris is an expert in imaging with huge experience in this field.
Yeah, my question is, with functional MR, we have a sense in clinical practice that some patients, really they behave like with a malignant type of functional MR, where they have significant ERO, significant regurgitant volume. As you go into the left atrium, you have the giant V waves. For some patients, there is a subgroup of patients which may be picked up more in the COAPT study that really have a more severe form of functional, I would say dysfunctional MR. Whereas in the MitraFrance study, we have patients with a more moderate type of MR which is more quote-unquote benign maybe. So I think part of the problem is that this severe type of MR that is picked up by co-op study maybe should be renamed in a sense, in a particular way, maybe should be designated with a different way rather than just functional MR, because it really is dysfunctional MR. It's something that's more malignant, more behaving more hemodynamically in a difficult way. Thank you.
I think you are hinting at something that is very important. We still haven't fully understood why is there this big difference in the results of co-op versus mitral FR. The mortality, as I described to you at 1 year, is similar. The results of the trial are very different. Who knows what is the reason? Now, we need to not forget one little issue. Whatever is the reason for the particular benefit in many patients in co-op, we haven't been able to figure this out by echocardiography measures. There is an echocardiography sub-study, and there's not a single of the many different echo parameters measured in these patients. There's not a single parameter that was able to predict the benefit. So whatever it is, we haven't figured it out really yet. Maybe with the addition of the ReShape-HF2 trial, which by the way is using an echo core lab, and Stefan von Badeleben in Mainz, very experienced echocardiographer and interventional cardiologist, and he runs, by the way, also the EuroEcho journal. So really, we hope that maybe then together these trials can shed some light on this.
So, thank you very much, Stefan. Thank you very much, Professor Ranker. Looking forward to see you soon in Athens and, of course, in Prague in the Heart Failure Association meeting. Thank you very much for being with us.
Thank you. Bye-bye.
Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known, proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
ladies and gentlemen. I would like to welcome you to this TAVI complication session that is very important in valvular heart disease. On behalf of Professor Michalis and Dr. Dimas, I would like to welcome you also. And we start from the first speaker. I would like to invite Dr. Kalogeras from the Sotiria Hospital. In the first topic, unexpected TAVI complication at the heart level. Dr. Kalogeras, the floor is yours.
Good evening, ladies and gentlemen. First of all, I would like to thank the organizing committee and especially Dr. Sparias, Dr. Patakos for the kind invitation to participate in this very interesting roundtable regarding TAVI complications. So we start with the unexpected TAVI complications at the heart level. And when a patient comes to us and before going to the cath lab, we give him the consent form to sign, and what we usually say, we report a mortality rates of about 1%, 30 days mortality, stroke 1 to 3%, conduction disorders, pacemakers 5 to 20%, depending on the device, and vascular complications around 5%. Is that all? So in total, TAVI complications have to do with vascular complications, paravalvular leaks, embolization, migration, strokes, conduction disturbances, coronary obstruction, annulus rupture, but some of them are at the heart level. Are all of these complications really unexpected? So let's see them one by one. PVL, it is considered to be a TAVI complication as it has to do with annulus calcification, shallow and or deep implantation, patient's annulus prosthesis mismatch, but it's not a really unexpected one, as it's very common, and we know how to prevent it in most cases with correct and annulus measurements, appropriate sizing of the prosthesis, optimal implantation technique. We know how to treat it with balloon post-dilatation, valve or snaring. So when we really talk about unexpected complications, and we can see also severe PVL, device embolization or migration is a really unexpected one. And when we are talking about migration, we mean upwards or downwards movement of the valve, but always within the aortic annulus. Embolization is when we actually lose the contact with the annulus. From the pattern trials, about 1%. It's quite rare. It causes technical factors like malpositioning, too high or too low implantation, undersizing, failure of the pacing, manipulation after the implantation, or even the first generation devices had more migrations. Anatomical factors like horizontal aorta, the prior mitral biprosthesis, or bicuspid valve have been associated with this complication. The mechanism, usually it's spontaneous embolization into the aorta, called as pop-up, migration into the LV, or incomplete release from the delivery catheter, or embolization during the post-dilatation. From this trial, it was found that the horizontal aorta, the implantation of a self-expanding valve and low ejection fraction, these factors were identified as independent factors to predict embolization, which the final position of the embolized devices, usually 8 out of 10 cases, was in the ascending aorta. And as expected, this complication was associated with high mortality rates, especially during the first days. And if it happens, what we can do, first of all, to keep the wire in position. Bailout strategies, it depends on the urgency of the situation, and if the patient is hemodynamic compromised, if there is a coronary obstruction, and where exactly is the device embolized. If it's embolized into the LV, then mostly performed, this is faced with an open heart surgery. If it is embolized in the ascending aorta, in 80%, then it can be percutaneously managed either with snaring a self-expanding valve or with balloon inflation of a balloon expandable valve. And as we can see here, the 30-day mortality is higher when you have to use a second valve, and even higher when you have to take the patient to the operation theater. So in total, either when the valve is moving towards the aorta or when it's moving towards the LV, 8 out of 10 cases, this happens during the procedure, 15% during the first hour, and there is a small amount of cases happening delayed after the first hour. And as expected, the mortality rates are higher when the embolization is towards the LV. How to prevent it? With correct measurements, pre-procedural planning, selection of the appropriate device and device size, accurate deployment techniques, and adequate temporary pacing during the implantation. But it's really an unexpected complication when it happens late, even after the day 2, and it's associated usually with cardiogenic shock, disruption of the mitral valve function. It's correlated with limiting anchoring of the prosthetic valve because of lack of severe calcification, or when we deploy a small valve for the annulus of the patient. We have to suspect a late migration where the clinical condition of the patient deteriorates suddenly. And here there is a case we had recently in our lab after implantation of a self-expanding valve. There was at least moderate PVL, so we did a post-dilatation, and immediately after, the patient deteriorated severely with hemodynamic compromise, and the valve, as you can see, has dived into the LV. The first measure was to try to snare it. However, at the end, we have to put a second valve, valve-in-valve, and the result was better, and the patient actually improved rapidly. Conduction disturbance is another complication. We know that the His bundle is close enough, 6 millimeters. However, these disturbances may resolve with time due to the mechanical injury or ischemic injury that can go away gradually. The most recent devices we know that have lowered the pacing rates, even at 10%, 11% for self-expanding valves. It is well known that during the first couple of days, we have the highest rates of pacemaker implantation, but even later this can happen. As you can see, until day 15 or even 20, we can see conduction disturbances. The patient might need a pacemaker. This study, out of 1,060 patients that were discharged without a pacemaker, 6% of them needed a pacemaker after the discharge because of syncope, which was the most common symptom. And factors like LBBB, first-degree AV block, and valve-in-valve were the independent factors that were associated with need of late pacemaker. Coronary obstruction is a rare and potentially catastrophic complication. It can happen acutely or delayed. Balloon expandable valves and valve-in-valve are associated with high rates of coronary obstruction. This can happen because severe calcified aortic root and the combination of shallow sinus of Valsalva, less than 30 millimeters, and low coronary ostium high, less than 12 millimeters, have been associated with a higher possibility of coronary obstruction, which can happen due to displacement of the calcified native valve leaflets, or even due to direct occlusion of the coronary ostium by the skirt of the valve. Most frequently happens in the ostium of the left coronary artery. The patient can have hemodynamic deterioration, ECG changes, and as you can see, for the left coronary artery, for men, less than 11 millimeters is quite dangerous. What we can do when we detect a patient that it's high risk for coronary occlusion, during the pre-dilatation, we can combine with simultaneous aortography, which can show us if there is a danger, really danger for the coronaries, use of protection wire, and even better, a protection wire with a stent already loaded. If occlusion happens, we have solutions like snaring the valve, trying to pull it out and free the coronary. The chimney technique is another technique when we can use long enough stents, which should come above the most superior portion of the TAVI leaflet. And basilica is another more complex technique for valve cases when we can free and the coronary ostium. Here again, delayed coronary obstruction is quite unexpected complication, usually with self-expanding valves. As you can see, they are reported in some cases. And finally, the annulus rupture, another complication at the heart level. It has to do with the so-called device landing zone, which is the aortic root, and the LVOT is formed by these two. It can cause from injury either in the aortic root or the LVOT during the balloon pre-dilatation, during the valve deployment, or the post-dilatation. Clinical symptoms depend on the location of the rupture and how extent is the injury. So the patient can be even asymptomatic if it's a very mild rupture, or it can be a really catastrophic event with pericardial tamponade, with hematoma between the aorta and pulmonary artery, new aortic wall thickening, VSD, conduction abnormalities. All this can happen. Predictors of annular rupture can be the oversizing of the valve, more than 20%, calcification extending down to the LVOT, subannular, post-dilatation, the annulus eccentricity. All these are predictors and predisposing factors. This is a classification for annular rupture. As you can see, it's divided intraannular, subannular, supraannular, or even combined. And what we can do if this happens, so if it's mild and really asymptomatic, conservative strategy, if we're lucky enough, pericardial drainage if there is a tamponade, or open heart surgery if the rupture is bigger. And this is a case a few years ago during my fellowship. This was a self-expanding valve which was recaptured and then re-advanced across the annulus. So a few minutes later, there was this massive rupture of the aortic annulus going all the way up to the aortic arch. So despite the ECMO team came in the cath lab, the patient survived a few minutes. There's nothing you can do. So finally, the take-home message: unexpected TAVI complications are rare, but often they are devastating if they occur. We always have to keep them in mind and be ready to face them. Of course, patient selection, the increased operator experience, and the improved devices that we have nowadays are the key points to prevent them from happening. Thanks a lot.
Thank you very much, Dr. Kalogeras, for your nice presentation. I think the take-home message is very important. We have to study very carefully each patient in order to prevent the complications. I have one small question for you. Do you prefer embolization of the TAVI to the aorta or to the LV?
As I saw, the mortality rate show that it's better to embolize towards the aorta, but there is a danger of occlusion of the coronaries if it happens. So if you're lucky enough not to occlude the coronaries, or if you manage to pull up and snare the valve immediately and to free the coronaries, yes, it's better to go up.
Okay, thank you.
If we are talking about embolization, so you lose the contact with the annulus.
Do we have any question from the audience?
Thank you very much. Let's now proceed with the second presentation. This presentation will be given by Dr. Latsios from the Hippocratic Hospital. It is entitled Unexpected TAVI Complications Outside the Heart.
Hello, good afternoon from me. Also live, because this morning I couldn't come to the place, which is a tremendous place. Thanks and congrats to Kostas Sparias, Stratis Patakos, and friend Kostas Stathogiannis, because as I said this morning, TAVI and interventional cardiology and medicine is an art, and there's no better place to exhibit art than in a national art gallery. So I'm going to keep saying, Kostas, as long as you do this congress here. And let's try to be a little bit didactic. Didactic meaning, excuse my cough, experiences to learn from other people's mishaps, mistakes. So let's go. What are problems that can TAVI cause outside of the heart? Problem A, you can have stroke. Some embolic debris when you cross the arch, also in the diagnostic cath, when you balloon, when you place the TAVI, can go, travel through the carotids and embolize in the brain. Fortunately, this is quite rare in Greek experience. It's not that rare in worldwide registries. It happens in something like 2%. Half of that happens peri-procedurally. And if you be, and your patient, unlucky enough so that this happens, that puts up your mortality up to the stratosphere, like 5 times more mortality. So you have to avert embolic stroke by all means. What can you do? Well, the idea is you occlude, semi-occlude from the debris, the carotid arteries, and things cannot get through. This was the idea behind all sorts of toys. I like to say toys, all these things. The most common toy was the Sentinel device that put through the radial artery 6 French sheath two baskets in the two carotids, and then you collect debris. Unfortunately, the first randomized trial in 3,000 patients could not find something positive out of it, could not avert embolic stroke, also in various subgroup populations, which probably are better. So just pray. We tried this. See, we tend to use it in bioprosthetic prostheses that have degenerated. We fear that these are more troublesome in terms of stroke. Here you see not such a good surgical outcome, a very deep prosthesis. We had to put a valve in, and we had to put also on sentinel, and we fished two small things out that could have gone to the brain. Problem B, also very rare. What happens if you have a bleeding post-TAVI on the immediate period after the TAVI? If you have this eponymous, this namely syndrome, that's called Hayes, you have angiodysplasia and you have aortic valve stenosis, so-called, you'll have no more bleed when you fix the valve, but you can have bleed during the TAVI in a 25%. See here, if you have the syndrome, you have 25% GI bleed during the first 48 hours of the TAVI procedure, and you have to know what to do. And also you have a serious, in this elderly population, 2 to 3%. What you can do, you have data. Data shows that you can safely, if you fear, omit one of the two antiplatelet agents, and you have either clopidogrel or NOAC in this, or in the people that you are afraid that are high risk for bleeding. So you have decreased your chance of bleeding if you give them less poisonous antithrombotic treatment. And this is the main talk, and also my favorite subject to talk, not to happen. What happens if you have peripheral access complications? We tend to attack all these elderly, frail 80 or 85-year-old patients with, used to be 20 French sheaths, now there are 18, now there are 14 that expanded to make holes 20 French, but we say there are 14 French sheaths, and then we have to close them, and I'll make some comments on that. Comment A, peripheral complication in frail patients with calcified vessels with 14, 16, 18 French sheath are here to stay, unless we tend, and this is never going to happen, to tend to have TAVIs 8 French sheath compatible. And then, where is Stratis Patakos? I've heard that in the same Congress 10 years ago, and I never forget it, we'll put TAVIs transnasally, okay? And this is a very interesting motion from Stratis. So, complications do occur, also in the STS huge registry. In a percentage, major complications, about 10%. Major meaning you have to transfuse your patient, you have to operate on the patient, you have to put stents on the patient, you have to do something on the patient that prolongs hospitalization and also perhaps increases mortality. And increases mortality not only during the TAVI procedure, but if you, let's say, you had a perfect TAVI procedure and they had to put 2 units of blood in the patient, that's, say, the registry, because of all the thing that led the interventional cardiology community to go from transfemoral PCI to transradial PCI, that thing, the bleeding, the transfusion, has made the patient susceptible to twice the possibility of dying of something during the following 2 to 3 years. So, and you see the curves tend to go apart just because you've transfused these TAVI patients. So you have to be very, very focused and lucky to avert peripheral complications. And the picture says here that access and closure is not a walk on the park. Okay, it causes problems. Problems can be bleed. Problems can be occlusion. Problems can be bleeding and occlusion. And let's see some stuff. What we always forget, and we tend to forget, and we do forget, and this is not something to forget, is that 1/3 of all vascular complications are caused by the small, innocent, helpful other side sheath. You put a 6 sheath in the contralateral femoral artery to be safe, to do angio, to do something. And that causes 1/3 of your vascular complications. If you choose, not easily, but if you choose to have as a second access a radial artery, you take down your vascular complications by almost 40%. And there are data from the UK, from the US, from Greece. So it puts a little more cumbersome an effort in our side, like the same idea, let's try to change transfemoral PCI to transradial PCI, but it gains in bleeding, gains in lives. So the other question is, okay, why to bother to access an 18 French sheath and to close an 18 French sheath? I have perfect vascular surgeons that do perfect vascular surgery, complication-free. This is a myth. This is a myth taken down by the vascular surgeons themselves. The vascular surgeons randomized themselves in TEVARs meaning 20 French sheaths, either to operate and close by direct sight and direct suturing, or by using toys, by using instruments. And they said there are either no difference, or in other trials, there are even better outcomes when the vascular surgeons do not operate, but they use stuff. That's why in over 500 patients, all of them in the Partner 3 trial went transfemoral by interventional cardiologists, and also data from Greece, to be proud of our country, of our friends like Kostas Stathogiannis. How to puncture? There is this ongoing trend, abandon angiography, abandon fluoroscopy, and try to puncture by echo. It is a great idea, and like all ideas in the beginning, we are all happy and we all want to, take it in and substitute something that causes us problem. It's the access that causes problem. It's not the fluoro in access that causes us problem. So the initial slides, the initial data showed that perhaps it could help, but as the numbers increased, and you know what they say in statistics, when you increase numbers, you tend to go to the truth. Like when we went to 12 to 1,200 patients, there was no difference in complications by either seeing by fluoro or seeing by echo. So I suggest use, at least in your 21st cases, the method that you know better. And let's see some slides to have, not to sleep at night when you see that. A very unusual complication, because I cannot understand the idea of expected complication. If you have a complication, it's unexpected. Otherwise, don't do it in the first place. So this is an unexpected complication. It was a severely calcified femoral artery, and we pulled out the sheath to suture the proglides. The top of the sheath remained in, so we had a PTFE covered stent in this artery. This is now almost 10 years, no problems at all. The patient doesn't know. In order to avoid complications and to be only unexpected, not expected, and this was said by many people and described, and when the sheaths were larger, it was the routine practice. We went crossover on through the radial. We occluded the femoral artery with an over-the-wire balloon where we could inject contrast. When we had a very, very dry, where are surgeons, a very dry surgical field to deal with the arteriotomy puncture site. And also, if wanted, we could, cross a wire and then cross whatever we wanted. So we used to do that routine, not anymore, as the sheaths went down and the experience went up. And see some horrible pictures. This is a long, long time ago from another country where I was. That time the ProStar needles didn't fully work. Crossover, very small sheath compatible, it's French compatible covered stent, went over and occluded the artery. Okay, that guy cannot or should not bend that much the leg, but it was 78 years old. And not to be prejudiced in favor of any instrument, I'll show you also something sort of the same with a proglide. We put two proglides in, occlusion of the femoral artery due to the proglides, and then we went through the radial artery. It was a short-statured lady, and we done normal coronary equipment, coronary angiography, just a balloon with restoration, a perfect restoration of flow with instruments and techniques we know from interventional cardiology. Also, collagen-plugged devices can cause various problems. Here we see they just don't always work as advertised, as expected, as wanted. But then again, we have, we have a good result, trust me. And also this was 2 weeks ago. Things we have to know in advance in order, in our panic, in our patient bleeding to use. Here we have a severely occlusive bleeding manta puncture site, bad. to make it even badder, even worse. We could not crossover, and trying to cross, we sort of perhaps dissected, perhaps occluded more proximally the vessel. And then at that time, we went and we punctured without pulse more peripherally, like 2 to 3 centimeters in the mid to upper thigh. We put a sheath, and then retrogradely, we crossed like our colleagues from CTO do. We retrogradely crossed the occlusion, went in the ascending aorta, and then it was easy. We've ballooned, we've stented, and in 20 minutes, the patient was back in our bed with that final result. And it's easy as long as you have the knowledge to do it beforehand. Having that, thanks once again. This is a picture ske from my hometown, Larissa, and also from Kostas. Thank you.
Thank you very much, Dr. Latsios, for an excellent presentation with clarity and pinpoint documentation. Thank you very much for sharing your mishaps and giving us insights how to avoid them. I will ask a very simple question regarding non-vascular bleeding. What is your antithrombotic regimen for TAVI procedures?
Okay, that's a very good question and should be heard in the audience. We give normal heparin dose, 70 to 90 units per kilogram, and we measure ACT, we should be above 250. Some of the times, if I may advance a little bit the question, and that message comes from trials, comes from the last MANTA versus ProGlide trials. Our German colleagues do routinely what we anecdotally do. Like in all of the cases, they reverse the heparin. Half of the cases, they half reverse the heparin. Half of the cases, they full reverse the heparin. And we should at least think about it before suturing the leg. I know the objections when you put a valve and then you have some contrast staining in the NCC cap. That is prothrombotic, and we should avoid it. But it is a tool to reverse, to safely reverse the heparin that we should have in our mind and in our armament.
Regarding the use of protection devices, you use them frequently?
No, because we don't have the data to support a routine use of protection devices. Anecdotally, we tend to use them, not based on any data, when we believe there is increased thrombotic risk. A, if there was a previous embolic stroke. Okay. B, if there is a very degenerated bioprosthetic prosthesis.
So there is a very selective use.
Yeah, without based on any
even
data.
rare use.
Without based on, and also without based on any data.
Okay. Any questions from the floor?
Thank you for sharing also your complications. So it is very good. So my question is regarding your last case. For example, don't you prefer to put a safety guide wire after ProGlide insertion? Because if you don't put a safety guide wire at that kind of complication, this is a very good example for this, because it is not possible to recross from contralateral side. So if for example, you have put a safety guide wire there will be no need to puncture the POBA. So I think before the procedure, it's also very important to examine the femoral artery anatomy, and if posterior calcification is present, for example, like in this case, contralateral safety guide wire is a very good option not to leave this complication.
Thank you for the suggestion. This is an excellent tip that should be discussed. There are people and TAVI groups in Greece and in worldwide that routinely do that. There are some arguments also against. The pro-arguments, when you have a problem and you have a wire, it makes your life easier. Arguments against are, A, I'm not that sure that the safety guide wire always remains untouched by the sutures on the MANTA device. Arguments against B, I don't know if you use a 6 French or a 7 French sheath contralaterally to be able to put the wire. If you use a 7 French sheath, which our colleagues in our hospital use, I tend to disagree to increase the French sheath size in these 80 or 85-year-old people as long knowing that 1/3 of the vascular complications come from the contralateral side. And also, I've shown this complication because it was the first time after almost 800 procedures that we were not unable, like you have to deal with such a complication if you cannot go undergrade. Like you have a 10%, let's say 10% vascular complications, half of those are occlusive, so in 5% of your cases you have to put a wire across. In 800 cases, it was the first time we were not able quickly, easily, and effectively to put a wire across. So, you know, to routinely use a crossover 6 or 7 French sheath to avoid 1 in 800, it needs merit. On the other hand, for people, for teams starting their program, like the crossover balloon, it is a very, very good choice in the 51st cases to be safer when you put the valve. But it's a great trick.
Not a crossover sheet, but crossover guide wire.
Yes.
And over that guide wire, you can send, for example, Navicross catheters, like peripheral catheters, and then put a stiff wire, and the balloon always work. Even graft stent also always work. So there is no need to put destination sheet or another sheet. But I agree with you, not routinely, but in selected cases. Thank you.
If there are no more questions, thank you very much, Dr. Latsios.
Thank you. And we move on in the next presentation from Dr. Panoulas from Royal Brompton. The topic is complications that can be detected and how to prevent.
Thank you very much for the kind invitation. Thanks for having me, and thanks to the organizing committee. I want to apologize. I'm currently in Minneapolis. I'm visiting an ECMO program. That's why I couldn't be with you today. But I hope I can share some of my experience. I'll try to just show mainly videos from complications rather than bore you with the literature. I work both in Brompton and at the Harefield Hospital. And I think I do around 150 TAVIs every year. So it's quite a high volume center. I've also been a lead author in the complications section in Up to Date. So I'm not going to bore you with statistics and numbers. I just want to show you pictures of things that I have come across over the years. This is a complication that's something that we are going to see more and more in the future. So this is someone that had a TAVI 7 years ago, done by an operator that decided to put this Evolut valve quite high up. So as you can see here, this person comes to us with an STEMI and some nasty chest pains. And the first thing you do when you have a TAVI from the past is do a little aortogram and see what on earth is going on. So as you can appreciate, tackling these coronaries is going to be quite a tricky thing. And here I show you, this is a CT that we took. You can see that there's no commissural alignment. And if I don't want to necessarily play the video, I just want to show you some frames. So as you can see here, this is the ostium of the left main and the ostium of the RCA. And you can see that there's the whole valve has already got a little bit of pannus inside it that makes it impossible to cannulate these two ostia. So I'll move to the next picture. There's a 3D reconstruction of how the valve is sitting. And obviously, you remember this is a supraannular valve, so that kind of adds extra complexity. Here, we're trying to get access to the right coronary, which is quite impossible. On the left picture, you see the wire trying to loop in the coronary sinus and then into the left main in an attempt for us to go with guide liners to try and find that slit passage that's going to give you the best imaging. And, you know, in the end of the day, through this, we managed to get a guide liner to sneak through and do the ballooning and the stent of the proximal LAD that was the culprit. But I can guarantee you that was not a fun and not an easy procedure. So that's something that could have been avoided. The operators could have put the valve in a lower position and also use commissural alignment to make the life of future operators a lot easier. This is a case, I don't want to tire you with the actual comorbidities of this gentleman, but it's a case of a 71. I had some comorbidities on a previous mitral metallic valve that came for a TAVI. This is a case I did a very long time ago in Milan when I was a fellow back there. And, you know, it was a relatively straightforward. We were used to do all our CT reporting back there. You could see Yeah, severe aortic stenosis, quite fibrotic as well. In fact, there was not a massive amount of calcium. It was a suitable valve for a 23 Edwards or a 26 Evolut. We did our own CT measurements back then, so I used to do everything in a software called Osiris. You know, you look at the iliacs, some tortuosity, but nothing incredible. So we go ahead for the procedure. Happy as always, previous patent grafts. You can see here the previous metallic valve, and you can see it was a mixed aortic valve on AR. Not much calcium, as you can appreciate. And then it became very clear that as we were trying to get this procedure done, it was very difficult to get from the groin all the way up to the aorta. We used some funky wires. One of them is called Stork and has a hydrophilic tip. And you can see that we have radial axis as well to kind of see what's going on. And as you can see, there's a little unfolding bend in the level of the descending aorta, where it's thoracic descending aorta, where it's joining with the arch. And at some point, I actually said to all the operating team, let's pause and go back to the CT and see what on earth is going on here. And this is what it was. It was a pseudo-coarctation. So I'm sure you can appreciate the unfolding of the aorta, and that made it extremely difficult. There was no great invasive gradient as such, that's hence pseudo. But this is something that, you know, if most operators pay a lot of attention to the annular side and to the peripheral sides, the groins, etc., and sometimes we tend to forget the thoracic aorta. And this was just a case to show to people that, you know, if you had this in mind, maybe you could have chosen an alternative access. Maybe you would have gone from a subclavian or axillary access to make your life a bit easier. And this is something just for people to be aware that it exists, and it can make your life a bit of a misery. So here is our attempts to manage to get it through. We tested that the balloon goes through as well, and in the end, we managed to get a delivery system up there with some push and a Lunderquist wire, which is a stiff wire that we have. And as you can see here, it does go through with some difficulty through the pseudo-coarctation, and we managed to get it down to the good position and get a decent result. But since that case, I have managed to follow through the peripheral vasculature all the way in the abdominal, the thoracic aorta, to make sure that I don't miss any weird kinks. So this is the final result, and that was good. Annular rupture, I think Kostas has spoken to us about that very eloquently before. It's a very devastating complication. Sometimes, you know, you should have known better, as we say in the UK. If you see lumps of calcium in the LVOT, you should definitely not go there. But there are cases like this one, for example, that there is calcium in the quite bulky calcification in the leaflets of the aortic valve. And sometimes this is something you don't necessarily expect. So here we had an annular rupture and a tamponade, and then we had to use, obviously, a drain as an emergency situation. This is one of my colleagues' case, but as you can see here, we did what we use these days very frequently is a substance called Surgiflow, where we drain the pericardial effusion and then we inject the Surgiflow. It's a thrombin inhibitor matrix, and it tends to clot the holes as well as possible. But this particular case, as you can see there in the red, left that patient with a small pseudoaneurysm that in follow-on CT was smaller, but that's a scary complication that I think, you know, you send people home, you manage to get them out of hospital. Surgeons are never interested with these cases. But then the question comes, what if happens if that pseudoaneurysm breaks in 1 month's time? So we tend to keep a very close eye on them with follow-up CTs to make sure that pseudoaneurysm tends to heal and thrombose. Now, another case, we have a percutaneous axillary program, so I try and do quite a lot of cases that are alternative access and they have no access from the groins through the axillary. This was one of them, and we don't use cut down, we do it percutaneously. So you can see there a very big S-bend at the level of the left subclavian, which made our life a bit more difficult because you needed a stiff wire. And of course, to do that, we used a Lunderquist wire. And whenever you lose a Lunderquist, you're always in danger of perforating the LV. But even though we used a wire called double curved Lunderquist that has a pre-shape, so I will show it to you in the next slide. So this is us crossing. This is the double curved Lunderquist that looks like a nice normal wire. However, by trying to tackle this S-bend further up, there was a lot of pushing and pulling on the wire to try and get the valve to negotiate that and come to the right height. And I think that's probably when it happened, because we managed to do the procedure. The patient was up to there quite stable. We had the valve in with a very decent result. And as you can see here, closure, absolutely no problems. And in fact, when I finished the closure, the pressure started slowly going down, as they often do when you get a tamponade in TAVI. It happens after your closure. And initially I thought, could we have a leak there in the axillary access? But as you can see, it's extremely dry, and we used 2 prostyles and 1 angioseal. That's the kind of routine. Very neat. There was no hematoma developing. There was no extravasation of contrast. So the next thing you do is you look at the pericardium, and surprise, surprise, we saw that effusion. Again, we went in, we did a pericardial drain. I did a drain straight away, and then when I clear the effusion, I inject this Surgiflow. It comes as, you can prepare it. You have to actually agitate 2 syringes and then immediately inject it into the pericardium, and then flash it with 2 mLs, and then you get a very good seal. So there was no reaccumulation of tamponade. And here you see the echo that was 3 days later with some mild paravalvular leak and very trivial pericardial effusions in there. So that patient did really well. As you can see, we don't use any more RV wires for pacing. We pace everyone through the LV wires. So we know that when we have a tamponade in a self-expanding case where you did not pre or post dilate, you are 100% sure that what caused the tamponade is your wire, your LV wire, and nothing else. Which is a very good thing that you can differentiate what's happening. Coronary obstruction, again, coronary obstruction is a real thing and can be very scary. Again, Kostas mentioned a few things about chimney stenting for prophylaxis in these cases, and basilica, which I think, let's all be honest, no one's really doing it in routine practice, and I don't think will ever become available widely, despite new devices that they tend to create. This kind of mechanism of burning leaflets sounds extremely scary to me, and I think even in most very experienced operators would not be very keen to take it on. Here we have a case that the left main to the annulus distance was 14 millimeters. So, one of those, decent size sinuses and a very decent distance, where we went with an Edwards. Heavy calcification of the leaflets, of the TAVI leaflets, however, and that is something that I think needs to be a take-home message from this case. And we learned from this case. This was not mine, but a friend operator that did that, but also increases the awareness in the whole TAVI team. So this is an Edwards going up with very bulky calcium. You can see here how occlusion of the left main straight away, patient going into PA cardiac arrest, and immediately positioning of an impella to keep things going and tackling the left main, as you can see here. The support obviously with the impella alone in someone which was, as you can see, nearly in asystole was not fantastic. So then they had to upgrade this patient to via ECMO on top of the impella, opened up the left main, and in fact he has survived and made it through despite this horrific complication that I think would scare even the most experienced operators. Now, and as I said, we finished off with an ECMO. This is a case I did about a month ago, and this is something that will come more and more often. This was a high implantation of an Evolut 26, and now we're putting a valve-in valve, and this is something that's going to be our future in the TAVI procedures. The reason you see 2 stents hanging out there is because I want to protect both ostia, because the previous valve had no commissural alignment, and there was distances of the ostia to the neo leaflets of the core valve were only 2 millimeters. So mathematically, it would be probably 100% certain that by putting the Edwards in there, I would probably occlude both of those ostia. And then we decided that, we don't want to take that risk. This is a lady that's 86-year-old and had torrential AR to start with from a degenerated Evolut that lasted 7 years. And we thought, better safe than sorry. We just had deployed the 2 stents, chimney stents on the Edwards, and we managed to get a very good result. She's doing well now, and no problems at all, no issues at all. And I think it's not worth taking the risk. Valve embolization is a real problem. And no matter, how much you study the literature and how much meticulous you are with your approaches, it's always going to happen. This is a a case of a Navitor valve. I've been trying this valve to see, because I'm mainly a Medtronic Evolut and Sapien user, but I want to also check this out. This valve has a fantastic flexibility, so it can go up anatomies that are extremely tortuous. However, what is the trade-off? The trade-off is that it doesn't have particular radial strength, and this is a case. It was in my early experience with it. I even had an experienced proctor next to me, and I'm a proctor for Medtronic, so I have big patience and very meticulous implantation techniques for those valves. We did it very slowly, and as you can see, the first clip on the left side, there is a perfect position for this valve. In fact, I would argue it might be a bit deep. But then I just noticed that it's a bit eccentric. And this was a fibrotic aortic stenosis, very tight fibrotic aortic stenosis, which we pre-dilated quite aggressively, as you saw. So it's not an aortic valve that we did not pre-dilate. But it became apparent to me without moving anything that this valve started migrating on its own, slowly upwards. And you can see here that I'm very cautious in taking the nose cone out. In fact, I sinnate, and you can see it in the top left picture, because I knew someone will come back and tell me, your nose cone catch the valve and it popped up. But that's not the case. You can see it there, it's still there. And then slowly, I just take clips, as you can see. As the time goes by, you can see this valve just migrating upwards and eventually popping up. I mean, this was extremely distressing for me, because if you remember, I started at +5, and then I end up with a valve that has completely embolized the ascending aorta. And here you have it. And obviously, when that happens, you start getting problems with coronary perfusion, you start getting torrential AR, and patients really don't like it, and they start being hemodynamically very unstable. So obviously here we had to run, and then snare this valve and put a new one in. You can see in this second picture how far up it is. I mean, it's quite impressive, the distance between the annulus. I'll just pause it so that people understand. So here's the annulus, and here's where the valve has ended up, which is quite a long, far away. So what we did is we had to obviously grab it, snare it. I mean, thankfully, it's an easy valve to snare, a bit like the core valve. And then through it, we went with an Edwards valve, and we managed to get a good result. However, this is a complication that could have been avoided should I have used the valve that I'm, used to and I have the most experience with. But equally, it's a complication that up to this very day, I spoke to the chief medical officer of Abbott at that point, Neil Moat, and we still haven't quite figured it out. But then the main answer that I got was because the annulus was very fibrotic and very eccentric, it managed to squeeze this valve upwards. But that's a complication that it's difficult to comprehend, and it's a complication that stresses the operator a lot and quite unnecessarily, because you could have argued I go with another technology, I wouldn't have this issue. But pop-up is always something that can happen. It doesn't happen often, but it's something to take into consideration. Now let's see. Yeah, that's kind of the final shots that we had to make sure also we don't create a syndrome. This is another case done by one of my fellows. I just want to show you that if you have a lot of push on the wire, you can see there on the right picture, then the nose cone tends to jump up. So this wire is very pushed in, and it's pushed in because they wanted to have the system horizontal. But you can see how when you release the valve, the nose cone pops out, and that's a risky situation to take the valve out with it. They were lucky on this one, but that luck runs out at some point. Vascular complications, Dr. Lachos already alluded to some of them, but I just want to highlight a couple that are normally the most stressful for us, for the operators. Again, this is fellows that are doing the procedures. One of them is quite experienced, had a year of experience, but reassured me that his puncture was excellent with echo, but clearly it was not excellent with echo. It was a very deep, very high puncture in the external iliac. And when you do a puncture in the external iliac, most of your devices are not going to work because they're not coming perpendicular to the vessel. So this is one of them. And clearly you have a MANTA device that is not well deployed, and you have active extravasation of contrast into the pelvis. And this is a situation that your hand cannot compress that. So you just have to run in there and just put a cover stent as fast as possible, because obviously you have crashing hemodynamics, pressures go down in like 30 seconds or so. And that's what we did. We decorated this person with covered stents. I think we used the fluency covered stents here that are self-expanding. And normally with these situations, you just want to go as generous as possible, use the biggest self-expanding cover stent as possible to make sure that you have covered the hole and you don't have any other issues. So here we did a bit of a reconstruction. And in fact, that gentleman went home a couple of days later. So I didn't really give him any comorbidity, but it's a complication that obviously can be avoided with meticulous puncture techniques, knowing your ultrasound. And yeah, ultrasound, people talk about it a lot, but it's a difficult thing to do, and it takes time to get very familiar with it. So I personally use it as first line. I never screen my hands anymore as we used to do in the past. But it does take quite a few years of experience to be very proficient and be able to follow the tip of the needle, as I say, rather than, start wiggling with your probe and trying to understand where is your needle. This is another case where the manta was inserted too deep. So if you don't have a good manta technique and you don't anchor it very well, what you end up doing is you end up pushing the whole plug inside. So a lot of people comment that manta is like an angioseal, it's very easy to do, and then they ended up putting it in the vessel. And when you do that, you have this picture on the ultrasound. So you can see here this white mass inside the artery. So this whole thing is the manta that is now occluding the lumen. And with these cases, the only easy way out is basically to go retrograde wiring, because that's where you have the majority of the force, with either a slippery wire, or if you cannot not achieve that, you can use a coronary wire with a balloon support, and that always does the trick. And what we did here, we did that, and we put the self-expanding stent, and we post-dilated it, and we managed to get a very good seal, as you can see there. But you need to be proficient again. And then recently, I just wanted to show you a pseudo occlusion case where we had a stiff wire. I think that was a Lunderquist wire. And we basically straightened the bends of that iliac. And here, if I just play that picture, we were all like in the cath lab saying, I was thinking, because there were fellows inside, it's like, oh my God, you have done it again. I have to go in and start, anterograde wires or retrograde wires, trying to opening up this vessel. And I keep telling my fellows, I don't care what you do with a manta, just don't put it in the vessel. That's the worst thing you can do. That's the only situation that I don't have another bailout. If you put it a bit further out, you can still push it in. There's a lot of techniques you can do that, but please don't stick it in the vessel. But in the end, this was not the case, because what happened here, there was a lot of tortuosity, and just by pulling that stiff wire back, you can see how the bend straightened itself out. And in fact, the vessel was absolutely okay and patent and with no issues whatsoever. This was a horrific complication that I had. That was about a year ago. It was an extremely calcified valve with a gradient of 140 that we did balloon pre-dilatation. That was a VAX balloon that ruptured because of a spike in the calcium. But that was not the problem. We all do BAPs, who cares? But on the way out, as I was trying to remove this balloon, it got stuck on the sheath. So it split because of the rupture on the calcium, and then the balloon got stuck. And I know probably the image is not fantastic, but you can see one dot of the balloon up here and the other dot of the balloon down there. And it got stuck so much, I was pushing it forward, dragging it backwards. There was no way that balloon was coming out. It like welded itself onto the wire. So what I had to do is get back the whole system, the whole sheath, the wire and the balloon, pull it all the way out and leave just a little bit of wire in to keep my access. Obviously, I lost the access to the LV. And guess what happened, obviously, after that? The patient arrested because he had torrential AR. So we were doing CPR while one of the other operators was trying to get to disconnect this balloon from the wire and try and clean the wire, so at least we can regain access, recross the valve, and implant the new valve. All of that happened under CPR within 3 minutes. And this, at the point of being able to have the valve recaptured, we gained ROSC. So straight away, the moment I managed to put the valve with hands-on CPR, we managed to get ROSC. And then we managed to get a decent result. It's not perfect by no means. This valve, this lady would never have got a perfect result. But for me, even though I left her with this eccentric valve and a moderate paravalvular leak, mild to moderate, she managed to go home 2 days later. So for me, that was a success, because at some point I thought this is the first TAVI casualty I'm going to have on the table. Here we had another valve that caused an infold. This is a true problem. So in about 1 to 1.6% of the Evolut 34 Pro Plus valves, there is a caution tail from Medtronic saying that you might see this infolding. And this is exactly the appearance that you get. So when you see that, you don't mess around, you don't deploy the valve and try and post-dilate it. That's never going to happen, because the valve looks like this. And I took a video of it because I think it was really difficult as a concept to understand what infolding is. And this is what the valve looks like when you do infolding. So it literally, there's a massive wave, let's say. And no matter how amazing an operator you are, you're going to run into big troubles if you go and implant this valve. So what we did in the end is we basically took it out, implanted a new valve in, and we got a good result. Here you can see the final results of a new Evolut Pro Plus. And with that, I think I'm going to stop because I might have exceeded time, but very happy to take any questions.
Thank you very much for the interesting presentation and for sharing your cases. Do we have any questions from the audience? Okay, I have one small question for you. I noticed that the guide wires that you used is Landerquist and Safari. Is there any options to do it this, or depends on the valve that you used?
In fact, I use, most of the time I use Confida as my workhorse. And the reason I use Confida is because it's a wire that is very easy to strip off the polymer and you have very reliable pacing. I use Lunderquist double curved only when I have excessive bends and tortuosity or difficulties with growing axis, when you want to make sure that your valves can go through like 5 or 6 millimeters, or where you're going to do some POBA or some shockwave of the legs to be able to go up. Otherwise, my workhorse is Confida. The reason is mainly financial, that because we have a package that the wire comes free. I don't think it plays a big role. Safari is a good wire as well. I've used it quite a lot. There's the Safari Extra Small for smaller ladies with very small LV cavities. But, whatever the operators are comfortable with, it's fine. Lunderquist is just 3 times stiffer than the normal wires, and it's a great wire to tackle bends.
Okay, thank you very much. Professor.
And let's move to the next speaker. Thanks a lot for being with us. And now we'll call Dr. Katsimaglis from the Navy Hospital, who is going to tell us about TAVI in unstable aortic stenotic patients. George, you have the floor.
Dear Presidents, I would like to thank the organizing committee for the kind invitation to participate to this very interesting and leading Congress. The topic of the presentation would be TAVI in the unstable aortic stenosis patient. Is it a good idea? Recent studies have proven that TAVI is a viable treatment option for symptomatic aortic valve stenosis regardless of surgical risk. These results, without doubt, have already broadened the range of TAVI indications and subsequently lead to an increase in the total number of TAVI procedures worldwide. For unstable patients, European and American guidelines suggest BAV as an emergent solution, a bridge to definitive treatment. But they do not give advice on urgent clinical scenarios when patients are not in a critical condition but are not advised to leave the hospital without aortic valve replacement. So there is a difference between urgent and emergent. The patients who were not admitted for an elective procedure, but for medical reasons and you need an intervention during the same hospitalization were categorized as urgent. These patients couldn't be discharged without a definitive procedure. As emergent procedures are going to be done, for example, during a cardiogenic shock. Emergent and life-saving procedures should be performed immediately after decision making. So let's proceed to some data. A retrospective analysis of approximately 600 consecutive TAVI patients was performed during 2013 and 2018. Of these, 53 were categorized as unstable TAVI. Data was collected from Maastricht University. These are the procedural characteristics for elective and urgent patients. As you can see, the difference is between in creatinine, in logistic Euroscore, in Euroscore 2, and especially in pre-TAVI hospitalizations the total number of days, and the post-TAVI hospitalization also for the total number of days. The main predictors for short and long-term mortality for all the patients was only the urgency. Here you can see the cumulative survival for 1 year for the elective patients with the blue line and the urgent and emergent patients with the red line. The main symptom for this patient was the heart failure symptom, dyspnea, and the other was angina and syncope. The length of pre-hospital admission was the most significant predictor for 1 year mortality, since prolonged pre-procedural hospitalization was unique to urgent patients. We can see that the observed 1 year mortality rate remains reasonably lower than to say the 30-day and 1 year mortality was 11 and 29% for urgent and emergent patients than previously published 1 year mortality rates, which was higher of untreated symptomatic aortic valve mortality. So the treatment of unstable patient is better. Here are the official guidelines of European Society of Cardiology in 2021 for balloon aortic valvulotomy. They don't speak about TAVI for hemodynamically unstable patients. Here is the algorithm of European Society of Cardiology for management of non-cardiac surgery in patients with severe aortic stenosis. Here is for urgent patients, as you see, if the risk of the non-cardiac surgery is high, then we are going to proceed not in TAVI, but in BAV, in balloon aortic valvulotomy. In 2021, there is a large Chinese review and meta-analysis for approximately 75,000 patients, from whom the 10%, approximately 10% was unstable. That's to say they were urgent and emergent patients. Emergent TAVI was associated with higher incidence of 30-day in hospital and 1 year mortality. In terms of post-operative adverse events, emergent TAVI had higher rates of acute renal failure, dialysis, bleeding, and major bleeding. On the contrary, vascular complication, pacemaker implantation, cerebrovascular events, and moderate to severe paravalvular leakage were comparable between emergent and elective TAVI. Mark Reisman in 2018 published the data for 51 patients who underwent emergency TAVI due to cardiogenic shock, electrical instability, severe angina, and decompensated head failure with respiratory failure. Despite the critical condition of this patient, there was a procedural success rate of 95%, with a single intraprocedural death, only one, and an acceptable 30-day and 1 year survival probability of 85 and 61, respectively. The in-hospital mortality rate of emergency TAVI was approximately 20%. 1 and 2 year old cause mortality rate was 31 and 43%. It was better to use mechanical circulatory support pre-TAVI and not after TAVI as a bailout treatment. Here we can see the mortality in TAVI unstable patients with these 51 patients. As you see, the mortality is the mortality here in 30 days and 1 year. And here is the readmission probability, which is high for 30 days and 1 year after the emergent TAVI. And here we can see that the mortality rate of the patient who had mechanical circulatory support, as you can see here, with the patient with mechanical circulatory support before the TAVI. Here are patients without mechanical support, and here are the patients who have mechanical support after TAVI. Here are the hemodynamic predictors of early mortality of these patients. The only one was the pulmonary artery pulsatility index less than 1.8. We're going to explain what is it index, what is this. The importance of early identification of patients with very poor cardiac and functional reserve who should be stabilized pre-TAVI potentially benefit from upfront use of mechanical circulatory support. This result suggests patients with impaired right ventricular function, especially, as evidenced by a low PAPI. This is the pulmonary artery pulsatility index, which is a ratio of the pulmonary artery pulse pressure to right atrial pressure. Is a predictor of right ventricular failure. In your intervention in 2016, for 800 patients approximately, the most powerful factors was the baseline cardiac output less than 3 liters per minute, the reduced cardiac index, the impaired renal function, the need for mechanical ventilation, and the 30-day mortality was 33.3% in cardiogenic shock patients. It was significantly higher than the 8% observed in electively treated patients. Which are the alternative therapeutic approaches? This is the BAV, as you have already said before. However, the mean post-BAV aortic valve area in cardiogenic shock patients has been reported at values between 0.8 and 0.85, which still represent severe AS in most cases. Moreover, in such patients, in hospital mortality after BAV was reported to be as high as 70%. It is better to have after BAV more than 1.25 centimeters for patients with decompensating left ventricle. And it is better to proceed during the same hospitalization for TAVI. Transfemoral TAVI is a valid choice for patients in cardiogenic shock requiring urgent treatment. In cases where this approach is not feasible, the transaxillary route may be chosen and not transapical. The use of a balloon expandable valve was associated with significantly lower risk of 30-day and 1-year mortality in patients undergoing emergent TAVI. In CHOICE, the trial where there were 241 patients who randomized high-risk patients with severe AS to balloon expandable and self-expandable valves. The device success was the same between the two groups. Operators perhaps may perhaps to prefer use self-expanding valves in sicker patients with more severe left ventricular systolic dysfunction, cardiogenic shock, or unrevascularized coronary artery disease in order to minimize or to avoid rapid pacing, which may explain the higher mortality with this type of valve. The paravalvular leakage also is more with self-expanding valves. And here is an algorithm how to treat patients with aortic stenosis with complex PCI feature and decompensating left ventricle. As you can see, when we have an ejection fraction less than 35%, we can use BAV after impeller placement, after complex PCI, and after TAVI, or ECMO, complex PCI after to treat the complex PCI and after TAVI. As a conclusion, emergency TAVI can be a viable option for decompensating very unstable patients with severe aortic valve disease, with an in-hospital mortality rate of approximately 20% and long-term outcomes similar to studies of extreme risk patients treated electively. Careful patient selection taking into account baseline hemodynamic parameters such as PAPI and early utilization of mechanical support may improve survival following emergency TAVI. And let's present just a case for an emergent patient who have done recently in Naval Hospital with an ejection fraction of 15%. It was 30% 2 months ago, no CED, no coronary artery disease, in cardiogenic shock, intubated, inotropic support, in a list waiting for TAVI. We have already done a CT angiography 2 months ago with large annulus, so we knew schedule, and we have scheduled him for a 34 evolute. These are some echo pictures. Sorry. Can we play it? Okay, he was a patient. We have done a BAV. He was extubated next day. We have reduced the inotropic agents, and after 2 days, we proceed with the implantation of a self-expanding valve. The patient is alive and but not kicking. He is alive and very active now. Okay, this is okay. Doesn't play. Sorry. Thank you very much.
Thanks, Dr. Katsimaglis, for your fantastic overview, during which you covered a lot of different things, I have to admit. Do we have any questions?
I would like to make a small comment. I think when the spiral of aortic stenosis, unstable aortic stenosis begins with low cardiac output, cardiogenic shock, the only way out, as you stressed, Dr. Katsimaglis, even in the presence of concomitant coronary artery disease with ischemia, is fixing the valve. TAVI provides the only way out.
There were many topics that you've gone through, I have to say, and you've been through very nicely. One of the different things that I sort of mentioned and just try to summarize for the audience is, first of all, we have two kinds of unstable patients. One is because of the aortic stenosis, the other is because he needs another operation. He's rather unstable for that reason. The other is that patients hemodynamically futile definitely are the ones with the right heart failure. This is a bit of a problem because we might correct the left, but the right then become difficult. Another interesting topic is the use of support devices. That's a very interesting topic. We don't have a lot of experience here with Impella, I have to say. We tend to use intra-aortic balloon pump. It's a good thing when you have just aortic stenosis, but if you have a moderate, more than just small aortic regurgitation, then becomes a problem. One of the questions is that I don't know, you have a sort of with Impella. Yeah, definitely is that you put the Impella in, that's a good thing. You do a BAV, you put the Impella. My feeling is it's better to finish with the same session, do the BAV, put the Impella, fix whatever you want to fix with the coronary arteries and your way out. That's one thing. The other thing is if you want to just stabilize the patient, make him feel a bit better, improve the heart, then better to leave the Impella for a couple of days and then do the TAVI. I think that's...
I don't have this experience.
That's the way. For these patients with the very low injection fractions, the self-expandable valves, I do prefer them. It's easier because you don't have to keep them in a lot of time with ventricular patient because they collapse then. But I think you went through fantastically well. I don't have any questions. That's how I summarize it because there were too many top things. Try to make your lives easier. Yeah, sure.
Excellent talk. Thank you very much. One thing to consider also from a cost perspective is just go on fem support with the surgeon. Come in, you can percutaneous, and we've never had a patient not be able to come off. It's cheaper than Impella. And it's very simple to use because all the cardiac surgeons and anesthetists are used to it. So it's another way that can be very useful.
Yeah, it concerns me a bit because we don't have any experience. Do you sort of overstress the left ventricle because you increase even more with the ECMO
We put them on full fem, not ECMO, because you have to vent the ventricle, especially with the low EF. So, and the surgeons, again, do this all the time with cardiac anesthetists. And it's a nice, easy, cheaper way to do things, which, again, from Canada, we don't have all the money that the Americans have and Europeans have, but it's a nice way to do it.
Okay. Please.
Regarding the balloon valvuloplasty, as you remember in past, like in Canada also, larger balloons like Mansfield balloons were used, and in the TAVI times we are seeing that these increased complications. There are some specific balloons like 8-shaped balloons, different from the conventional cylindric balloons. And this kind of balloons opens the valve like the inverse direction, not like make harmful to the valve like the conventional cylindrical balloons. For me, for example, in some cases with cardiogenic shock, with this kind of balloons are still options for patients, especially V8 balloons, like true balloon. These balloons are also important because another point is for example, to use also balloon expandable valve, but large sizes rather than, for example, classical adverse valve. Like Merrill Mayville valve also give another option for patients with large annulus. I mean 30.5 and 32 sizes, because you can be rapidly put the valve on the crimp on the balloon, and you can go easily, very easily, like a balloon valvuloplasty.
Yes.
What do you think about this?
I think that this kind of balloons are better only when we have a lot of calcium amount. It's better. Differently, I think that all the balloons have the same result. Only when you have a large amount of calcium, these kind of balloons are better. Only this.
We are very happy that the presentation generated lots of interaction, but in the interest of time, we thank Dr. Katsimaklis and we will proceed.
Thank you very much.
It is my privilege to ask Dr. Roxana Maran, whose pioneering research work encompasses the entire field of interventional cardiology, to enlighten us on why the TAVI gradient is going up and what can you do about it. Dr. Maran?
Thank you so much. It really is a great pleasure to be here once again with you and to speak to you about why the TAVI gradient is going up and what can you do about it. These are my important disclosures, but specific to this talk, not really much. So let's understand better about the mechanisms of increasing gradients and valve dysfunction. When you think about the bioprosthetic valve, you have to think about that the valve stent that could go wrong, the leaflets, the annular calcifications, the stent, the original valve that's behind that stent, and of course, the sinuses. And there are important deteriorations that could happen that could be structural, that has to do with the valve seam disruption or stent fracture leaflet calcification or leaflet tear, or non-structural valve deterioration where there's leaflet thrombosis, paravalvular leak, and endocarditis. We have to tease this out because treatments vary with what the diagnosis is and what the mechanism is, because after the final common pathway of hemodynamic valve deterioration, bioprosthesis failure, and valve reintervention is something that we all have seen. So if you look at the VARC-3 manuscript from 2021, you see that they did this very nicely as well. The type of bioprosthetic valve dysfunction, is it structural or not? Is it thrombosis or endocarditis? Are there hemodynamic changes? And they gave stages from stage 1 for morphologic to moderate hemodynamic valve deterioration for stage 2, and severe when their gradient is going up a lot higher. And then the clinical consequences that have to do with bioprosthetic valve failure. And Philippe Pivaro did a beautiful job as well. The very important red flags of the bioprosthetic valve dysfunction, where you have reduced leaflet mobility, thickening, color flow, systolic restriction, mean gradient being higher, some important echo abnormalities that are listed here, and then some symptoms that we should be paying attention to. Importantly, the determination and the etiology, once again, is very important because the treatment will be varying depending if it's structural, non-structural, thrombosis, or endocarditis. And going into this, to prevent this, you obviously want to be looking for it with imaging, healthy lifestyle behaviors, and primary, secondary prevention. And for thrombosis, specific antithrombotic treatment is something that we're trying to do in terms of reducing any kind of a bioprosthetic failure due to thrombosis, and of course, antibiotic prophylaxis with optimal dental care. And importantly, I think treatment, when there is finally need for treatment for structural valve deterioration, it's usually SAVR. When it's non-structural, you might want to do things like paravalvular regurgitation, things like this. You could do transcatheter leak closure, or maybe even a valve-in-valve for structural or non-structural. And then, of course, specific treatments are anticoagulation for valve thrombosis and antibiotics for endocarditis. Important to understand the fact that leaflet thrombosis occurs rarely, less than 1% of the patients. It's at least 2 of the following: hypoattenuated leaflets or valve deterioration with increasing gradient. The management, there's now class 1C in the ESC guidelines for valve heart disease for anticoagulation using a VKA and or unfractionated heparin when there is bioprosthesis valve thrombosis before considering reintervention. Really, really important. And how we diagnose this, again, through CT or TEE for hypoattenuated leaflet thickening, halt, or hemodynamic deterioration. It all started a few years ago with, of course, the reports from Raj Makkar. Lots of patients, 900 patients looked at CT scans, and this was with surgical and TAVR, where there was some incidence of halt and restoration when there was leaflet thrombosis, restoration of normal leaflet motion in those patients who received anticoagulation, and persistence in those who did not. In partner 3, increased rates of valve thrombosis and composite endpoint of stroke, transient ischemic attack, and thrombotic complications in patients with halt were shown and seen. But it's important to understand there could be progression from halt to thrombosis. What is the treatment of choice right now? You could see all of the trials that have been done. We had many work to do with Envisage and of course, Galileo. When there's no need for anticoagulation, you could see less is more, and we're going towards less and less, and oral anticoagulants are not indicated for those who are not on oral anticoagulants, who don't need it. But certainly for those who are, you could use apixaban, edoxaban. All of those are now available. What do the guidelines say? In 2021, very, very important in patients, oral anticoagulants when there is an indication, but when there is no indication, single antiplatelet therapy, oral anticoagulants not recommended. And I think that's important. And even if you need coronary revascularization, it's single antiplatelet therapy. If there is a stenting, DAPT for a short duration, no more than 6 months. And you can see again the 2021 guidelines for valve heart disease that you basically are now getting a 2A recommendation for anticoagulation for leaflet thickening and reduced leaflet motion to elevate gradients until there is resolution. So finally, I think in conclusion, what I'd like to say is that the gradients, once they're increasing, this could be a sign of dysfunction. It may be due to structural, non-structural thrombosis or endocarditis. Prevention and treatment of the valve dysfunction depends on the underlying mechanism. Clinically significant thrombosis should be treated first with anticoagulation, and then before you re-intervene, and you consider it when there is subclinical valve thrombosis if the patient is at low risk for bleeding. And then the routine use of oral anticoagulant is not recommended in patients with no baseline indication for oral anticoagulants. Thank you very much. Ευχαριστώ πάρα πολύ. I will see you soon in Athens, I hope very, very soon. Thank you again.
I think that we're going to move. That was a videotaped presentation, so there will not be any questions for that. And so let's move to the last topic by Dr. Velianu, who is going to talk, I think what implies the title is how we can find the right device for the right patient. And is there any way of doing that? That's a very interesting thing to see how we can choose our different devices. Thanks a lot, Dr. Velianu.
Thank you very much to everyone here, all the organizing committee and all the participants. This is one of my favorite conferences to attend. So again, thank you, Costa. I met Costa at a poster meeting about over 20 years ago. So it's been a great ride. So unfortunately, I thought I was speaking tomorrow. I just landed a couple hours ago from Toronto. So I changed the topic on the plane a bit. So I apologize for that. So I'm gonna speak about what I may have done to avoid a complication had I chosen a different access. This is an 84-year-old patient, ex-smoker, dyslipidemia, was living independently with her spouse at home, chronic COPD, but the respirologist felt that she was quite stable from that point of view. Severe aortic stenosis, preserved EF, and she had a bicuspid valve. In our center now, about 10% of the patients we treat are bicuspid patients. Taking a look at everything here, we felt that going transfemoral would not be the right approach, and we felt that auxiliary approach, which was our standard secondary alternative access, would be the way to go. And you can see that the measurements in the femorals are down in under 4 with calcified, just a small lady, not the right thing to do, at least in our opinion. So, procedural plan, primary access, left axillary percutaneous access. We're going to do a secondary access with the right femoral and placement of a safety wire. And we decided on an Ultra 26 valve to be placed and a dry closure. And for the auxiliary, as we started that program, and we probably had the most experience in Canada, we brought in our vascular surgeons, and initially we did open cut downs since they were very familiar, as were our cardiac surgeons, and then we went to percutaneous. But as any surgeons here will tell you, the axillary artery is a different artery than the femoral for sure. So baseline angiography and placement of our safety wire, and then using ultrasound guidance. And in these patients, you can often palpate it very easily, but you still want to use ultrasound guidance and dissect down well to really get through the muscle, especially in younger patients who are more muscular, not in an elderly woman necessarily. Uneventful TAVR. In alternative access patients, we generally do RV pacing. If there's no, and we generally use LV pacing for most other patients unless there's pre-existing EKG issues. Unfortunately, we remove the sheath. Okay, it's not. We remove the sheath, performed dry closure, everything looked good. But then we had that. Now, the vascular surgeons will often inject through balloons. As an interventional cardiologist, I just don't like that. And I don't know what happened there, but we feel that the perforation occurred probably on entry of the actual sheath. And then either because of that or because of injection, something happened distal. So again, there's a perforation and a dissection distally. Patient was fairly stable. They were already intubated as we do for alternative access. We went up, inflated, felt we sealed it partially. Put the dilator in to make sure we really sealed it so we had time. And then put in a covered stent. And that was just deployed distal to the vertebral artery. And about 6 millimeter. But we didn't like what was happening more distally, as you can see. Post-dilated to make sure we sealed up. And again, the surgeon was with us, the vascular surgeon. And at this point, felt that we should try and do something more distally. We were not very happy with this, that's for sure. Attempted to rewire a vessel, left radial approach. We felt that we entered it, and then we put another stent in. And unfortunately, probably in a false lumen, a cut down was employed, and the surgeon repaired the vessel. The patient didn't lose that much blood. Things went quite well, we felt, after all that, and patient went to the coronary care unit. Unfortunately, patient had multiple strokes post-TAVR. And of course, we know from the literature that this is an issue with access through the axillary artery. And then, unfortunately, the patient had PA arrest, dilated pupils, and we suspected intracranial hemorrhage, and we did withdrawal of care at that time after speaking with family. Our experience evolved from 2018 with a multidisciplinary team feeling that everyone could add something to this. Initially cut down, then a percutaneous approach. But then we were quite worried because inconsistent results, even with expert hands. And then we went back to cut down. And then after that, because of, and this is one of the issues, this particular case, we felt this was not the way to go anymore. And again, as the evidence was coming out that there were more issues with strokes with axillary approach than even the carotid approach, we developed a carotid access. And you'll hear tomorrow Dimitri from Laval in Quebec City talk about that because they have one of the largest experiences of carotid approach. So that's what we've done now. And again, altering our care based on our experience, based on the literature, feeling what we could do best for patients. So again, a very sad situation, but I'm going to say a good situation here. On the left is a picture with myself, and to the on my left, Dr. Chu, Dr. Natarajan, who we were part of our first TAVR back in 2008, so we're coming on 15 years now. And I saw the two of them doing the procedure because our fellows had to go to a mandatory retreat. So I said, I have to go in there with them just so we could take a picture. So, after 15 years. And on the right side, and some of you may not have seen this, but that person, that's the same day as their valve. That person is my father, who was 86 years old at the time. He's 88 right now. And he was a same-day discharge, actually. He had a pacemaker placed for a high-degree block a few weeks earlier. And then when I left, was going home that night, I was doing TAVI after it was done by my colleagues. He looked at me and said, "Pupas." So I had to take him. So we took him home, same-day discharge. He did very well. So again, everything we do, everything we learn, good, bad, ugly, helps not only our patients, but potentially our families. So thank you.
Thanks very much.
If there's any questions.
Dr. Vilianu. And so Now you suggest that it's better to go through the carotid than the subclavian?
So we've done about 20 carotid procedures now, and all of them have gone very well. It's a bit tricky because how you position, you're getting a lot of radiation, so we're trying to shield as much as possible. We bring a vascular surgeon in there. We do a CT scan to check circle of Willis, but from what I hear, some centers aren't even doing that, and the results are excellent. Their stroke risk is lower. The vessel is a different vessel. Again, as any vascular surgeons here know, the carotid is a very different vessel than the axillary artery. And we're quite happy with it. There is a learning curve post-care because the blood pressures can go up and down. You're near the carotid bulb, and sometimes blood pressure can go up to over 200. So you have to be prepared for that. So you have to have a whole process in place to care for these patients.
Why do you think, because we're doing quite a lot of subclavians ourselves in my center, always with a surgeon, I have to say. We do an open cut down.
Yes.
I think that there's no point, I found it very little stressful for me. I don't know about the surgeon or the patient, but I can have my coffee by the time they prepare the patient. So
you mean doing axillary? Or?
Yeah, axillary.
Yes. And most of ours went very well. But there'd be a little nuisance bleeding or a little bit here and there. It just wasn't as smooth as now I'm seeing carotid. And if you asked me a year ago about carotid, I was thinking this was crazy. I didn't think it was a good way to do things. But I'm a believer now, and you'll see some data tomorrow on that by a real expert.
Interesting. I thought always that axillary must be sort of an easier thing than the carotid.
That's what I thought, but again.
Possibly we'll find different things. Dr. Christocharis, please.
I remember at some point in the beginning, a few years back, that we really didn't use the axillary approach for sapien valves. We used it mainly for self-expanding valves. But have you seen that maybe there's a difference in outcomes if we use it for sapien rather than self-expanding?
When you look at the literature, it seems that both valves have an issue with it. So I don't know if it's the valve per se or just the access. And even if you have a nice smooth artery free of calcium, it seems to disturb things differently. And I don't know where in the point in the procedure that's occurring, but it just seems to be higher than the carotid. At least, again, the carotid may be done only in the majority of centers that have a lot of experience. So maybe they're generating this data. As with anything, we need to do some first and get good at it. Before we can see how well. But
it's always an issue when you try to remove it back and how you will put the cone inside the sheath. Then you have to be very careful because you might find it to dissect much easier than other parts of the arterial system. I noticed that. We haven't seen the dissection. Possibly we will see it. But you have to be a bit careful there with how you maneuver and in the way that you position the sheath and how you till the point that you stop the sheath and then you move the valve in, it's a bit of tricky. There's some issues, but and why do you think that causes more strokes from the axillary?
No one really knows, but when you look at observational studies, it just seems to be higher than even the carotid, and it doesn't make sense to me. But for whatever reason, it seems to be. Maybe it's a straight shot with the carotid, often, especially if you're going from the right side. And
do they go left-sided strokes or either part?
I think it's either, but again, it just seems to be maybe the device is more finicky. We're pulling it out. We're doing something. So I don't know what.
Okay. Anyway, I think thanks a lot. I think we finished with the session, and we didn't destroy a lot of the program. I think just 1/4. So we can move on with the next part of the program.
Good afternoon. It's time for the next session. The next session is about transcatheter edge-to-edge repair for the tricuspid valve, myths and realities. We will start with Dr. Chris O'Harris, who will describe the anatomy and pathophysiology of the tricuspid valve in the setting of the edge-to-edge repair. Looking forward always for your presentations, Dr. Chris O'Harris. We always learn from them.
So, ladies and gentlemen, thank you very much for being here, and we'll discuss in the next few minutes about the anatomy and pathophysiology of the tricuspid valve with an eye towards transcatheter edge-to-edge repair. So just a quick update, refresher on basic anatomy. The tricuspid valve consists of an apparatus, actually, of the right atrium, the right ventricle, the leaflets, the tricuspid annulus, the chordae, and the papillary muscles. It's a complex structure. Regarding the leaflets, traditionally we've considered to have 3 leaflets, but we'll see that we have lots of variations in that. With the 3 leaflet configuration, we have 3 commissures and coaptation zones between septal anterior, septal posterior, and anterior posterior. Again, we have variable now a number of leaflets. You can see on the left side of the image the typical 3 leaflet configuration, but here we have 2 posterior leaflets. In addition, the tricuspid annulus is defined by the leaflet insertion at the atrioventricular junction. The fibrous tricuspid annulus is indistinct and incomplete, especially at the free wall, and that's why that's the area that we have dilatation of the annulus. It's oval and non-planar for normal individuals, but becomes more circular and planar with RV dilation, and is highly dynamic during cardiac cycle, impacting on the closure of the valve. The tricuspid annulus is the largest orifice of all valves. It's in continuity with the Koch triangle and the right coronary artery, anteroposterior, and with the aortic cusps. The annulus is attached to only one fibrous trigone, the posteromedial, and the septal part of the annulus is the more stable and doesn't dilate. It's the more consistent. However, the lateral side is the one that enlarges. And we see here that in pathologic states, the free wall of the tricuspid valve enlarges outward, as well as follows the right atrium and right ventricle. The trigone of Koch and the membranous septum are important structures to keep in mind. The surgeons know them very well because that's the area at the asterisk here where we have the AV node, and that's the area that they avoid putting sutures in. And we can see here how proximal the AV node and the His bundle is to the anteroseptal commissure, and this is very important for us to understand. And you can see here that in one of our cases, we needed to elongate and come out of the right ventricle, but we got caught in that septal anterior commissure, and you can see that we have complete heart block developing as a result, which resolved once we pulled back on the catheter and some supportive measures. But it's something that we should keep in mind. So regarding the papillary muscles, there's the dominant papillary muscle is the anterior papillary muscle that supplies cords to the anterior and posterior leaflets. There's a smaller posterior papillary muscle, which is usually bifid or trifid, and provides cords to the posterior and septal area. The septal papillary muscle is usually very short or non-existent, and there's lots of septal strut cords that attach directly from the myocardium up to the septum, and these tend to decrease the mobility of the septal leaflet, especially as the ventricle dilates. Especially also, it's important to know that in the commissures, there's a lot of cords that we can get caught in, and we need to be very careful when we manipulate the devices in that area. The right ventricle and right ventricular outflow tracts. The right ventricle is thinner and more distensible than the left ventricle. It's important to know that the tricuspid and the pulmonic valves are widely separated. There's no continuity between them. Now, the best way to understand the tricuspid valve is by 3D echocardiography, either transthoracic or transesophageal, as in this case. And here we can see with the landmarks being the coronary sinus at 6 o'clock and the aortic valve at 9 o'clock, the 3 leaflet configuration that is the standard. However, the work done in the recent past few years has shown that the traditional configuration is only present in about 50% of cases, where we have an anterior septal and posterior leaflets. The next most common configuration is having 2 scallops on the posterior leaflet, and then other small lower incidence is when you have 2 leaflets instead of 3. You have a fusion between the anterior and posterior leaflets, or you have more scallops, 2 scallops in the anterior leaflet, or more scallops in the septal leaflet, or multiple scallops all across. In terms of etiology of tricuspid regurgitation, it's considered to be primary in about 10-15% of patients where we have a structural abnormality of the tricuspid valve apparatus, as in this case, a flail septal leaflet on the left side or Epstein's anomaly on the right side. For the most part, however, most of the TR is a ventricular secondary tricuspid regurgitation due to insufficient leaflet coaptation from apical displacement of the papillary muscles and leaflet tethering. This could be caused by left heart disease, pulmonary hypertension, primary or secondary, and RV dysfunction of any cause. Here, a typical example of a patient with ventricular functional TR and the dilated right ventricle. And we can, with volumetrics, we can measure the size and contractility of the ventricle. An entity that's becoming more in vogue in recent years is the atrial secondary tricuspid regurgitation, where we have dilatation of the atria and subsequent dilatation of the annulus of the tricuspid valve without significant dilatation of the right ventricle. This is a diagnosis of exclusion. We have to exclude that there's no leaflet abnormality, no left ventricular dysfunction, no left-sided valve disease, pulmonary hypertension, or pacemaker wires. This is a typical example of a patient with atrial functional TR, where you see on this schematic here that it's a small ventricle compared to the one we saw before. And this is sort of highlights in a graphic way on the left side of the screen the image of a patient with atrial functional versus ventricular functional. With the atrial functional, the right ventricle usually is normal in size or mildly dilated, and there's not significant tethering of the leaflets, conversely to the ventricular TR. This case report highlights the difference between atrial functional versus ventricular functional that we mentioned before. The other big category of TR is cardiac implantable electronic device leads that may adhere to the leaflets, impinge on the leaflets, or get entangled with the subvalve apparatus. It's estimated that about 25 to 30% of patients with pacemakers may have some degree of tricuspid regurgitation. And 3-dimensional echocardiography helps us clarify whether the cable is actually causing the problems or not. This is an example of a patient who received a pacemaker shortly after aortic valve replacement. However, immediately after that, the patient went home and she was very tired and fatigued all the time, and this is a cause severe tricuspid regurgitation because of the wire. This wire had to be pulled back and repositioned. Conversely, here's a patient who has a long-standing implanted wire that impinged a bit on the posterior leaflet and caused secondary ventricular dilatation and ventricular and functional TR because of that. Traditional methods of assessing tricuspid regurgitation severity we know very well. The method that we like to use nowadays is the vena contracta area of the regurgitant jet. And also we use volumetrics, and we use also 3D echocardiography for that. The grading of tricuspid regurgitation severity has expanded from mild, moderate, and severe to massive and torrential. And the reason is that for many patients with torrential or massive TR, just decreasing the amount of regurgitation to severe or moderate or less helps them clinically. So that's the reason we have expanded that classification. Now, it's important to know that when we approach a patient with to assess the severity of tricuspid regurgitation, it's not just tricuspid regurgitation, arrow, severity, and that's it. Actually, we want to look at more, and we want to look at annular dilation, how is the leaflet coaptation, what is the right ventricular remodeling, is it dilated right ventricle, what is the hemodynamics of the pulmonary circulation, is there RVPA coupling, which is a measure of the afterload of the right ventricle, and other clinical features. So we have to go with a more comprehensive evaluation of these patients. Invasive hemodynamics are important in patients with tricuspid regurgitation, and we see here that a pre-procedural assessment of cardiopulmonary hemodynamics offers clues as to the risk of these patients and how they will do long-term. And it is that if a patient does not have pulmonary hypertension, or if he does have pulmonary hypertension but is post-capillary, those patients have better prognosis than if they have pre-capillary pulmonary hypertension. So that's something that we can easily discern by right heart catheterization. Now, the other important thing about the tricuspid is how volume dependent it is, in functional TR. You see here that this is a patient that, actually it's in the operating table, but I put it here because I found it very interesting that immediately as the patient goes on cardiopulmonary bypass, this torrential big coaptational gap becomes smaller and the valve seems to coapt better. But in any case, we know from clinical practice in real patients, obviously in clinical practice coming to our office, that if we diurese them well, we can improve the size of the degree of regurgitation, and we can create better, shorter coaptation gaps that will enable us to proceed with a successful edge-to-edge repair. In addition, the other thing that's very important with tricuspid regurgitation is its correlation with atrial fibrillation. This is an interesting study that they followed 690 patients with new-onset atrial fibrillation, and over time, approximately 1 in 3 developed moderate or greater tricuspid regurgitation, with female gender and permanent AF being more closely associated with the risk of significant TR. And in addition, when rhythm control strategy was employed, there was a lower risk of TR. And this actually, I felt it to my bones because this is a patient I've been following for a good while, and up to last November had this trivial tricuspid regurgitation in sinus rhythm and mild mitral regurgitation. And then he presents in February, 3 months later from his last EKG, he's in atrial fibrillation. Now we have these type of significant tricuspid and mitral regurgitation. We put him on optimal medical therapy. We try our best, wait for a while, but no improvement, still significant TR. Eventually we do cardioversion, and this is 10 days after cardioversion, he's back to normal in terms of what he was. So definitely AF and rhythm strategy is important in some of these patients. In addition, for tricuspid valve, multimodality imaging is very important. CT and MRI gives us a lot of different information. Obviously, echo is #1 modality for assessing the tricuspid valve, but we get lots of information from both CT and MRI. Finally, to conclude the tricuspid valve, the questions that we need to answer as we move on to tricuspid edge-to-edge repair is, from our assessment, what is the leaflet length and mobility? We need at least 7 millimeters of leaflet length and good normal mobility to proceed with edge-to-edge. We need the coaptation gap to be acceptable, and acceptable would be less than 8-9 millimeters. We need the TR location and severity. Ideally, the jet to be central in the anterior septal zone with clear grasping zones. Imaging needs to be adequate because we have to be able to see the often very thin and difficult to image tricuspid leaflets in order to be able to follow the procedure carefully. If there is a pacemaker wire, then that pacemaker wire should not be impinging on the leaflets to a point that we're not going to be able to decrease the TR. RV remodeling, if it has occurred, then we should have a sense that if we fix the volume overload, that some of this RV remodeling will regress. In terms of pulmonary vascular hemodynamics, we need to assess the peak and mean pressures. Ideally, we'd like to have peak pressure less than 60, 65, and a mean pressure of less than 30. With a transpulmonary gradient of less than 17, the pulmonary vascular resistance should be less than 4 Wood units, and the TAPSIT to PASP ratio should be over 0.41. And in addition, to have to establish that there is no significant left-sided heart disease that we can treat with another intervention or with optimal medical therapy. So in summary, understanding the anatomy and pathophysiology of the tricuspid valve is evolving. We are getting a lot more wiser than what we were a few years ago. Multimodality imaging is key in deciding interventional options. And our focus should not only be on the severity of tricuspid regurgitation, but we should also look at the right ventricle function and the pulmonary circulation hemodynamics before we make our decisions. And with that, I would like to thank you for your attention.
Thank you so much, Dr. Chrysoheris, for your thorough and very constructive presentation. Should we go on with questions or with the next session, because we're lacking back in time?
If there is a short question and with a short answer.
If I can ask a very short question, do you think that 3D eyes will be a modality that might replace TOE during the procedure and making it a procedure without general anesthesia?
I think that's the plan. That's where things are heading. That once we get ice and once we get fluent with the use of ice, then that will make a difference for many of the steps of the procedure. I'm not sure if it's going to fully replace TOE from the get-go, but at least for the time-consuming aspect of the procedure, which is ensuring good leaflet insertion, it will help us tremendously.
Great, thank you.
Okay, Michalis, thank you. And can we proceed with Fabien Praz? He's a professor of interventional cardiology in the University Hospital of Bern in Switzerland. And he's going to talk to us with pre- and procedural imaging of the tricuspid valve for transdermal therapy. Please.
Thank you very much. Thank you very much for the invitation. I regret not being able to be with you in Athens, but very happy to be online. Excellent presentation by Michael, as always. So, I will try many of the things I will show have been already explained by him, but, I will try to give you a little bit an interventional cardiologist perspective on that, and to tell you in a very summarized way what are the information that an interventional cardiologist needs to have when selecting the device, when going into a procedure that could be edge-to-edge or another one. I think one of the very important steps, the first one, is the selection of the device. So, for me, I think it's very important, as it has been mentioned before, that we classified tricuspid regurgitation in an appropriate way. We start to know a little bit more about the differences of ventricular and atrial tricuspid regurgitation. This has been very nicely shown in the previous talk, but we know now that there is also a difference in terms of prognosis of this patient, probably also in terms of response to different therapy, and I think in the future, probably in terms of management of this patient, one of the aspects is atrial fibrillation and the control of the rhythm. That is a very important strategy, and probably in the future, more important strategy for the treatment of atrial TR. It has been very nicely shown in the case by Michael. And for ventricular, then the treatment of TR is probably the way to go for this patient. The other one, and that's the classification we have developed with the PCR tricuspid focus group that I'm heading together with Francesco Maizano, and the goal of this group is to standardize a little bit the approach to tricuspid regurgitation and also the treatment. And what
Professor Praz?
Yes?
We cannot see your slides. If you have any, could you share
them? Oh, I'm
them?
sorry about this.
Could you share
I'll
them?
Try. Yeah, of course. Can you see it now?
Yes, you can. You go to presentation mode.
Yes, sure.
Can you?
Yeah.
Can you put on the presentation? Oh, it's perfect now.
Now it's good.
Now it's
So
good.
sorry about that.
Please carry on.
Yes, so exactly. So what I was talking is that I was saying is that we were feeling in that group that we should also separate the pacemaker-related tricuspid regurgitation from the primary, which is also little bit different mechanism as well. You have seen example. I will show some example as well of this etiology of tricuspid regurgitation. And finally, we have a very rare primary tricuspid regurgitation that is generally iatrogenic or in patient with Barlow disease, and that is the most rare one in our patient. So you have seen about the gradient of tricuspid regurgitation. Of course, the classical parameters are very important, but there are limitations. And in the example I show you at the bottom of this slide, you see that this patient with a very large coaptation gap is a situation where traditional grading parameter cannot be used in the same way. Looking at the jet, at the velocity of the jet, or at the traditional PISA, in patients with very large coaptation gap, you have a situation where this parameter cannot be used for grading. So very careful grading, very careful assessment of tricuspid regurgitation is needed. Also in patients where the jet, as a traditional example, cannot be seen. What we start to understand is the prognostic value and the prognostic prediction of tricuspid regurgitation in different situations, and you see that there is actually a linear increase of mortality linked to the regurgitant orifice area that is start to be exponential even when the PISA is bigger than 0.3. You see this on the right part of the slide. So we have a linear relationship of prognosis and tricuspid regurgitation in terms of grading. That is very important to understand that way. What do we need to see as imaging before starting the procedure? Very important, we need to see a very good quality of the transgastric view to understand the anatomy on one side, to be sure that we will be able to reproduce this view during the procedure. So it's a deep transgastric view that needs to be produced to be able to see the leaflet, and the anatomy is, as you will see here, can be defined on this view with a septal leaflet looking towards the left ventricle and the septum. Then you will have the anterior one in that region and the posterior one. Of course, the complexity, as you have seen before, is much more difficult to appreciate, and you have a lot of variability in terms of anatomy. But that's a little bit roughly the situation and the orientation you will need also as an interventional cardiologist to be able to orientate your device and appreciate the presence of indentation and the number of leaflets. And then the next view that will be extremely important during the procedure, but need to be already done during the screening, is the deep transesophageal view. I think the imager need to be to get used to this and to train this view already during the screening. And you can see here that with this view, you will be able to look at the anterior part of the valve, which is toward the aorta. And in this part, you will rather look at the anterior septal commissure, meaning that you will have the anterior and the septal leaflet, but you will not be able to differentiate generally the anterior from the posterior leaflet on this view. And that's why, again, the transgastric view is extremely important. You will need a third dimension to be able to distinguish the commissure and to make the difference between the anterior and the posterior leaflet. So when you screen, during the screening procedure, through the valve, and when you go posterior, then you will be again more likely to see the septal and the posterior leaflet, but for differentiation of the anatomy, the transgastric view is absolutely key. The next step then is selection of the patient, and for that we will need the information of the coaptation gap. We know that until a coaptation gap of about 10 millimeter, we will be able to treat a patient very effectively with edge-to-edge repair, but above in patient with bigger coaptation gap, we will probably need our strategy, combined strategy, or a replacement. And this can be also measured on the transgastric view. If there is no standardized way to do it, and what we consider is doing this measurement at the position you anticipate to implant the first device, typically on a transgastric view, the best one you can get to really have the tricuspid valve in the plane. And this will be essential for the selection of the device. The number of leaflets is linked to the success of the procedure and need to be taken into consideration according to the experience of the center, also to select the patient. Patient with more than 3 leaflets will be more difficult to treat, and the result will be less good, in particular when the experience of the center is lower. And finally, you have seen this, but that's something I want to insist on, which is often forgotten when we talk to our fellow or to a referring physician, referring patient with tricuspid regurgitation. Often people do not know whether the patient have a pacemaker or forget this information, which is extremely important. Is there a pacemaker crossing the valve? Is there several leads maybe crossing the valve? And do we have an interaction with the leaflet? On the left side, we have actually several leads, but no interaction. You see that the leader is moving completely freely. On the other side, you have an interaction with the septal leaflet, and the lead is the cause of tricuspid regurgitation, which we, of course, need to know. So, we will need to develop with time and with experience a kind of pattern recognition, describing the tricuspid valve on echo, using mainly the transgastric view, the jet location, coaptation gap, the presence of a lead, and finally the etiology of tricuspid regurgitation need to be described to be then able to make decision on whether to treat the patient and which device to use. We have an attempt here to add all these criteria. You see that all the criteria I mentioned previously are in this algorithm to select the device. Michael has mentioned it before. We need to go very fastly to advanced imaging, to CMR and CT scan. I don't go into details because this, of course, has less implication for edge-to-edge repair, but for the understanding of right ventricular function. Only one parameter is not enough to understand right ventricular function. We cannot rely only on longitudinal function on TAPSE, but we need to understand the relationship between right ventricular function and the PA pressure. And also we need to look into more parameters, for example, strain. There is a recent study there showing that you are able with strain to identify more patients with right ventricular dysfunction, and also to look at the result after treatment. You see on the right side a patient after and before and after replacement of the valve with a complete different motion of the right ventricle that you will not necessarily understand only by looking at the longitudinal parameter. And finally, the question I've been raised regarding intracardiac echocardiography. I think this is for tricuspid valve a very important modality that will be more and more important to introduce a catheter into the right atrium and are able to do actually already very precise imaging of the valve. You see in the cardioband implantation, you can see the leaflet very clearly, the annulus and the catheter also in 3D, very useful already. Only one catheter is approved in Europe, but in the future we will have different options. Just in summary, what are the essentials of tricuspid valve imaging? So we need a good transgastric view. We need a very good grasping view, right ventricular in and outflow view. We need to understand the valve morphology and the number of leaflets. We need to have an information regarding the gap. And finally, the presence of a pacemaker as well. And in the future, probably, we will do more and more of this procedure with ICE. Thank you very much for your attention.
Thank you so much for the detailed analysis. Is there a question from our audience in those technicalities? Dr. Chrysoheris, please interact. You are the advanced imager.
Thank you very much, Fabienne, for the beautiful presentation. Have you, in your experience, the 4D ICE, you've used it throughout the procedure instead of transesophageal or in combination, or how do you perceive it working for you in the future?
So for tricuspid procedure, we have used it in combination generally, but I think you probably for edge-to-edge repair it's a little bit more challenging because the imaging need to be of higher quality, and the catheter we have now that are now approved in Europe are not of so high resolution as the transesophageal echocardiography, I would say. So there are some progress to be done there. But for a cardiovent procedure, for example, you can use it to implant the screw in a very precise way. So potentially you could implant devices and also replacement device using only eyes in the future. I'm quite optimistic. It will be, of course, a complementary. There is still quite expensive. There is a cost issue to be considered, but I'm quite confident that we will be able one day to do this procedure with eyes only.
Do you see any usefulness for fusion imaging, Echo Navigator, and so on?
So Echo Navigator is useful not for edge-to-edge, but for replacement, because you can identify the height of your catheter in the right ventricle. The recognition of the border of the right ventricle by the current version of the Echo Navigator is not completely accurate, and you really have to have an excellent imaging quality to be able to really have the true border of it on the right ventricle. But I think there are progress done also regarding this, and that the echo fusion may be also very helpful. Replacement is definitely a category of procedure where the fusion is helpful to identify the annulus.
Dr. Spargios.
Fabian, hi, and thank you for being with us this year.
I
just want to ask you if you have any experience, or in other words, if you have a pacemaker wire, or if you have a defibrillator lead, which is thicker, and you don't have good imaging because of it, because of the shadowing, or you think from the imaging that it impinges a leaflet, do you accept this as final, or do you go with a deflectable catheter and try to move the lead and see if we can improve your visualization, or if you can create a space to go with a clip? Have you ever used this technique?
No, I have never used an additional catheter to move a lead, but I have seen this done actually by some implanters. I have to say I cannot remember of a case we had to interrupt because of bad imaging, of course, but because of really a true artifact coming from a lead. Generally you are able to work around this and to see something. There are situations when the lead, and you are right to mention an ICD lead, when it's very close to the septal leaflet, where your visualization will be really difficult. But in that situation, even with using the catheter of the clip, you will be able to move that lead a little bit to make you to have a little bit more space to grasp the leaflet. So moving the lead is something actually very we do quite often, but we do it generally with a catheter, with a tear catheter. And I have never used, I have to say, additional technique to move the lead away from the area of interest.
Thank you so much for your comments, and I think we may proceed.
Well, the next speaker will be Professor Moody Makar from Cedars-Sinai, Los Angeles, and he will give us a presentation on the strategy planning in the non-standard anatomy and when to reject the case. We cannot hear you, Dr. Makar.
Yes, okay.
Okay, now we do.
Now, and I hope you can see my screen.
Yes,
thank you so much. Fine. Perfect. Thank you so much for the invitation and to be with you. My talk will be mostly about the non-traditional standard anatomy and how can be affecting the procedure. So, in tricuspid tear, the case. When you have a good anatomy but add images, this is where the 3D eyes might come in role, trying to get the good procedure. But what happens when you have a bad anatomy and good images? Maybe this patient is more suitable for a valve replacement, Or what you do when you have a bad anatomy and bad images, even with replacement, would not be a good option in these patients. So the challenges that it encountered during the TEER are the multiple of them: presence of a pacemaker lead, lack of adequate height, septal hugger, coaptation of the leaflet, wide jets and high residual gradients, and challenging imaging. So we're going to talk a little bit more for the pacemaker leads. The interaction of the pacemaker lead in the tricuspid valve, it could be one of three things usually. It could be one, it could be tucked in the commissures far away from the regurg, or it could be in the lead in the jet location, but is free and mobile. Or the worst kind is when you have the lead is impinging or adhered to the leaflet. And these are the ones that we are having very hard time to treat. So the options will be one of two: either removal of the pacemaker lead followed by the tricuspid clipping, or the trying to clip with the pacemaker lead end. So we have a case here with a 75-year-old male with a 4 times heart failure, 5 times hospitalizations in less than 3 months. And he has, as you can see here from that, there has a septal leaflet with a pacemaker lead that is adhered and impinging on it. So we decided to send this patient for a surgical pacemaker lead removal because he didn't require pacing for the last 2 years. But there was no change in the severity of the TR. But what it made is made the coaptation gap much less, as you can see here on the 3D images. And that allowed us to be able to treat this patient. So the patient came back in, and sorry for the images is not playing the video, but was able to come back in, and we are able to treat the patient with 3 clips and reduced it to a mild TR. And this is here his comment that he has never felt the same in the last 5 years. His weight decreased from 214 to 198, and no admissions for the heart failure. This is the end result here. After 20 months follow-up, he still have a mild TR. Another patient where we decided to leave the pacemaker lead in and to be able to work around it, especially because it's not tethering the leaflet and around it. So this is a 77-year-old female referred for TEER, 3 admissions of heart failure in the last 12 months. And as you can see here from the images, that the leaflet, the lead is tucked all the way in the posteroseptal commissures. So we went ahead and we treated this patient with an edge-to-edge repair. And in the next image here, we're able to put 2 G4XT clips on the anteroseptal and the posteroseptal side, with decrease of the TR down to mild again. And just without actively pushing the lead was even just tucked more and more into the commissure. And this is another patient here with referred for a clip. Patient has a wide pacemaker, and the lead is more in the anteroseptal position, not the posteroseptal position as before. And we were able to easily put 1 clip with reduction of the MR, to the TR down to mild in these patients. So next challenges that could be in some patients who have lack of adequate height or a septal hugger. And in this patient, 85-year-old with referred for the TEER, I'm just going to skip that for the sake of the time. And she had accepted coaptation gap for the TEER, and we decided to move forward with it. But what happened is during the initial procedure that we had a very bad septal hugger, what we call here, and that led us to have inadequate height. And that's when we're using the commercial off-label use, and we use the right femoral vein. So we canceled the procedure. Patient continued to be symptomatic, but then we started to dig more and more and see what we can do, and we started to try to do that through the left femoral approach. As you can see here from the images, and we'll show you with the next image, they can get more distance between the steerable guide and the septum and the through the left femoral approach compared to the right femoral approach, and that will lead to the case here that we're able to achieve optimal trajectory from the left femoral approach with adequate height, and we're able to do the procedure. And This is the end result after we putting 2 clips in, successful reduction of TR from severe to mild. And this is the patient follow-up, 6 months follow-up with a mild still residual TR. As you can see, the patient note here, she is really very helpful and thankful from that. And this is the paper that we published about this case, that it gives you, especially using the left femoral vein, gives you much higher trajectory, and that will help to achieve a lot of or overcome a lot of the challenges of the septal hugger or lack of adequate height to achieve a good result. Next will be the next challenges that we can have are the leaflet coaptation gaps, which is 7 to 10 millimeter. Usually up to 7 is as easier to grasp, but in some patients, we had this patient with a 9 millimeter gap, and it was less ideal for a tear. And that was before we had the valve replacement available. So we decided to use the PEEP administered through the ventilator, trying to compress a little bit on the heart by decreasing the venous return, by also pressing on the tricuspid annulus. As you can see here, we use independent grasping. The gaps were very big. We use independent grasping, grasp the anterior leaflet first, and then followed by the septal leaflet after that, and we were able to achieve a very good result. Next challenge could be if you have a very wide transcatheter jet and you already have a very high residual gradients. What could be acceptable in these patient situations? So again, 78-year-old female referred for the tear because of the severe TR. And the jet was very, very wide. And we can see from the transgastric view, the width of the jet was about 1.76. Not by the jet color by itself, but we decided to see how many clips this gonna get. So we used a G4, NT, XT, and NT with a reduction in the TR from the torrential to mild, but we had a very high residual gradient after the tricuspid. And the gradient for this patient was 7. And the patient didn't really feel any improvement in her symptoms, despite that we were able to get it down to mild. Another patient that 57-year-old with a very severe symptomatic tricuspid regurg. This patient, very, very similar, that she had a torrential TR and she has a bileaflet tricuspid valve, actually. And in this patient, we decided to stop after we have an adequate reduction, about 2 to 3 grades, but we still left some moderate residual TR behind. And the mean tricuspid gradient was 5. So this patient had a significant improvement in symptoms, and NYHA was 3 to 4 baseline up to 2, and that was in 2.5 years follow-up. The gradient in this patient that we left was about 5. So we know there's still the paper that came in the JACC interventions about the prognostic value of the tricuspid valve gradient, but just be cautious that these gradients that we measured was up to 5 usually. So maybe we should have 5 as the cutoff for these patients when to stop. So last thing about the challenging TE imaging, when to proceed and what to do. So we had a patient that was very, very challenging. And as everybody demonstrated here, the use of a 3D eyes or a 2D eyes that we used here initially was very, very helpful to achieve a very good coaptation and reduction in the TR jet by demonstrating the leaflet insertion and the adequate leaflet grasping. Another modality that could be used, and it should be very, very encouraged, is using the MPR, which could be done from the mid-esophageal RV inflow or the transgastric view, where you'll be able to see all the position, the trajectory, and the orientation in these, and you can see the leaflet insertion, and you can see actually even the reduction, the TR with that. So that is very, very, very important imaging modality that overcome the lack of the 2D images in some patients. So conclusion is that the tricuspid tear is feasible treatment for tricuspid regurg. Anatomical challenges precludes from getting an optimum results, and larger studies with including the complex anatomies is needed to confirm the reproducibility of these results. Thank you so much.
Thank you, thank you, Dr. Makar, for your excellent presentation. Do we have any questions? Do you have any questions?
Thank
Dr.
you for,
Spargers.
yeah, thank you for the excellent presentation. I think you covered everything so well. All the worries of an interventional operator of this procedure were presented and dealt with in your presentation. Thank you for being with us. And I want to ask you, when you have a problem with tethering of the septal leaflet, that creates difficulty in grasping it, would you recommend in that case also to go from the left femoral? Do you think that will be beneficial or will give you more chances to be successful?
So it will give you definitely more chance to be successful because you're going to have more height. And with the more height, you can change your trajectory in different angles. Sometimes just a small change in the septal to lateral trajectory make it very easy to grasp. All it takes about 2 or 3 degrees to be able to grasp both of them at the same time. Another technique we always like to go to the anteroseptal first because that's the easiest. So maybe trying to go to the easy part of the anteroseptal to grasp with the first clip, which could be the investment clip we call. And then usually after that, the septal leaflet will be elevated up higher, and then you'll be able to do a second clip there.
Thank you. Thank you very much. It was wonderful. And now we don't have Professor Maizano with us, and we should proceed with the case. Dr. Spargers. Dr. Arvadinos will do the case presentation. Dr. Spargers.
Dr. Chrysoheris, Dr. Georgiou should come
to the discussion and the interaction.
Good afternoon.
Dr. Arvadinos from GIA Hospital, Department of Percutaneous Valve Therapies. He will proceed with the case. Okay.
Thank you, dear colleagues. Our case is a patient of 83 years old male, overweight. From his previous cardiac history, he had surgical mitral valve replacement for severe mitral regurgitation with a St. Jude mechanical bileaflet valve. 25 years ago, here we can see the mechanical valve and the washing jets, well-functioning valve, and with a mean gradient of 5 millimeter of mercury. Our patient presents with fatigue, exertional dyspnea, and in mild exertion, NIHA 3 with volume overload and worsening symptoms last year. So here you can see the chest X-ray. He has a right pleural effusion, pulmonary congestion, and also from the ECG we can see the atrial fibrillation and interventricular conduction delay. He is on a maximum tolerated medical therapy with furosemide, 100 milligram daily, carvedilol, acenocumarol for atrial fibrillation and the valve, the mechanical valve, spironolactone and injection to release T for diabetes. Here is his recent blood work with a good renal function, good also liver function, a BNP level of 151 and low platelets due to thrombocytopenia. Here we can see his recent chest X-ray, CT scan with the right pleural effusion. And also from the other comorbidities, he had atrial fibrillation, non-insulin-dependent diabetes, colon adenocarcinoma with a partial colectomy 3 years ago without chemotherapy or radiation, and thrombocytopenia. He also underwent coronary angiography months ago without stenosis. From his echocardiography summary, he has a dilated left ventricle with an LV ejection fraction of 43%, a dilated right ventricle with good systolic function, a severe tricuspid valve, and a well-functioning mechanical valve with a mean gradient of 5, and also a systolic pulmonary artery pressure of 44 millimeters of mercury. Here, we can see from the dynamic, the heart model, his left ventricular systolic function that is impaired with an ejection fraction of 43, dilated left ventricle, and impaired also global longitudinal strain of minus 7.7. Also, we can see here the right ventricular function that is dilated with an elevated CVP and an adequate systolic motion with taps of 15 and SDI of 11 centimeters per second, and also a free wall global strain of minus 19. From the subxiphoid view, we can see the severe tricuspid regurgitation, mainly coming from centrally and also from the anteroseptal leaflet and commissure. And now, Mr. Chrysoheris will will continue with the imaging analysis of the case. Thank you.
Thank you, Dionysis. So this is the screening echocardiogram, transesophageal echocardiogram. And this is the midesophageal biplane imaging that we utilize a lot. This is the cursor is positioned right in the middle of the valve. At this point here, we see the coaptation gap that we measured it at about 9.5 millimeters. And the corresponding image with color on the next, on the right image of the screen shows a torrential tricuspid regurgitation with a very wide jet. The ERO was estimated at 1.7 square centimeters, indicating torrential TR. Usually we do a sweep, and actually I can show you the sweep a little bit later on. We go all across from the anterior to posterior to see exactly the whole valve. From a midesophageal view, we see a live 3D image, and again, as we saw earlier, this is probably a tri-leaflet valve with one reservation. Maybe we have a septal 1, septal 2 back here, but it's probably tri-leaflet overall. Torrential TR, as we can see here. Again, now the cursor is a bit more anterior position, closer to the aorta on this image here. This is we see the anteroseptal commissure area here, which is close by. The gap is smaller as we go into the commissure. And here we see that there is some color in this area as well. The gap was measured about 9.5 millimeters. It was a gradient of about 2 millimeters of mercury, which is interesting because this looked like a wide opening of the valve, but and definitely there was no significant stenosis based on the opening of the valve on 3D. Here we go to transgastric views, which are the very important views that we obtained. And here we can see the septal leaflet in this area here, the anterior leaflet and the posterior leaflet back here. Lots of cords tethering on the septal leaflet here, as we saw before. So these are strut cords that hold the septal leaflet, and sometimes they may give you a difficult time getting between them to grasp the septal leaflet. The corresponding 3D color image shows a good amount of color coming from the septal anterior area, which is very promising that this will be probably on the feasible side of things, be able to do it successfully. In addition, we had the right heart catheterization that, as we mentioned, is important in these patients. And we saw that the systolic pulmonary artery pressure was about 50 millimeters of mercury. And the right atrial mean pressure was 19 with a V wave of about 30, indicating severe tricuspid regurgitation. We could see the initial part of the video we have in store, because the first 3 minutes this is views from the study that we did on the table. This is transgastric images, as we saw before. This is on the day of the procedure. Deep esophageal views here. We have we see only the right side. We don't have the left side impacting our images. And biplane images here, you can see the scanning that we do pulling the cursor closer to the aorta and then scanning all the way to the back and see exactly how the color is in each individual area of the valve. This is anteroseptal, this is here in the middle of the valve, and we can see that the coaptation gap seems to be even better on this image here compared to our screening, which is probably due to good diuresis of this patient leading up to the procedure. So this is the scanning that we like to do, and it's mandatory for us to do it before we do anything. As we move more, actually the gap is still there, so it's not gone away. It was just the position that we were looking at. It's about 11 millimeters. Now here we position more posteroceptal as we move away with the cursor. Not much color in this area here. So most of the color is central and anteroseptal. So this is our assessment. And we're probably going to proceed with maybe some 3D images coming up next. And actually, we're going to measure the ERO again from the transgastric, from the mid-esophageal view. This is a live 3D from a mid-esophageal view, which is an easy view to obtain. And again, with the aortic valve is at 5 o'clock. This is the interventionalist view. The anterior leaflet is at 6 o'clock, and the septal leaflet is at the far field for orientation purposes. And here we bring down the color gains to see exactly where the color is coming from. It's coming from the center of the valve. Again, back to transgastric views and live 3D with transgastric. So our plan is to put something in the septal anterior area and hopefully get a good result with that. Most likely, we may need 2 devices in this case for an optimal result. The measurement of the ERO is at in the range of torrential TR, 1.7 square. So here again, we're in the mid-esophageal views, looking at the valve. And with this, we can go to the PowerPoint slide and just give you my final sort of overall. This is functional ventricular tricuspid regurgitation, good leaflet length and mobility, coaptation gap about 10 millimeters central, location of the jet primarily anteroseptal and torrential in severity, likely 3-leaflet valve, dense chordal distribution at the septal leaflet. There's no pacemaker wire. The right ventricular remodeling, we have dilated right ventricle with good systolic function. Pulmonary vascular hemodynamics, we have moderate pulmonary hypertension. And we have mitral valve replacement, but nothing else from the left side that we need to intervene upon. So with that, we can proceed with imaging analysis and
I would kindly ask Dr. Ioriou from the director of the hemodynamic laboratories of Apollonian Hospital in Nicosia to give us his strategy and planning and tools for the case. Yorgo.
Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizers and especially Dr. Sparias for their kind invitation. In our hospital, we have a small experience in tricuspid tear with only tri-clip devices. With regards to this case, obviously it's a challenging case. It's about an 83-year-old male patient with a previous medical history of mitral valve replacement. A mechanical valve was implanted at that time many years ago. He has also chronic atrial fibrillation with controlled ventricular rate. And he was recently presented with congestive heart failure and right pleural effusion despite optimal medical therapy. He has mild pulmonary hypertension, significantly elevated right atrial pressure. The transthoracic echocardiography showed moderately dilated left ventricles with moderate to severe impairment of the overall ejection fraction. He has a well-seated, well-functioning prosthetic mitral valve. The right ventricle is mildly dilated, and the inferior vena cava is also dilated. The RV systolic function is impaired. The TAPS is 15 millimeters. The RV free wall longitudinal strain is -19. The regurgitant volume is 124, indicating a massive or even torrential tricuspid regurgitation. So we have a massive secondary functional tricuspid regurgitation. It's a combination, according to my opinion, of ventricular and an atrial TR. The septolateral coaptation gap, according to the side markers of the echocardiogram, is less than 10 millimeters. It's a 3-leaflet morphology based on the 2D and 3D transesophageal echo. It's mainly anteroseptal jet. No leaflet thickening or shortening was noted. There is no marked leaflet tethering, and we have good echocardiographic leaflet visualization. Based on this simple and accurate tri-score system, we know that this patient is a high risk, has a prohibitive risk for open heart surgery, isolated tricuspid valve repair or replacement. So, according to the proposed algorithm by Dr. Prass, we have seen a few minutes before, this patient with a gap of almost 8.5 millimeters has good chances to be treated with tricuspid TEER, although annuloplasty also can be discussed. The experience is limited in few centers. The tri-repair study showed some benefits even for the symptoms or for the remodeling of the right atrium and ventricle, though it's not a well-spread technique, and we have no any experience with that technique. So tricuspid transcatheter H2H repair is a good option for the patient. The anteroseptal jet should be addressed. The patient will be should be admitted at least 24 or 48 hours before in order to be treated with diuretics in order to improve the rate of success. Thank you for your attention.
Thank you, George. This is exactly what we do. Like you said, we admit the patients 24 hours before, and we give intravenous diuretics to have the smaller ventricle and annulus possible to facilitate the procedure. So if we can dim the lights down now and play the video. So all of us can comment now, and I'll just try to give some small description of what we're doing. Michael also can help me. So as you see here, we're already there with the Pascal ACE device. So you see the flex of the guide cath, how take us away from the septum. You see that? So when you flex the guide cath, then we get away from the septum when we advance our device. So this is just the guide.
This is a view that you can see the orientation of the guide over the tricuspid valve, so looking from above. So it's sort of useful if the operator wants to know where septal, lateral, anterior, posterior is.
And here comes the device.
And now the device is coming out.
So you see it touches the septum, so when you flex, now this is the folding for going from the default to the closed position. And then this is the flex. If you see my finger on the knob on the guide catheter, and this takes you away from the septum. Now we're pointing to the aorta, so we are anterior, and you correct the anterior or posterior by torquing the delivery catheter. So this is the part of the procedure that we need to be very careful, because we need to be coaxial on the space. So we need to be coaxial on both the anteroseptal on the right, anteroposterior on the right, and the septal lateral in the left. So we have to be like perpendicular to the annulus on this plane if we want to be successful.
And then in this plane, we see the color, so we know where we should target, where we should go for. We go to the middle, usually, of the collar. And you can also get an idea by looking at the leaflets how easy or how difficult it will be, the clasping. So here is the opening of the device. You see that we're a straight line on the right side, which means that we have to clock the device. We need to open the arms so to get there the septal and the anterior leaflets. So here is a 3D from above that we are trying to do the clocking. So now it's like 2 o'clock and 8 o'clock, and we rotate. So the strategy here could be to go in the commissure, in the septal commissure, and to accept that because this is torrential TR, we're going to use at least 2 devices. So get the first deep into the commissure and then go with the second more central, or try to put one right in the gap in the center and see if you are lucky and this is successful. So this second strategy is the one I like, and I always try this first. Because if you put tension on the leaflets where the gap is and you bring them together, then having another device into the commissure is probably redundant, and it just makes the procedure complex. So here you see how we do the cloaking. You see the septal above between 12 o'clock and like 3 or 4 o'clock. And the anterior just below. So this is MPR?
Yes, it's a live multiplanar reconstruction. It gives us similar views to the transgastric. But we always use transgastric if we can see it, because we trust the transgastric a lot.
So this is a deep transgastric, and you see that we are our clocking is satisfactory. So we're like 2 o'clock and 8 o'clock. And if you remember, there was a dense corda in the middle of the septal leaflet. So the discussion there is, should we go above that dense corda or below? If we went below, then we would be more deeper into the commissure. So at least our plan was to go just above that dense corda, so to get the septal leaflet in the center. So Michael likes to use a lot of MPR lately.
I would like to use it because it gives us a full view, irrespective of the angle of intonation. So on the left upper we have the anterior-posterior view, and the right upper window we have septolateral. So we see that we are very nicely perpendicular to the annulus plane. And on the left lower quadrant is that the short axis that would try to see if we can be perpendicular to the coaptation zone that we want to be. It's between septal and anterior, or close to it at least, before we go into the ventricle.
So the Pascal ACE has a spanning opening of 26 millimeters. So from end to end is 26 millimeters. And even if you have a gap of 10 millimeters, as we said earlier, then you have another 16 millimeters to play. So you can get the lateral leaflet, then torque septally and try. So here you see we are more central. Earlier we are more commissural. So here we're right in the center. And you see how the lateral leaflet, which is the anterior, is sitting on the paddle of the device, but we are a bit deep now, so we have to go higher to drop the clasp and get it. Sometimes in this position you get confused between the anterior and the posterior leaflets. You may get the leaflet in and keep having a moving leaflet, which is not the one that you have into the device, but the posterior. So here I think we have, yes, we have dropped the clasp on the anterior leaflet, and we're trying to rotate. You see the movement of the clip to go to the septal leaflet, and the anterior is in already, so it's independent clasping, and you see that we don't have the reeds. So and we try, like in these cases, we close a little bit the device. This is what we did here, and then we try to scoop it from below. Sometimes to do this you need to be a little sudden, quick, so once you see it sitting you go quickly up. So that was not very successful. We're not very happy. So the device is open.
And the septal is curling a little bit. It's as if the strut cords there are holding it down, if you agree.
It's probably the area of the cordite.
Yes.
That we had in the middle.
It's not free there. It's not very mobile.
Yeah. So you saw the same thing again, the sudden movement up, but it was curling. And here I think it's a little different, so more promising. So we drop the clasp and we close. And when you close the device, you see the pulling of the leaflet. So the leaflet is certainly in. And now you do your assessment on the reduction of the color.
I think we wanted to optimize at this point.
Yeah. Obviously, we are not very happy with this color. It's not a great result. There is certainly a reduction, but it's not a great result.
So I think you wanted to optimize the septal leaflet. I'll have to recall. Let's see.
So most of the color comes now from posterior of our device or more central to our device.
Gradient is 3. Go back to transgastric to see how we are grasping the leaflets.
And you see here we're a little deeper than what we wanted into the commissure. That's why we get the color more central. Actually, we're below that codi we said that is the middle of the septal leaflet. So let's see what we did. I don't remember the details, so we'll discover all together. And also it's probably a little rotated clockwise, the device here. So we would like it to be more standing up.
So you're trying to see leaflet insertion. That's why we're doing MPRs on the device. We're not sure about the leaflet insertion of the septal leaflet. So I think we went back to optimize the septal leaflet better while keeping the lateral leaflet in. And this is after we close the device. Actually, for whatever reason, we're not very happy with the color, and I don't have the color here, but
so now
we may be optimizing
the lateral.
Yeah.
We'll see.
Now we're looking for the arm, so we changed the angulation on the probe to try and optimize the visualization of the paddles. So we don't, not the traditional plus 75 plus 90, but we're, you know,
so the lateral clasp is now up. So we'll try and now down again to optimize the lateral or anterior leaflet. I think we are happy with the septal, Michael, because you see the bouncing of the clasp of the septal. So we know that we're good with the septal, and we just try to optimize the lateral.
Yeah, for whatever reason, we don't seem to be able to immobilize it. But again, it's a long leaflet, so we may not be able to mobilize it, but the image can confuse you at times because it seems that we definitely have the leaflet inside, But if you scan a little bit lateral to it, then you may see it differently. But I think the
if you notice, we moved more central now than a little more central than earlier.
So gradient is 2. And this is live 3D again from mid-esophageal. Looking at the tissue bridge.
So this is a complete transformation change from everything we're used to as interventional cardiologists. You see that you only note now the echo image. You don't pay any attention to anything else, which is very strange because we usually, when you do balloons and stents and everything else, we just have fluoro. So but in this case, fluoro is not helpful at all. Everything is echo guided.
Here we're interrogating with multiplanar reconstruction the device, and we're sort of moving the red line in and out. So we'll see on the right upper frame how the leaflets go into the device.
And I think you can appreciate now that we moved more centrally and that we are above that coda in the septal leaflet. So now we are in the desirable position in the center. So in this case, if you have a good result, you accept it. If you don't, then you open it, you move more commissurally, and you get a second device. Let's see what we did.
I think, let's see. I think this is actually releasing the device now. I think this is released.
So the device is released and stable. And this is what we have now. We remember the torrential TR we had at the beginning, where the color was going everywhere. So certainly we have a significant reduction with just one device.
I think because of the number, the gradient was 2 or 3, so maybe that's part of the reason we didn't pursue it further. And this is not a bad result, because before we got torrential TR, and this would say it's moderate TR, visual estimation, obviously.
Michalis, for the non-expert, does the spontaneous echo contrast preclude you for another device? It's a warning sign, it's nothing, it happens, it just happens?
One second. Here in the images, we go back to look at how we started, sort of going through to compare before and after. That's why we're going. The images on echo are.
So these are imaging from the beginning, just to make the comparison.
To make the comparison before and after.
But you're right. You notice this smoking in the right atrium. Yeah. Certainly, this is an indication of slower flow, stasis of the blood compared to the beginning. So
this is before. Baseline. This is before, and we try to go to the same angle, same biplane images to have that direct comparison. So this is the same, essentially, for direct comparison. This is before again, showing torrential TR, and this is after. So this is after release of the device, obviously, and
the RA pressure is also decreased as far as I see in the monitor.
The RA pressures, yeah, I think there was the V waves were up to 30, and now it's down to 23. This is gaining down a little bit to see exactly where the jet is coming from. It's coming posterior to the device mostly.
Yes, exactly, and that's what I was going to comment on. If you change the position and went more commissural to the anterior commissure, it wouldn't decrease any of these residual jets. So I think you did the right thing and stopped at the first device and at this central position.
So this is the error now with one device. You remember it was above 1 and now is 0.32.
I think following this will be closing images. This is the gradient of 3 millimeters of mercury. This is transthoracic subxiphoid images to see the tissue bridge between septal and anterior. The clocking is good. There's some jet coming posterior to the device.
But it's very small,
Yes.
and if you want to get that, then you should go. There's no other anterior leaflet here to get a second device. Everything is into this device, so if you go with the second device, you should go to the posterior leaflet and the septal.
This is transthoracic images on the table before we left the OR. A reasonable result.
It's an excellent result. It's an excellent result.
I think sometimes comparing with the baseline is very useful to understand what you did, because if you see this, you may say, okay, it's not perfect, it's moderate, and I have to go with a second device. But then that would probably be also our decision to go with a second device if we had a clean space of the anterior leaflet and the septal leaflet to go for. But here it was obvious that we would have to move to the posterior and the septal, and I don't know how much effect we would have in this moderate. So by getting the definition of 2-grade reduction from torrential, actually 3-grade reduction to moderate, I think we are finishing here. And here you see the figure of 8. We don't use proglides.
Costa, correct me if I'm wrong, this is moderate TR, it's not moderate MR residual, which is also important to keep in mind. So it's a very good result for the TR reduction.
Comments?
Congratulations. Any comments or questions?
From the floor?
From the floor.
Congratulations on the excellent case, and I think the hero of the case was your imager rather than the interventionist in this case. So just a couple of questions to the whole panelist. I mean, do you make it as a habit to measure the anterior or the lateral leaflet, the septal leaflet, pre and post capturing to see how much of a leaflet insertion is inside? And does that make you change your strategy or get more optimization? We noticed in the case that the anterior was really long. Do you think, and a bit bouncy, do you think adding another ACE will have impact on the long run, not the acute run? And finally, we talked about the definition of a successful TR in, clipping and compare to edge-to-edge clipping in the mitral. So are we now accepting 2 grades or 50% TR reduction with then what mean gradient we're accepting in the edge-to-edge repair in the tricuspid? Thank you.
So for the mean gradient, for the last question, we like to stay at or below 4. for a gradient. Now, we've had cases, one case actually that went up to 6, but it was important to get the regurgitation down to as much as possible. But 4 is our magic number at this point. In terms of measuring the leaflets, obviously we do that by scanning the valve back and forth in all different aspects by biplane imaging from midesophageal, and with that we have a sense of the leaflet lengths. Now, measuring how much leaflet is outside and how much is inside is very difficult, and the best marker for, generally speaking, is actually documenting the clasp fall on the leaflet as possible. And then my next best thing is to do MPRs. And in that way, you're as accurate as possible as to get an idea how much leaflet you have inside the device.
Would anybody go with a wider device here, like a P10? Christos, George, Santos?
I think for the tricuspid valve, we already made an establishment to go with the P in Pascal A's. So I don't know, maybe it's too wide, so you get tangled in the chord of the tricuspid valve easier with the P10. So I wouldn't feel comfortable. The very few cases I've done with the tricuspid, I've used only Pascal A's.
So during my training in the earlier stages in the structural, we were in the early stages of using Pascal P10, which is the only available device at that time in 2017 and 18. And couple of things were noticed. Number one, it was more difficult for the imager because of the bulkiness. And it's already the tricuspid is difficult by default, so giving them extra challenge wasn't easy to them. The second, and in compared to ACE, they become, at least from the image perspective, more comfortable, either because their training and their experience have changed or because our technology has changed. Hard to tell now. And as he mentioned, the doctor, that it's become the default of using an ACE, that's correct. But it was noticed, at least in the earlier stages, having a P10 going inside of the small, thin, as Dr. Michael has presented in his anatomy of the tricuspid is very thin, very small chordae. We had difficulty going in and out as freely as we are in the ACE. So that was like 5 years ago. Now we have lots of improvement in our imaging, in our experience, in our also device mechanism. And we have also now the Pascal Precision, I think, is just around the corner. So hard to tell now, because I was thinking when we were presenting, maybe if we had a P10 that would have covered your gap. But I think during the screening, maybe having a good image so you can a bit compromise some lack of imaging if you use the P10. But I haven't used it yet, at least during my recent practice. I don't know, Dr. Constantino, have you used it? And Dr. Michael, I don't know if you have any experience with it.
I think we all agree that we would use an ACE in this case. I think we moved completely away from P10 in the tricuspid. In this particular case, it was the dense chordae on the septal leaflet that were discouraging completely the use of a P10 here. The other option would be to go with a strategy, from scratch, to go with one device below the chordae and then a second device above the chordae. But now we put a second device above the chordae, and we didn't have any color from the anteroseptal commissure. It was just the lateral. So I don't think putting two devices like that would have any different outcome than one we saw here. So we try to keep, for now, this procedure simple, low risk, and as quick as possible. For now, again, when we get this result, three grades reduction, I think it's very acceptable to stop. And as somebody commented earlier, the tricuspid valve is not like the mitral valve that you want to be really perfect if possible.
And the other thing is that this is the real everyday work in our cath lab, in our hybrid room, because these cases are not selected. These are consecutive cases of 4 continuous days of our work. And these are the cases we're presenting today. So they're not selected at all to be, you know, failures or the most excellent results. This is our daily work.
Kostas, can I ask you something? Do you still use the tri-clip for the tricuspid valve? I mean, Pascal has an added benefit compared to the tri-clip, the advantage of elongation. I mean, a month ago I was doing a case and I got tangled in the cord, and by elongating the device I was able to get untangled quite easily. Otherwise, I don't think how I would get away with it.
We started with the mitral clip in the tricuspid valve. Our experience in the tricuspid, we did 7 cases, if I remember correctly, with mixed results. So when we started our experience with Pascal back in 2016, we had very good results, very acceptable results. So it's what we said this morning, that if you keep getting good results with one device, and you have already tried the other device, and you're not impressed, in the tricuspid at least, then you keep using that, and I think this is what happens now. But certainly we're open, you know, to gain from other people's experience. So we keep our eyes and ears open, and we're certainly we don't say that we're not going to use tri-clip again.
This would be a good case for if we had 3D eyes, because our main concern was the leaflet insertion of the lateral leaflet and then the septal leaflet. So if we had 3D eyes, I think we definitely would have used it and try and you know, shorten our time spent ensuring leaflet insertion.
One other small difference between the 2 devices, especially in the tricuspid, is that the difference in the spanning is not big. It's just 1 millimeter, 26 for the Pascal, 25 for the XT. But it's the flexibility of the Pascal system in the right heart is a lot better than the stiffer tri-clip device. So it's more forgiving to move, to withdraw back, to change position. All these are more forgiving with Pascal, I feel, than with tri-clip. So if there are no other comments, I think we can finish the session. And now I see in the program that we have a break for half an hour, right? Okay, so you can all go to the cafeteria and enjoy a coffee or a snack till we start again.
Till 17. Till 17.
Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known, proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
και από την απογευματινή συνεδρίαση της πρώτης μέρας του Βαλβιδικού Συνεδρίου 2023 του Συγκροτήματος Υγεία στη συνεργασία καρδιολογικού και καρδιοχειρουργικού τομέα. This session is a TAVI masterclass, ensuring optimal outcomes, and we're going to have a series of virtual and live sessions. I'm George Dangas, chair of this session, along with Dr. Zarifis, who is chief of cardiology at the Papageorgiou Hospital in Thessaloniki. Papanikolaou Hospital. That's right, Papanikolaou Hospital. I got the Papa right. Papanikolaou Hospital. Very well. And welcome. We can see you very clearly. And we have our first speaker, who is the professor of cardiology and my friend Manolis Vavouranakis, Sotiria Hospital. He has really not only founded but revived a tremendous program of cardiology there. And he's going to talk to us specifically about the valve program that was also inaugurated there by him regarding screening, planning, execution, and residual gradients for valve-in-valve. Manoli, go right ahead.
Thank you, George, for your kind invitation. We're glad to have you here in Greece. And we will start with my presentation. Let's go on full screen. In the next minutes, I'll try to give you some information on how we treat patients with bioprosthetic valve failure.
Manoli, please share your screen. Please click share the screen.
Should be okay. Now
there you go. Thank you. We see it now.
Okay, great. So I will talk about this problem, which is becoming quite usual, I would say, because a lot of patients that were treating in the past with bioprosthetic valves start to develop this kind of image, as you see here, and the deterioration. And this creates a significant problem when we try to treat these patients. Of course, it was a pioneer procedure done in 2007 by Krube and his team when he first implanted a bioprosthetic valve which was damaged. It was actually used to implant a valve-in-valve procedure with, as we see here, was a core valve, if I remember well. And this created, obviously, a new era. And since then, as we see here with the TVT registry, a lot of patients starting to undergo this procedure, this valve-in-valve, as we see in red. So it's good news that we have this option. And from the partner 2 of valve-in-valve registry, we can see clearly that all-cause mortality is better in these patients if we have more than 20 millimeters gradient. The mean gradient, if it's less than 20, it's much better than if it's above that. So I think this is something, a message that we should looking to get as much as lower gradients after a procedure. And of course, this better results are also interpreted with a better quality of life and better orifice areas and less gradient. It's interesting that when we compare the valve-in-valve procedures with the native valve procedures that we do with the transcatheter aortic valves, the mortality seems to be less. Also, we have less hospitalized, not significant difference as far as the gradients, I would say, the need for intervention, and the stroke seems to be less. So this is interesting. And I think in order to succeed these results, we are more experienced now, at least on how we can screen patients and how we can plan the procedure. And maybe that's why we have good results also. A decision needs to be made when you have a valve-in-valve procedure, and you have to take into consideration the type of the failed valve, the mechanism that developed the failure, whether you have some precise measurements or estimations about the dimensions of the valve. We have applications that can be used. We have CT scans that can be used and should be used. We have to evaluate the risk of coronary obstruction. We have the ability to select valves with a CE mark for this procedure. And also we need to have some expertise if we decide to do the procedure in difficult anatomies, like alternative techniques like the basilica. Although these are rarely used, at least we should be aware that when there is a need, we have to basically refer this patient to a center that has the experience. So whether we should do a surgery again for a valve that has deteriorated, or whether we should do in a transcatheter aortic valve, I think it relies on some also criteria. For example, if the patient is above 80, obviously the transcatheter is favorable. Patient's preference should be taken into account, although it's not in our country, in Greece, the decision by the preference of the patient. A large size without severe patient prosthesis mismatch is against favoring the transcatheter. Balloon valve fracture, if it's possible done with a specific valve, is again in favor of proceeding with a transcatheter valve. Favorable coronary anatomy, if the chest, the aortic root is hostile for surgery, and also the option of which valve we can use depends also regarding the need for reaccess of the coronary. In that case, you prefer the balloon expandable valve. The need for pure aortic regurgitation in a stentless valve, which both valves can be used. I would probably use, because that's the one I have experienced most, the self-expandable valve in this situation. And whether this valve can be fractured or not fractured is another option that also can be used for deciding which valve you're going to go with. The other thing that you need to assess is the chance that you have an obstruction of the coronary by the leaflet that extends up to the orifice. So if it's not the case, then of course, you can go with a conventional transcatheter aortic valve replacement. The other parameter you should take into account is the distance between the valve and the coronary ostium, and they use the 4 millimeter as judge distance to see whether this can be done with a conventional procedure, or whether there should be a need for a modification to give a space and avoid the position of the leaflet, the new leaflet, against the coronary ostium. Potential risk factors for coronary artery occlusions are both anatomical and the factors and the characteristics of the bioprosthetic valve. Narrow sinotubular junction, narrow sinus of Valsalva, previous aortic root repair, low-lying coronary ostium should all be taken into consideration. In addition, the supraannular position of the valve that we're going to treat, the high leaflet profile, the mitral flow imperfecta are notorious valve for giving us problem, and the non-stent frame and bulky leaflets are also potential for creating risks of coronary occlusion. In general, the prediction of the proximity of the coronaries to the anticipated final position of the displayed bioprosthetic leaflets after doing the procedure is very important. And of course, like I said, there are some features that I mentioned before that can be helpful. Here's an example. If you have a stentless, it's hard to know where you are. You can use 2 pigtails initially before to define the orifice of the bioprosthetic valve, but generally it gives more difficulty to position precisely versus a stentless valve where you can see actually and be guided where to put. The other issue is the true internal diameter we should know, and unfortunately there are applications. Also the CT will guide you, or the measurements by the CT, which was done in all of the patients that are going this procedure. In general, you should oversize the valve, at least if you use a self-expandable valve, and based on the true internal diameter. Consider the echo and the CT measurements. Of course, if you have a very small valve, maybe you should consider if it's possible to redo the surgery in order to avoid the patient-prosthesis mismatch. And we have to remember that you can get as much at your best to the gradient where you have before the procedure when you first input the valve. So you have to take into consideration if you started with a small valve, what the result could be if you implant a second valve inside. The execution, we go with a coplanar coaxial fluoroscopic view as an implantation view, and the bioprosthetic ring is seen as a reference point where you put. And we see here that predictors for malpositioning are the baseline regurgitation, poorly visible stented and stentless valve, and that I would say, and a self-expandable heart valve. Here's an example where you see that the malposition, if you have adequate availability, is around 5.3%. It goes higher when you have a poor visibility valve, bioprosthetic valve, and a stentless, it's going even higher. Of course, if you do not implant properly the valve, you can have paravalvular regurgitation as a result of either too high or too low position of the valve, regardless of the type of the valve that you're going to use. And you have to be able to get the best orifice area, and this is not on the left an acceptable opening of the valve, of the frame of the valve, so you have to take into consideration that a lot of times you need to open, if you have residual gradient, the valve, and you should know which valves can be broken with a balloon, like here you see, for example, the trifecta valve is not a valve that you would like to, you would try to break, since there at least there are no data to support that this can be done safely. And after you do the balloon, obviously the gradients go down, and the mean valve area, effective coryphus area, goes up, as you see here on the green. And the question is whether we should do it before or after you put the valve, a rupture of the bioprosthetic, a valve which was already implanted in the past. It looks like safety is more towards doing the procedure after you have a frame that will prevent a rupture, actually an injury of the annulus. And it looks here, as far as measuring the gradients, that it has a better effect on SAPIEN 3, this I would say technique, but it doesn't change the gradients before or after the implantation if you do the balloon inflation. On the Evolut, it does change, I'm sorry. The post has less gradient. On the self-expandable valve, it looks that there is no difference here as far as the gradient as we see on this slide. And I mentioned before the trifecta and the mitral flow are notorious for coronary occlusions because the leaflets are outside. And even worse, if you have a stentless bioprosthesis, it makes things even more difficult, I would say. And as you see here, the coronary obstruction is, I would say, the incidence of coronary obstruction is higher when you have external mounted leaflets, stentless even high, but less than the first group. And then stented with internal mounted leaflets is actually, I think, the best valve that you can treat with valve-in-valve as far as the coronary artery occlusion. And here we see that there are techniques advertising protection of the coronaries, and also if you really have a high risk of occlusion of the coronary ostium, the basilica technique has been advertised and has been used, but I think it requires significant skill. What about residual gradient? If the residual gradient is there, you have to consider why. Was there a stenosis as the baseline mechanism of the failure, not the regurgitation? That is a risk factor, of course, for creating not an adequate opening of the valve after you put a second valve inside. Was there a patient's prosthesis mismatch? As I said, you cannot get better from what you started. If it's a stentic surgical valve, obviously there's some limitation in the expansion. Small surgical valves will create smaller annulus afterwards, especially if they are diseased already on the leaflets. During the procedure, you have to see where you put the valve if it's too deep, if it's also if there is intraannular transcatheter heart valve, and if you did not break the ring, whether you should have fractured that before you leave the cath lab. And after the valve-in-valve, consider always when this occurs, the leaflet thrombosis, patient prosthesis mismatch, which was from before, I would say, and structural valve disease deterioration. And as we see here, this is an old publication, 2014. I don't know if it applies to SAPIEN 3, but from Israel, you see here the VIR, the publication, looks that the core valve is behaving better as far as the opening after the valve-in-valve procedure. And we see here that in the multivariate analysis, the factors, the small surgical valve, stenosis, mix and failure, left ventricular ejection fraction that actually influence the results. So what about if patient undergo valve-in-valve surgery, and the smaller the surgical valve, the higher the mortality. So obviously we need to push and discuss with the surgeons to get the largest valve they can, because bioprosthetic valve will deteriorate, and we will be in need to correct this stenosis and these gradients. And if we compare that to going back to surgery and do a second operation versus TAVI, obviously the valve-in-valve has low risks of pacemaker and atrial fibrillation, shorter ICU stay and hospital stay. However, with redo, if they are able to get a good result, we have less chances of getting a severe pacemaker prosthesis mismatch and lower rates of paravalvular leak. And these results are also confirmed with this meta-analysis as far as the mean residual gradient and the mean gradient, which obviously, if you can get a good surgical result, will be better in comparison to having a valve in a previous implanted valve. So I would say, finishing with this last slide, that there are many unmet needs that need to be addressed in the future when we do valve-in-valves. Of course, I would start with the bicuspid, which is, of course, used in occasionally in our patients, but there are, especially when they have RAFI, they're not very calcified in the RAFI, but still there are unmet needs that need to be addressed, and trials in order to be able to treat patients correctly. And of course, we can prevent or even better image and do better as far as preventing coronary obstruction, both in degenerative valves and valves-in-valves, degenerative valves-in-valves, and also in native valves. Well, I will finish here because of the sake of time, and thank you very much, and congratulations for your Congress.
Thank you very much, Manoli. This has been really great. And maybe we have one comment by Dr. Zarifis, if he has one. I would like to ask specifically the question of the break of the valve and the PPM. I think there was a lot of theoretical hype about that a couple of years ago, several years ago maybe, but I'm not sure we need to break many of the valves in the end of the day, particularly if those valves are of excess of 5 years after surgery, because usually PPM, clinically significant PPM, it presents soon after valve replacement. The patient never gets very well or whatever, but if the patient gets really fine and goes, many years without, it's a little bit of a clinically doubtful that the PPM that we detect or we project 10 or 15, 12 years later has anything to do of that sort of importance. Maybe a few comments, one last comment before you go, Manoli, and maybe Dr. Zarifis.
I agree, George. It's rare that we had to do the procedure. We never planned it before actually seeing the results of the gradient you have after you already implanted. If it is an acceptable gradient, which is similar to the gradient we had after the surgery with the first echo that was done, then we accept the result. But if this is significantly higher and we cannot achieve an acceptable gradient, then we have to do it. I think I have done it maybe like 4 or 5 times in my procedures that I have anticipated, that I had a good result and I didn't. And it's always that you had small valves with some tissue, thick tissue inside. I mean, that's my experience. I would say yes.
Yeah, very well. Understood. Okay, let me also remind the audience that you can send any questions or comments via the chat, which I have right in front of me, and I will bring them up for discussion as they come. And that was something that came up already. Great, thank you so much, Manoli, and again, congratulations for the great program you have set up at Sotiria University Hospital.
I have to go to another meeting now. Thank you very much. Thank you.
Thank you. All right, now let's move on. We move on and invite, well, interestingly, another friend of mine, Dr. Kassel, University Hospital Zurich, Head of Structural Interventions. He's going to talk to us about a very challenging, a very interesting subject, TAVI for isolated aortic regurgitation. That's a new frontier. Let's see what are the current best practices and what are the unmet needs. Thank you so much for joining here in person.
Thank you very much for introduction, George. Yes, my topic is treatment of insufficient aortic valves. And so I think currently we don't have perfect options for transcatheter treatment of insufficient aortic valves. And as it is like this, it needs a heart team discussion what to do with this kind of patients. In my opinion, in low-risk patients, still open heart surgery is the way to go. And but in patients who have higher risk for open heart surgery, yes, transcatheter option also here should be discussed. What is necessary for treatment? Most valves need calcification. We have to understand the amount of calcification in a valve. So if there is some calcification, treatment is really feasible. Is there no calcification, it becomes challenging and perhaps also dangerous because of valve migration or embolization. And also another topic is aortic annulus size as one of the reasons for insufficiency. It could be a dilated aortic annulus, and the valve is because of this insufficient, and we have limited valve sizes, transcatheter valve sizes. So here the heart team discussion should have the result, what is the best way for the patient, surgery or TAVI. When we decide for TAVI, we have to understand how to anchor our valve, and of course, we have to choose the right valve. And so as I'm very experienced with the balloon expandable SAPIEN valve, my choice in this case and my experience, what I can talk about is with this valve. So what are the topics, additional topics perhaps, when we treat insufficient valves? So the height of implant is a topic. And so I try to implant, especially in insufficient valves, the valve very high. In this situation here, it's on the left side, the green marker. I implant the valve at least 80-20, perhaps 90-10, perhaps I go really to the border if possible. I explain you why later. So with the SAPIEN valve, we discussed this a few times also this today. You have the option to undersize, but also to oversize. And years ago, we published this sizing chart with when SAPIEN came on the market. So SAPIEN, what was new with SAPIEN 3 in comparison to XT, you can really oversize this valve. And it is helpful also here in treatment of insufficient valves, because I think at least, depending on the calcium amount, we need 10% oversizing in the valves not really calcified or severe calcified or moderate calcified. And then there are, with SAPIEN, I use deployment techniques like I flare the outflow of the valve. Why I do so? It is shown here. I place the deployment balloon a second time. I did inflate a second time with a higher volume, and to flare the outflow of the valve, flare the top of the valve. And why I do so? You know, while systole, the valve open, and embolization will not happen towards the aorta once the valve is implanted. But in diastole, the valve is closed and pressure comes from above and pushes the valve towards the ventricle. You have to understand this. And when you flare the inflow, it becomes more difficult for the valve to go through the annulus down. There's another technique, as you know, when you see paravalvular leak, very effective, is to do the flare at the opposite side of the valve, at the inflow side. So here, when you flare the inflow of the valve, you get to a much better sealing, especially when you don't want to give more pressure on the annulus. Very calcified valves, you see there is still paravalvular leak. An effective tool is go towards the ventricle with the balloon, inflate a second time with a higher volume, and flare, open only the inflow of the valve. So here's an example. High degree aortic insufficiency, calcified but not too calcified valve, and a mean annulus diameter of 27.5. So we implanted a 29 valve, in this case, to have enough oversizing. This is implantation. 80-20, as I told you, is our target. Then, second inflation of the outflow, the top of the valve, so it becomes a bit flared. This is the result then direct after implant. And you see that the valve becomes this shape. And also in echo, it was a good result. And when you see this afterwards, when you do a post-CT, and we did it here 3 months later, the valve is flared, especially in the small diameter of the valve, not the long diameter of the annulus. It is in most cases oval. And you can imagine when the valve frame has this shape, it becomes more difficult from the pressure to push the valve through the annulus. Same technique we use also for mitral valve. Kostas knows this. But you can use this also for the aortic valve. So on the market now is Jena valve has a CE mark now. The valve is not really on the market in Switzerland. We tried to get the valve, but until now it was not possible. Only the study sites currently get this valve. What is special with this valve? We know this valve from years ago. It was available for transapical treatment. Now it's available for transfemoral treatment. It has 3 arms which you place into the cusp, and it's clipped in the 3 cusps, and it's anatomically aligned. It's a very interesting concept. It works. But also here there are some limits with this valve, because limit in sizes. The range for treatment here is up to 27, and insufficient valves are often bigger than this. And also the catheter deployment system has a very stiff, long tip. And we know this from years ago when we used Centera. It becomes then difficult to align this valve, and only it is usable in patients with special anatomies. A lot of patients are screened out, and you cannot treat them even it has this clip mechanism. But very interesting concept, and we in Zurich we want to start with this, but at the moment it was not available. The preliminary data are very promising. I think in the US there was a trial, FDA trial. I don't know if it's finished now. This is my last slide. That's my team. Yeah, thank you.
Marcus, thank you. This was a tremendously helpful presentation. So do you think this, the question that we have is that, is there a simple rule through which we can say, actually two simple rules. One simple rule to say, yes, this could be done, and no, this could not be done. And then we can refine the techniques. But obviously this is for patients who clearly in the very high risk for surgical repair, because this is a little bit off-label, I would say, approach here, no?
It is still off-label, not for Jena valve, but as I told you, it is not free available at the moment. I hope it changes. And it's only, as I pointed out also, it is for patients with high surgical risk, perhaps no surgical option. And for me, it's this is a rule. I don't accept a patient who only has the wish to get a transcatheter valve.
That's what I wanted to come across and be very clear about that. And clearly having some calcium is always helpful. That would be, if there is zero calcium, is there still a possibility, or is mostly
there is a possibility. The risk is the less calcium you have, I think the risk for embolization is then much higher.
Yeah, so there is
that's you have to figure out really what is the risk, and when there is no calcification, really you have to oversize more aggressive, and this flare of the outflow, I think while the talk I said inflow, but it's the outflow, flare of the outflow is really helpful in anchoring. And with this technique, you don't give the whole pressure on the annulus, because once you do too much oversizing, then you see more annular rupture. So yes, you have to. This is a technique to handle this in patient without good other options, let's say.
And do you go by the volume and the visual, or do you also correlate with a pressure? Do you have like a manometer that you also see what pressure of the inflation is going, or not really? You just go by the visual flare?
So I go by the more or less by the visual flare. It becomes very difficult when I have a very experienced partner, so we are like an old couple. Then yes, he also tells me, oh, there's no resistance, or there's a lot of resistance. No, I have to stop.
Right.
But then in this situation, yes, you can use also the pressure, but we don't do it routinely. But for me, I look how the valve looks like. But in the coplanar view, you don't see the flare this much. You see a little bit. And when you see this little bit happens, that the top is a bit bigger than in the annulus size, then this is in most cases good enough. And as I showed you, the oblong axis, the small axis, it becomes more bigger. I think also I can explain there is more room for the valve frame to open. So, yeah.
Yeah, I mean, thankfully, the AI patients tend to have on the high size annulus most of the time. So all this, if you have a combination of AI and a medium or small size annulus, then you have a problem, because all this oversizing may be detrimental. But most of them have big sizes, maybe because of the pressure that is going towards the cusps and dilates over the years. Who knows, or maybe something genetic. We have a question, I think, from the audience. Dr. Vlachoyannis, who is the new chief of interventional cardiology at Euroclinic Hospital. Go ahead.
Thank you. Hi, Dr. Kessel, Marcus. So, first of all, the cutoff, do you have a cutoff for the big annulus, right? We're talking about Edwards, 29. What are you looking at anatomically to say?
So I go not above 29. And when I do 29, I add volume to the deployment balloon. And I showed this slide, this oversizing concept, what we did some years ago. You can, when you add 2 milliliters of volume to the deployment balloon, roundabout the valve becomes 1 millimeter bigger. This is not endless. And in this case, 29, we add then 4 or 5 milliliters more.
All right.
And we know perhaps this we deploy until we see a little bit of flare in a first step, and then we place the balloon higher in the outflows, and we give the full amount there and open the valve then with this 5 more volume. And
okay, so the cutoff, if I understand correctly, the cutoff is 29 diameter. This is on the CT. That's the cutoff.
Cutoff for.
Okay. In flaring, sorry, I have a couple of questions. Flaring is a standard procedure, so you flare the outflow always?
No, it's not a standard procedure. It is in this situation only for better anchoring. And we do this in insufficient valves and borderline big valves.
Yeah.
In both to have a better anchoring of the valve itself.
Okay. And did you have a pop-out ever? Have you experienced any pop-out while you
No.
do this second maneuver? Or
Because we do, the pop-out happens only when you have, when there is a beat coming through the rapid pacing. It will not pop out once it is deployed there.
Great. Thank you.
Thank you.
When you get Dr. Sparias, and then we'll have a couple of more comments. Marcus, why don't you join me here and sit around for the rest of the session? So this way we have one more spare microphone to help. You can just push that button there. Great. Excellent. Okay, go ahead.
My little comment is that when you have aortic regurgitation with no calcium, I think when you use a balloon expandable valve, you should use 20% oversizing, not 10% oversizing. I think 10% with no calcium is little, and you should probably get the oversizing of the self-expanding valve, which is minimum 20%. And when you use an self-expanding valve, then you should again have a little more oversizing than when you use them in calcified leaflets. The other difference between the two is that I think if you use a self-expanding valve, especially the Evolut, and you open the device and you see that you don't have aortic regurgitation, then by opening the device very slowly, you release a post, and then this comes in touch with the aortic wall, so you get this extra stability of the device so it doesn't pop up easily, because you get this extra stabilization. But for the balloon expandable, in cases with 0 calcium, I think if you want to be safe, what's your opinion? You should go to 20%.
So at least 10% is overall, so don't go below this. But most of the cases we do, they have perhaps a little calcification. When you go to 20%, it is, the rupture is much higher of annulus injury. Here, I think with this double inflation, with the, perhaps it is good to have the 20% at the outflow of the valve, but perhaps not good to have it in the height of the annulus because of rupture. I'm sure when we post-dilate the upper valve frame, it becomes much bigger than this 10%. You understand this concept is to avoid too much pressure, giving too much pressure on the annulus itself. But when you look at the top, the flare top, this is perhaps more than this 20%. So this is a concept what we have. We don't want to give the full pressure on the annulus. That was
5 and up. Yeah. Well, I mean, it's interesting. You know, you seem to imply that the more pressure is given in the higher part, in the last part, just because you seem the balloon is bigger there.
Yeah.
But I would say that the pressure is the same because it's a liquid, has a pressure always the same. It's just that area is more compliant and gives more, and the annulus just doesn't give.
Yeah, that's right.
Or something, but that's why some people advocate this manometer. Practically, I don't know how to figure out the manometer so easily during the case all the time because, you know, you have to close the hand injection towards the manometer. There's some confusion there sometimes. So I don't know how accurate, practical that is, but others use it like all the time. But I mean, you don't. So there you go. I think it's a
yes,
good
but it's, you know, it is
a
a technique to overcome this whole problem. It's not a device made for this.
Yeah,
but
exactly.
it is a metallic stent. What you can change also the shape of this stent, as we do it also in coronaries also, and you can do it also in aortic position. And in this example, we had 10%, it was a 27 annulus, we had a 10% oversizing with a 29 valve plus 2 in the upper part. We implanted it first in the annulus with nominal volume, but we flared then with extra volumes at the top. So it's a working concept. That's the reason why I showed you this. Yeah. It reduces perhaps the risk of annular rupture, and you can handle perhaps this kind of patients with no other real good option.
Yeah, very well. By the way, any comment from Dr. Zarifi? Go ahead and tell us.
A small comment that we should have a very good knowledge of the anatomy of the patient that we are having, because all the time we are going in the risk of the rupture and the bad result with the residual regurgitation. But we need to have in our mind the stage of the patient and the age of the patient as well. And sometimes we could leave at the end, for the good of the patient, a small residual regurgitation, as the patient will have a very good standard of life with the new valve that he is having, if it is some 85 or 87 years old. But we should all the time be in, especially in our centers, most of our centers in Greece are mid-volume centers, so it will be difficult to have off-label implantations of valves. So at the end, we will not have the experience of professor who's doing that in many cases.
That's right. Final comment or question from the audience, and anyone through the chat, please go ahead.
Dr. Kılıç from Turkey, and congratulations for the excellent presentation. As you know, there is an additional balloon expandable valve, MyVol valve, and it has got additional higher sizes like 30.5 and 32. So you can, if you have ability to use it, you can use this additional size of balloon expandable valve. But my question, especially for the traditional 29 millimeter adverse valve, for example, what is the upper limit of your contrast volume? Only 2 milliliter to enlarge it, or what is the upper limit
it is,
for you?
You know, I showed this sizing chart there. What we did there, we added in 29 4 more milliliters, and we could show then in post-deployment CTs We did these afterwards, we measured the frame, and we could show that this, the valve frame became 2 millimeters in diameter bigger, with 4 more milliliters. After this, we published this, especially in the US. It became a hype to over-deploy, and some pediatric cardiologists in pulmonic place, they over-deployed with 8 or more milliliters. And when we did the first cases, we were afraid that we create central insufficiency, but by chance, the leaflets from the sapien valve are this long that coadaptation still happen when you make the frame much bigger. So there is not a central gap. What happens, even what I heard in this much over-deployed valves. But everything has a limit, and you make the valve itself, the opening, not much bigger. That's right, because what happens, the leaflets, they became tapered afterward. After in high, when you make the frame much bigger, the valve itself becomes not this much bigger. But it's not the topic, the main topic in this. And I think also for durability, perhaps limit should be in this range. 4 milliliters it's a lot. Yeah. But we treated and published also one case with 1,000 square millimeters with the sapien. So you can do it also, but there you need calcification. And with this technique to flare top and the bottom, you can handle also very big valves, but also sure with other balloon expandable valves. There's perhaps, I don't have experience with Merrill valve, but should be very similar.
Well, listen, this was a tricky subject. That's why we have a super expert with us and many questions from many places, quite frankly. And let's go now for the next subject. And we're going to go all the way to the other end of the Atlantic Ocean, actually the Gulf of Mexico. St. Petersburg, Florida, a proud leader of the Greek American community, interventional cardiologist Dr. Marmagiolis. Welcome to the conference. Great to see you. Another friend and a fellow leader of AHEPA and our societies of cardiology and medicine in the United States. He's going to talk to us about structural procedure in cancer patients. And I can tell you, sounds a bit unusual, but if you look at my list of patients, there's a lot of people who have this diagnosis. Then that's why they're not a very good surgical candidates. So the very specific aspects of taking care of such patients, and Dr. Marmagiolis is going to take the lead in explaining what and how. Thanks for joining live.
Hello, everyone. Very nice to see you, Dr. Dangas, and thank you, everybody, for being here. Special thanks to Dr. Sparias and Dr. Stathogiannis for the kind invitation. I'm very honored to be invited among all of you. I will try the next 10 minutes to convince you about not only the safety, but the important value of structural procedures in cancer patients. So, first of all, I'm a part of I'm faculty at the University of South Florida, but my main research is through the MD Anderson Cancer Center, and most of the things I will present today has to do with the research being done at MD Anderson. So the three main structural procedures that we have researched extensively for cancer patients are the most common procedures that I believe all of you are doing, which is the TAVR, MitraClip, and Watchman. So why don't we do those procedures in cancer patients? There are several reasons why those patients have not been included in any of the randomized controlled trials in the past. There is a perception, which is an old perception, that those patients, they don't live long. They think that those patients, most of them, they will die within the next months or at maximum a year. everybody thinks those patients are the procedures are very risky because of the low platelets and hemoglobin. People believe that they cannot even take an aspirin because they will bleed to death. And also, since we did not have those patients included in the major randomized trial, people would say, well, we don't really know if those procedures even work for the cancer patients. So I will try to talk about each of those subjects and try to prove that this is actually, none of them is accurate. So first of all, in the United States, this is a little bit of an old slide. We expected to right now have much more than 20 million patients with who are cancer survivors. So as you can see in the first slide in the left, the first table, over the last 10 years, the survival in cancer patients has been increasing. There has been a race with new cancer treatments and surgeries and immunotherapy. And every year, this table is moving to the right. So on average right now, the survival, we're talking about 5-year survival, which you understand is it's very important. We're not talking about 1 month or 1 year. We're talking about 5-month survival. Has moved from 50 to 67, and it is expected in the next 10 years to go above 75%, which is very close to the expectation in the normal population. Also, the number of the cancer survivors are increasing. So whether you like it or not, in your cath lab, you will be receiving patients with cancer. And that's why it's very important to know what we need to do differently in those patients. Now, first of all, sedation. The main problem we had in the past with sedation was that those patients need to be intubated, go in deep sedation. And as you all know, it doesn't only increase the morbidity of those patients. Those patients may not come off the vent. They are too frail, and they may end up with complications from the sedation and intubation. And that's why we have moved to conscious sedation in all 3 of those procedures. So in most centers right now, we use conscious sedation for all those 3 procedures, for the TAVR, MitraClip, and Watchman. So of course, TAVR, we don't need to have transesophageal echocardiogram guidance. And as you can see in the first table, most of the centers are moving away from even deep sedation. So we do just conscious sedation, same way that we're doing with coronary arteries. And this number is increasing year by year. The complication rate, if people believe that patient moving may have complications, it has been extensively studied. And we know that those patients that don't have more complications than the ones that we deep sedate. Same with MitraClip. This was our study that we showed that a comparison with Dr. Selin Cirgulu from Turkey. We compared moderate conscious sedation versus deep sedation. Again, all the outcomes were excellent. We did not have any statistical significant increased complications, not even any signal towards that. And the other thing we do with MitraClip, because we need to have transesophageal echocardiogram that by definition we cannot do just conscious sedation. Over the last couple of years, we're using a lot of the 3DIs, actually they call it 4DIs right now, which we do not need to have a TEE during the procedure. So we can have the ICE catheter guide the whole procedure. And the ICE catheter can stay in the right atrium for the transeptal. And then we can advance the head of the ICE in the left atrium. And as you can see in this publication, we have great pictures of the 3-dimensional pictures of the mitral annulus, the mitral leaflets, and we can position our MitraClip in a great position. Same with Watchman. We can do conscious sedation. This was another paper of ours that we showed that conscious sedation is feasible, very safe for the Watchman procedure. And I believe most of the centers now are using conscious sedation for Watchman. But the same token with the MitraClip, most of the centers now are using 3DIs to guide the Watchman procedure, so we can avoid TEE, and we move from deep sedation to pretty much conscious catheterization. The difference is that in this procedure, we are moving the head of the 3D ICE catheter to the left upper pulmonic vein, and it gives us a very, very nice view of the appendage. And as you can see in this in those pictures, we can position the Watchman device very nice without having to put even a transesophageal echo. The other thing is that for the cancer patients, it's very important we don't keep them in the hospital for too long. Most of those patients are immunocompromised. We may do the procedure very well, but maybe if we keep them for 2-3 days, they may get hospital infections. So we want to get them out, if not the same day, earlier the next morning, because every day they stay in the hospital, they are at risk of getting infections. So the two publications, the right, this was our publication that we show the feasibility for MitraClip and Watchman. Again, those two procedures, as you know, is done with the venous access, and we're very comfortable discharging them the same day. But for the TAVR, this is a publication that was pretty much, none of us was comfortable doing it because of the arterial access and the arrhythmias may happen. But during the COVID period, there was this multi-center trial that they tried to get the patients out of the hospital the same day. And it pretty much, that was a gift for the cancer population, because that showed not only the feasibility, but the safety also of discharging patients the same day. So this is very handy for the cancer patients, because after we do the procedure and we check the patient by the end of the day, we feel very comfortable getting them out earlier rather than later. The second reason why people are scared of doing those structural procedures in cancer is there is this false idea in the interventional community that if the platelets are less than normal, you cannot give aspirin, you cannot give Plavix. So we did a SKY consensus statement 6 years ago, which, by the way, we'll have a new one next year, that we pretty much showed from the research from MD Anderson that aspirin is safe to give if the platelets are more than 10,000, and dual antiplatelet therapy, meaning aspirin and Plavix, after 30,000. If you look at any patient who comes to the cath lab, you very, very rarely see anybody less than 30,000 platelets. So a normal thrombocytopenic patient who has cancer with 80 and 90,000 platelets, it's treated in our lab and in most of the cardio-oncology labs like the platelets are normal, like they are 200,000. So interventional cardiology should not be scared of the low platelets. There is enough data out there to prove that those are enough to get the patients out with aspirin Plavix. Of course, the even stronger antiplatelets like Brilinta or Effient, or a combination with anticoagulation, is more dangerous. But DAPT is perfectly safe for patients with platelets more than 30,000. I will talk to you about two landmark studies that they were not made specifically for cancer, but they have a dramatic impact on the treatment of cancer patients. So the POP-TAVI that you all know, randomized aspirin versus aspirin with Plavix, and it showed that aspirin is perfectly safe after TAVR. Although this trial was not done specifically for cancer, this has changed dramatically the number of patients going evaluated in our valve clinic. Because before, the cancer doctors were worried that those patients would not be able to take dual antiplatelet therapy after TAVR. So right now we know that patients with TAVR can go home only on aspirin, and that has increased dramatically the number of TAVR of cancer patients who are getting evaluated for TAVR. The second very important, not trial, but approval, is that the Watchman device traditionally required 45 days of oral anticoagulation, either with warfarin or with the novel antiplatelet agents for 45 days. This has kept almost all the cancer patients out of the cath lab because cancer doctors would not want to risk 45 days of blood thinners. So when Watchman Flex got an approval by FDA to not necessitating anticoagulation, but only aspirin and Plavix, that again was a big bump on the number of cancer patients sent to our valve clinic and assess them for a Watchman device. And between the cardio-oncologists, we believe that in the future, that would probably be the standard of care to any patient who is diagnosed with cancer and is expected to go in a chemotherapy that would expect to decrease the hemoglobin and platelets. So maybe in the future, we will see prophylactic Watchman in any AFib patient going for chemotherapy. Now, the last question I will have to answer is, okay, this all looks very nice, but there's no data on cancer patients. So I will show you some of the data which is out there for structural procedures in cancer patients. So this is a meta-analysis we did with Dr. Tutuzas and the team in MD Anderson. That was a meta-analysis comparing surgery with TAVR, like a surgical versus TAVR replacement versus medical therapy. So the concept that patients will do well if we don't replace the valve because it's not going to be any different. You can see in this Kaplan-Meier curve that if a patient with cancer comes with severe aortic stenosis and you let him on medical therapy, its life expectancy is dramatically low. So putting a prosthesis on this patient, it will almost double the probability of living longer, and it will double his life expectancy. So TAVR does work at the same way with the non-cancer population. It works the same way to the cancer population. Now, this meta-analysis showed that TAVR versus surgical replacement has, first of all, much improved short-term mortality, statistically significant. The risk of stroke is statistically significant less with TAVR versus surgery. Kidney injury is significantly better. And the risk of bleeding, which was a big surprise, is not increased. So TAVR compared to surgery does not really increase bleeding, and it does not increase the risk of pacemaker implantation. So based on this meta-analysis, we proved that TAVR and surgery are pretty safe, and TAVR is actually seems to be safer than surgical AVR in cancer. Now, how about MitraClip? There is very little data out there for MitraClip. This is the data from a 1-year follow-up in patients with MitraClip. We see there was a 2 times more mortality with MitraClip in patients with cancer. But as you can see, the multivariate regression, it is mainly those patients who are very sick, the presence of cancer, as well as the kidney injury or very advanced heart failure with significantly improved BNP. That shows that the cohort of this trial is the patients that they are very, very sick and they did not have pretty much any option to survive. Now for Watchman, Watchman in patients with AFib, we have proven with everyday practice, but this is another trial that compared the comparison that shows that Watchman is perfectly safe to the cancer patients, no different than the non-cancer patients. So what are other considerations we have in a cancer patient? So what is, when you do a procedure in a cancer patient, what is different compared to patients without cancer? So number one is sedation. So everybody who has cancer, you have to use the least sedation that you can. So of course, like I said, conscious sedation, but if you can move to local anesthesia, if you can try to avoid transesophageal echo, that is even better. So using 3D ICE, if it is available in your facilities, is a game changer because patients are awake throughout the procedure and then they recover very fast and they go home same day. The second is same day. You try not to keep the patients more than 1 day in the hospital and try to see if you can recover at home outside of a hospital environment because of risk of infection. Access is another consideration. We do a couple of things differently in access in cancer patients.
Να συντομεύουμε λίγο.
Okay, yeah. I could leave this as my last slide. So access-wise, we obviously we do pre-close like everybody else in TAVR for the arterial access. But we always get a forefront access even in a contralateral groin or radial. The reason is we always want to have an access in case we have a major complication, the bleeding, because we can either go from up and over from the groin, or right now we have the very long shaft balloons that they are made for radial to peripheral interventions. So even from the radial, we can advance the balloon in the iliac in case we have a bleeding in order to prevent a major event. Now from the veins, I know that all of you are using different practices for vein closure. Some use figure of 8, some use 1, some use 2 percloses, some use full reversal or half reversal after the case. In cancer population, this is a very personalized approach. So for the people with low platelets, we try to give 1 or 2 percloses, and we usually reverse aggressively with full protamine. But in people who have a hypercoagulative state, like pancreatic prostate cancer, we try to pretty much use something minimum. We don't reverse, and we usually do just a figure of 8 or 1 perclose. So try to avoid any deep venous thrombosis. And again, antiplatelet coagulation, for every of the 3 procedures, we use minimum antiplatelet and minimum duration. So I had some cases, but I guess I've gone over the time. So
yeah, this has been tremendous, Costa. Very grateful for this talk. And indeed, the cancer patients are deemed high risk for surgery. There's no question about that in general. So we really need to pay more attention into preventing these types of complications of the anesthesia, of the perioperative bleeding, as well as the postoperative bleeding complications. And obviously, we focus in quality of life in such patients, and clearly any morbidity from the procedure would be counterintuitive. So when I have a higher safety profile. I want to invite a comment perhaps by Dr. Zarifis while we are setting up the connection with our next speaker, Dr. Dvir. Dr. Zarifis?
One question, if you want to comment on that. Thank you for the excellent talk and the data. If you are changing your strategic in patients with cancer that they are not already in having their surgery, if you will treat them firstly with a TAVI or another structural procedure before going for the main surgery for the cancer that they have. If you are changing your strategy in this kind of patients, sometimes here in Greece, some of the doctors, they are asking, oh, we are not want to do the surgery for this patient with so severe aortic stenosis. Then what is your plan on that?
That's a very good question, and we always have this question from the oncology colleagues. Not very long ago, maybe a year or 2 years ago, we would, if the patients we thought they would not go through the therapy, we would just balloon. We just do like a balloon valvuloplasty and let them go for any treatment, any surgery, and bring them back to do the TAVR later. But again, after the POP TAVI that pretty much showed that aspirin alone is safe, we feel it's not going to change anything, because most of the surgeons, even the thoracic and vascular surgeons, are very comfortable operating with the baby aspirin. So over the last year or two, we pretty much try to do the TAVR early on. So we allow the patients to go through that journey of cancer therapy with surgery, as you know, treatment, radiation, without having to go back and forth.
Okay.
So this has been a change over the last couple of years.
Thank you.
Great. Thank you so much for this contribution. Costa, you're welcome to stay on. I also see the next chairman, Professor Tutusas, has been joining. Welcome to chip in any comments after the next session. And obviously, this is going to help us a faster transition. We're a little bit strained for time. Let's go from the Gulf of Mexico all the way back to East Mediterranean, Israel. My friend and world expert in high-risk TAVI and leader of the many TAVI programs and now a faculty in Israel, Danny Dvir, is going to talk to us about the leaflet modification techniques in the TAVI procedures. Danny, thank you so much for joining live.
Thank you so much, Job. I think I enjoyed the previous talk tremendously, and from that to another challenging population, patients that are at risk for coronary obstruction in TAVR procedures. We know how to identify that population nowadays. We know how to deal with that population well. In the early days, we would say this is a too risky population for us, maybe for medical treatment alone, but not now. We need to understand that coronary obstruction is not another adverse event in TAVR procedures. It's a devastating complication with high mortality rate, and it is very difficult to salvage sometimes these patients when that complication occurs. We know how to identify patients at risk for coronary obstruction, and this is a classification that we put a couple of years ago. Basically, it all depends on the relationship between the deflected leaflet and the anatomy of the patient. Obviously, we do not like low coronary ostia, we do not like narrow sinuses, but it is all about the relationship between the size of the valve that we're going to put inside and the location of the deflected leaflet afterwards in relationship to the coronary. And I really suggest that you can read all about it in our different papers. The most common method nowadays, and probably in upcoming years, to prevent coronary obstruction in TAVR procedures in cases at risk for an obstruction would be stent techniques, which we call Finley or snorkel technique, in which we have a stent waiting in the coronary tree undeployed. We are doing the TAVR procedure, and after the TAVR, we pull the stent to the exact location where it needs to deflect the leaflet. Obviously, that method is completely off-label. Stents are not designed to deflect leaflets. They are designed for treating vessels with atherosclerosis, and we have many issues related to that technique, and the durability of that approach is also questionable. The ability to go back to the coronary tree is also not so easy. And there are some issues also with delayed coronary obstruction, which is it's a fascinating topic in which we can finish a procedure like that after having protection, thinking that there is no coronary obstruction, understanding that the flow is good, patient is doing well, but suddenly, after a couple of days, patient just collapses and dies. And this is, in some of these cases, delayed coronary obstruction, which is a big problem for the wiring techniques. And it's also a suggestion to be more active in patients at risk for coronary obstruction to deal with that issue. Other issues related to the snorkel or chimney technique relate to the fact that there is some crimping of the leaflet towards the ostium of the coronary, as you can see in that particular case. After 1 year on the right side, there is a delayed obstruction in the right and also with stenosis in the ostium over there. Also, stent jailing, while you do protection with the stents, is something that is not rarely described, an inability to retrieve them. So we need to understand that the issue of coronary obstruction is not related to the coronaries, and in somewhat it's not related to the TAVI that we deploy, it's related to the leaflet that is being deflected. In nature, we have wide sinuses in the aortic root. In diastole, the leaflets are close together, and these sacs are filled with blood, and they are allowing the coronary tree to have a lot of blood flow. But what we do in TAVR procedures, also in some surgical AVRs, is that we modify that anatomy in diastole, in which there is not a lot of room. The neosinus is completely different. So we need to change that route in some way in these cases. And the most basic way would be to tell the origin of the problem. The origin of the problem is the leaflet being deflected. If it's native AS, it's the native aortic valve. If it's bioprosthetic valve, it would be the bioprosthetic valve tissue. So from that came the basilica technique. We know now that a single leaflet tear is quite effective in preventing coronary obstruction, because after we deflect that leaflet, it creates a gap between the parts of the leaflet. Obviously, we need to do it in a very controlled fashion. The basilica technique was described years ago. It's around 6 years almost since the first procedures. Couple of hundreds, many hundreds of procedures are performed worldwide. Unfortunately, it doesn't seem to grow dramatically in practice. You can see how after you implant the TAVI device inside the surgical valve that has the leaflet tear, it allows for the coronary flow. So the basilica technique really pushed us towards a nomenclature related to a single leaflet. We need now to treat a single leaflet. So we know how to view each leaflet in the anatomy of a patient, in front view and side view, as you can see here. And we also understand how these leaflets are coming along the perpendicularity plane of the aortic root. So basically for left cusp, the side view is in iliocranial, the front view is in severe arteriocardial. We also know now about the fact of coronary ostial eccentricity. There are cases in native anatomy and some in bioprosthetic valves, especially for RCAs, in which the leaflet does not come in front of the middle part of the leaflet, it comes eccentric. And in these cases, obviously, the leaflet there could be eccentric as well. So we have a lot of TAVI bioprosthetic valves nowadays, many bioprosthetic valves that are TAVI devices, and when they will fail, sometimes it will be an issue to prevent coronary obstruction. This is an example of a patient with a failed core valve that I treated around 5 years ago with a double basilica. Very, very complex procedure to do. Each leaflet needs to have 2 catheters allowing for the laceration at the same time, and then eventually this is the TAVI. The patient did well. But what I'm trying to convey in this slide is that this is sometimes a very, very challenging procedure to do. Obviously, we need some easier tools, dedicated tools that will allow us to do the leaflet laceration quickly and safely, and hopefully without the need for electricity. So I'll describe one tool that is increasingly in practice within a clinical trial that is called Shortcut. The Shortcut device, I'll show you a short animation. It goes through a femoral sheath that is 16 French in size. You cross the aortic valve, and when you take the sheath out, you have the device being deployed in the aortic root. So you have a positioning arm that now we will focus on it, that needs to sit behind the leaflet of interest. And in this case, we need to bring it behind the left cast in order to do left laceration. So this is what we do. So we bring the positioning arm with rotations and manipulation. There are dedicated knobs in order for you to do that. And in a particular time, you activate the splitting element, which is a small knife coming from the LVOT. And then the leaflet is pierced. And after that, you just push on the wire, the LV wire, the gentle retraction of the system, and leaflet splitting is being performed. So we published our 8 original compassionate use cases with the shortcut device, and now it was performed already in around 45 cases worldwide within the trial. Hopefully that device will be available to many centers that want to use it. Here you can see several examples of leaflet laceration with splitting with a shortcut device in bench testing. And this is an animal example, a pig. And you can see data coming from the 8 cases. It was published in JACC Intervention. Some of them are extreme cases at risk for coronary obstruction. Maybe I'll focus on one particular case. You can see a patient with a Magna device, obviously extreme risk for both RCA and left main obstruction with valve in valve. That patient had a shortcut for both leaflets. You can see that we had some protection for both coronary trees, the left and the right, which is uncommon in basilica, in shortcut procedures anymore. But we did it, that was one of the first ever cases performed with shortcut. So the device lands behind the left cusp, and the splitter is activated in the central figure, and then the left cusp is being split on the right side of the screen. And next we go to the right cusp. In severe areocaudal, we see the right cusp on the right side of the screen. And the splitter is activated and we split the right cusp. Later on, we just quickly reset the device, we withdraw it, we keep the LV wire, and we do a conventional TAVR procedure that you can see here on the right side of the screen. So there are, as I said, dozens of these cases that performed. Maybe I wanted to show another challenging case. This is a patient with a failed evolute 6 years after the TAVR procedure. As you can see, at risk for left main, you can see the left cusp going up and down and how it makes the case at risk for coronary obstruction. And in areocaudal, we see the right cusp going up and down. This is also a case for RCA obstruction. So RCA, right cusp laceration. First, we activate the splitting device. The right cusp is being split. Later on, we just rotate the knob and bring it to, let's see it in a second, we bring it to the left cusp. And we activate the splitting element and we lacerate it as well. The benefit of that dedicated devices is that they are more clear. You can see the setting inside the volute. Although the leaflets were in critical relationship with the ostium of the coronary, there is no coronary obstruction, and that patient was doing very well later on. And just before I finish, describe another potential usage of leaflet laceration that is not related to coronary obstruction. We call it aortic root tricuspidization, or ART. We know that in some bicuspid aortic valves, TAVR procedures may lead to underexpansion, to residual AR, or maybe to mechanical complications related to that, maybe to poor durability of these devices. And maybe lacerating along the raphe may allow for better TAVI deployment. So you can see an example of aortic root tricuspidization in a type 1 bicuspid pararafal laceration. The basilica technique in this particular case. Later on, good expansion of that valve. Here is an example of tricuspidization of a type 0 bicuspid, leading to excellent clinical outcomes. So I'd like to summarize that coronary obstruction is obviously a life-threatening complication, and leaflet modification, either with basilica or with dedicated device, I showed you an example of it, may lead to a reduction of the risk for coronary obstruction. And hopefully we can have these tools, and these will allow for expansion of TAVR for new target population that previously was considered to be complex to do and high risk. Thank you so much for your attention.
Thank you, Danny. That was really great. Dr. Dvir is a leader in the University of Jerusalem. A truly international session this one was, from different continents, and each one of them, friends and family of the TAVR community, I would say. Great, from the early days and the research and the proctorship, and now everyone a leader of different programs all over the place. That's great. Maybe Dr. Zarifis has a comment. I don't. We had a lot of discussion in the previous sections.
Yeah, I think so.
And I want to invite the next session to just sitting up at the podium, Dr. Katsianos, Dr. Pilatis, Dr. Sparias to join us. Go ahead, Yanni, go ahead with your comment.
No, I don't have, because we ran out of time, I think so. The talk, it was excellent. They gave us a lot of information and a lot of data, his data. He is the literature on that. So thank you very much.
Great, many thanks and congratulations.
Thank you,
we have also online, thank you, Danny. Thank you for joining live. We have Dr. Chapras and Dr. Tutusas as well. If they wish to participate in the case discussion, that would be great. I don't know if Marcus wants to join up, if have an interest to give us some more comments regarding this complex case we're going to see presenting, a patient presentation, imaging analysis, strategy planning, as well as expert comments by several of the faculty. This will be great. Dr. Sparias will lead this part. Go ahead, Dr. Katsianou.
Thank you very much. We'll participate because I think we are really late for the program. Because I will participate until 7, because after that we have in Hellenic Society of Cardiology another congress.
Yeah, that's fine, Costa. You take part of this one as much as you like, and when you go, no problem, the leadership here will continue, no problem. Okay, just carry on with the virtual participation.
Good evening, dear colleagues. Very happy to present the next case. A 77-year-old male patient, BMI 29.4, refers short of breath on exertions in the last few months near stadium 3. The transthoracic echo, severe AS and mild AR, AVA 0.5. We see the peak and the mean gradient with an acceptable LVEF of 55%. LV hypertrophy in the coronary angiography, mild to moderate atheroma, under 50% stenosis in the LAD and the RCA. The medical history, atrial fibrillation, COAD, Parkinson, renal stones with multiple lithotripsies, and the prostate hypertrophy. Euroscore 2, 2.11, STS mortality score 1.82, the STS morbidity and mortality at 10.6%. So we see the X-ray of the patient with the high gradient, the transthoracic, the parasternal long axis view with a heavy calcified aortic valve, and the very mild regurgitation. And here we can proceed to the imaging analysis, Dr. Tsiapas.
Dr. Chapras, via video connection.
Yes, I'm in the rainy Barcelona taking part to the European Cardiovascular Imaging Congress. And I like to honor this kind invitation and take part through my mobile as my computer has crashed. Anyway, the point of this case is that is a rather not so old patient, 77 years old, overweight, with comorbidities not refractory to any surgical operation. There is a clear image of severe aortic stenosis with a well-preserved ejection fraction, systolic function of the left ventricle. And as we go through the imaging, the different imaging modalities, we see that there is no huge calcium in the different part of the annulus and the aorta. Can we go through the next slide, as I don't have any presentation?
Can we connect the presentation of Dr. Katsianos, please, for the slide? Can we go to the center presentation?
Yeah.
I cannot see.
One thing we have to stop is that the elliptical scheme of the annulus and the left ventricular outflow tract, a rather small diameter, as I can see, a minor diameter of the annulus is 19 millimeters and the major 26. This elliptical scheme may be a risk for any percutaneous implantation. The valve is tricuspid, seems to be tricuspid degenerative. The size of the aorta is reasonable, and also all the diameter and dimensions of the femoral, abdominal aorta and thoracic aorta are also within reasonable dimensions. I leave to Dr. Pilatis to comment about the distance of the origin of the coronary vessels from the annulus and the possible techniques to be used. From the risk score, I had to say that it is not prohibitive for an open heart surgical operation. The only thing is the degree of Parkinson's disease. How much is the deterioration of the mobility of this patient? I think that apart from the scores we used, the degree of any other problems and comorbidities may play major role. That's all for me. So, Dr. Sparias, you can go on.
Yeah, it seems we have a problem with the presentation. Do you have your own presentation? Okay. But there are more slides in our central presentation. Why it stops here? There should be much more slides here. Yeah, it doesn't end here. There are much more after that. Anyway, it's a straightforward tri-leaflet valve, as you can see, with a lot of calcium in all three leaflets. And there is also, as you can see, calcium underneath a non-coronary cusp that is extending down in the LVOT. So that is the area of the annulus that has the calcium. It's oval shape. You see the anatomy is big, is wide, and the coronary ostia are high up. You can also see some calcium in the mitral valve annulus below, but obviously we know from the echocardiogram that there is no problem in the mitral valve. Nectarius, are you ready?
Okay. First of all, I want to thank Kostas Sparias and the rest of the organizing committee for inviting me to this really informative session. So let's go over the case briefly and see the clinical and the anatomic variation of this case. So we have a patient who is relatively not very old, 77-year-old, with maybe, because doesn't have a lot of comorbidities, so maybe has a life expectancy of more than 8 years. So we have to choose a valve that which is durable. He is relatively low surgical risk, so we don't want to give him another characteristic of high risk from the valve we put in. So we have to choose a valve with low risk, at least for paravalvular leak. He has a moderate coronary artery disease, so we have to choose a valve with good coronary access in case that in the future he needs a PCI to the coronary arteries. He has a small to medium aortic valve anatomy with a moderate calcification, so it's better to choose a supravalvular TAVI for better AV gradients. On the other hand, we saw that it has a short membranous septum, 3.4 millimeter of length. So he is at least at moderate risk for pacemaker implantation. So we have to choose a valve that we may precisely place it to avoid the pacemaker risk, implantation risk. And lastly, the patient has kidney stones. I would check him for hyperparathyroidism in case that he has to treat and avoid accelerate valve degeneration that hyperparathyroidism may cause. So from the anatomy that we saw has a small to medium valve with a mean diameter of 23, so has a pre-shallow ST junction. The coronary sinus, the sinus of Valsalva are pretty large, but we have to see that the coronary ostia have a very high takeoff, just below the coronary, the ST junction, as you see here, about 18 millimeters above the annulus. So this specific anatomy with very high takeoff of the coronary ostia at the side of the coronary of the ST junction, which is relatively shallow, has a good anatomy of the peripheral arteries, so I don't think that that will be any problem. And there's not much tortuosity or a lot of calcium, so peripheral access is pretty good. You see here the moderate calcification of the aortic valve, which is mainly at the leaflets and not at the annulus or below it. And you see here the high takeoff of the coronary ostia, which is above the coronary, the sinus of Valsalva, and just below the ST junction. We see it again here. So we have a moderate size annulus, as I described before, and a narrow ascending aorta. I would not choose the Evolut R in this case, which according to the measurements should be a 29 millimeter valve. And as you see, at the height of the coronary ST junction, the width of the valve is 23. If we implant it, it's 23 millimeter. And as we saw before, the the width of the ST junction is 25 millimeters, so there is only little space in both sides of the coronaries, at the level of the coronaries. Although here we have the posts, and but there is, I don't like if you have another option to have metal in front of the coronary ostium. So we'd go. The same applies for the portico valve, which if we implant it, we use 25 millimeter. But again, you see the posts are high and you have a lot of metal in front of the coronary ostia. And also we have a small aorta, and maybe we put if we implant, we put a lot of stress on the aorta because the width at that level is 41 millimeter, and we have an aorta of 27 millimeter at that level. So we go with the SAPIEN 3, which actually I think it's an excellent valve for this case. Has a low risk of pacemaker implantation if we implant high enough. Very low risk for paravalvular leak. Has a great coronary access, because as we see here, the valve has expanded valve has 18 millimeter of length, and if we implant at 3 millimeter below the annulus, so we have 15 millimeters above the annulus, so we're way below the ostia of the coronary arteries, which are 17 to 18 millimeters above the annulus. The only negative thing is that is intravalvular, so have higher AV gradients, and if the patient goes for a future TAVI may cause even higher AV gradient if we implant another SAPIEN 3. And the last valve to consider is the accurate neo, which I think is the right valve to put in this case. It's a supravalvular, so we have low gradients, AV gradients. It's a very low risk for paravalvular leak, has a good coronary access, as we know, and a moderate high risk for SAPIEN 3 for pacemaker implantation, actually moderate risk. But if we put the valve at aligned, we don't put the post in front of coronary artery, I think we have very good result. And it's a good valve for future TAVI in this particular case with a SAPIEN 3 in case that we need to do that. So I think the final plan I would go with is a US ultrasound-guided femoral vessel puncture with pre-dilatation of the valve with 22 millimeter balloon, aggressive pre-dilatation for the accurate valve, implantation of the accurate neo medium valve with commissural alignment, maybe under RV patient at low rate, 110 beats per minute for stable position. And in case we need a future TAVI with SAPIEN 3, we can use it with, I think, very good results. Thank you for the attendance.
Thank you, Nectaria. So let's dim the lights down, if it's possible, and let's play the video to see what we did. Let's also try to shorten the video. So we only spent 10 minutes to see the procedure, so we have a 30-minute delay. So this is the beginning. We use, as always, a combination of ultrasound-guided and angiography-guided puncture, the combination of the two. And then we use two proglides, and then you see here an ECIF, 14 friends, so you can guess what valve we used. So we used the SAPIEN valve 23, and you see the hemodynamics on the left upper corner, and then we use a pacemaker, electrode temporary from the leg, and here we're crossing the valve, something that was easy, and we check the hemodynamics, so you see the gradient, the invasive gradient that is usually 20 to 30 millimeters below of mercury below the echo gradient, and then We go with a pigtail here, and then our standard wire we use is a Safari extra small or small, depending on the size of the ventricle. And then you're going to see valvuloplasty with a 20-millimeter balloon here with simultaneous autography. This is something we use almost always to check the sizing and also the movement of the leaflets in relation to the annulus. So you see a 20-millimeter balloon was relatively small and very mobile. But of course, the valve we're going to use is 23, based on the perimeter of the, based on the area of the annulus. Here, if you remember, the perimeter was 72, which will be something borderline for evolute between the 26 size and the 29 size. But for the balloon expandable, the size choice is very clear. And now you're going to see a 23-millimeter valve, and I'm sure we used some extra volume in this case because we had this space. And here is the alignment, so we pull back the balloon so the valve sits in the middle of the balloon. And then we go around the arts, and by using the flex of the delivery catheter and pulling back the wire, we managed to be away from the wall of the aortic arch, as you can see. So we don't touch the aorta, and this is possible with the flex of this system. And then we're crossing, and we check one more time the positioning in relation to the calcium and the pigtail. And remember, as we discussed in other cases, that the force shortening of this valve happens from below, from the inflow. So what you see now down, it will move up, but the top of the valve remains always at the same place. And we usually want to have like 90% of this valve above the annulus and 10% or 20% of this valve below the annulus. The higher we go with this valve, the lower also the pacemaker rate, which is anyway low for the balloon expandable valve. And you notice the force shortening from the inflow, from below to up. And then we remove the system, and we check the hemodynamics, and we do aortography and echocardiogram. So it's a triple check of our result. And you can see there is 0 PVL with a 23-millimeter valve plus 2 ml volume. And you see that we're about 20%, 80% to the annulus. We're clear of the corneostomy because this patient is relatively young and has some moderate coronary artery disease, so he may need in the future some coronary intervention. And also with this valve, it will be very easy when he comes back with this valve degenerated to do a TAVI in TAVI. And I think we should stop here and just a final discussion. So we didn't follow your advice, Nectaria. We didn't go for accurate neo. That would be size 25, I guess. Yeah. All right. The problem with the accurate neo is that it has the highest leaflets, highest of tallest than every other valve. So it will go up 32 millimeters and certainly go above the STJ. And as Danny told us earlier, explained to us earlier, when you go for a TAVI in TAVI, then you will create a cage that will be above the STJ, and leaflet modification will be much more likely to be required with the accurate valve. But I agree, coronary access will be easier because there is no stent behind the leaflets like Evolut or Navitor.
Actually, we're just at the border. If you see the measurements of the accurate neo, if you implant at the right level, should be 5 millimeters below the annulus. So the height will be 22 millimeters minus 5, should just below the coronary if you put another valve another valve in. So it will be just below the coronary aorta if you do TAVI next, if needed.
That's better. Okay. So I would have the same strategy than you. So so the problem with Accurat Neo, in my opinion, is later treatment with the second valve, even with the SAPIEN, is not this easy. It's visible, but where to place the valve? When you place it in the height of the annulus, you will have leaflet overhang. So what happens with the Accurat, the leaflets become, when you implant the SAPIEN, tapered, so it's pulled to the inside, it is pulled away from the coronaries. But leaflets are very high, and you have this overhang of the leaflets, what I don't, when I'm honest, I don't like. And the other thing is also coronary access is only easy when it's commissurally aligned. When it is not aligned, it can become very difficult with Accurat. So it is feasible to align it, but you have to align it. So for me, it's not a valve for younger patients who need a second valve, when I'm honest.
Okay, if there are any comments from the floor, and then we have to move on because we are already 30 minutes late. Okay, and we call the next panel, please. Thank you.
Is Professor Toutzouzas with us? Professor Toutzouzas? So, as we are very late, half an hour, Dr. Messas will speak about the future of heart valve disease treatment beyond the implantable devices. Please,
okay.
Dr. Messas.
Yeah, you hear me? Hello? Sorry? You hear me?
Yes.
Okay. So thank you for this invitation. I really appreciate. I am not an interventional cardiologist. I am an echocardiographer. And we try to develop a new technology based on non-invasive ultrasound to try to improve the aortic valve opening. It's not beyond implantable device, but to be fast and to help and to be complementary to implantable device. So this is what I will present now. This is my conflict of interest. And as you know, there is an important yearly incidence of aortic stenosis, an increased number of TAVR candidates we have seen in your beautiful congress, and still 60% of a severe symptomatic aortic stenosis patient have declined for invasive valve replacement. And above this, we know that the stroke risk remains high after TAVR, and we find in last publication that 74% identified by post-procedural MRI are associated with increased prevalence of cognitive dysfunction or asymptomatic CVA. So we think there is a room for a non-invasive option which will be complementary to TAVR and to be proposed to this population of aortic.
Dr. Messas, can you hear me? You should share your screen because we cannot see your slides.
Sorry.
Thank you very much. Thank you very much.
Sorry. Oops. You see it or not? Wait.
If you could share the screen so you can open the presentation.
It's okay, you see?
Yes, just open it in the full screen mode.
Okay, you have it?
Full screen. Okay, now we are okay, thank you.
Okay, so the idea was to say that we have a complementary non-invasive ultrasound therapy that we want to be complementary to TAVR. So we, as you know, that in the whole population of aortic stenosis, in 5 million patients in the developing world, in US and Europe, only 550,000 get valve replacement. 3 million patients are moderate, and still they don't have TAVI. We know that there is some study in process, and 1,500,000, even though they are severe stenosis, they didn't get valve replacement. So we think in terms of medical needs, there is an immense medical need in terms of reaching out this 1 million patient or these 3 million patients. So we developed a new device called ValvoSoft with the CardioWave startup company. That is a completely new device that has the goal to repair the valve. We have a stiff cusp. We want to make them less stiff and make them better open to improve the aortic valve opening. It's completely non-invasive, can be done ambulatory, no need for cath lab, easy to use, fast learning curves. And you see here the bubble of the cavitation into the aortic valve. And we have now a big plan echocardiography that we can see the short axis and the long axis in real time during the therapy. So principle is like here. We use focus, very high frequency and short ultrasound pulses that create microscopic cavitation bubble into the embedded calcification. When cavitation bubble bursts, they produce shock waves. And this shock wave has a goal to do micro cracks in the valve calcification without tissue damage. Again, we don't want to decalcify the valve. We want to make this cusp less stiff, smooth, and make the valve and the cusp better, an increase of the motion of the cusp, and the valve can better open. So we use what we call this non-invasive ultrasound therapy. It's completely different of high-intensity focus ultrasound that use the heat, and even completely different to the lithotripsy used for kidney calcification. So this is what we see in echo. It is in vitro. You see, we can even target which cup we want to target, and you see the bubble. This bubble is a bubble of cavitation. We don't inject bubble. It's only by the cavitation effect made by this very focused, very important ultrasound with high pressure and high intensity, and we can target the curves that we want. So we did a few years ago in vitro and in vivo evaluation of this new therapy in hemodynamic bound, and we're using bioprosthetic calcified valve, and also in vivo. And you know, there is no in vivo animal model of aortic valve stenosis, so we use bioprosthetic calcified valve that we explant from humans that got cardiac surgery, and we do the therapy, and we evaluate this before and after by echo and by Miller catheter. We published this in JACC, Basic Translational Science in 2017, showing that we were able to improve the mean gradient and increase the aortic valve area. And we correlate this using shear wave imaging to the stiffness of the valve that was decreased by the therapy. So thanks to that, we did also more than 50 POC to show that we were able to do this transthoracically on a normal valve. We were able to demonstrate there is no necrosis, no skin burn, no peripheral damage around the aortic valve, and still we get some arrhythmia, extrasystolic arrhythmia, never life-threatening arrhythmia, and we never get block aortic valve, atrioventricular block, and no need for pacemaker. Thanks to this study, preclinical study, we get the authorization in 2019 to do the first in-human studies on very sick patient that was severe symptomatic calcified aortic stenosis patient not eligible to TAVI or to surgery. And the primary safety endpoint was procedure-related mortality at 1 month, and the primary performance endpoint was the ability to modify the structure of the calcified valve leaflet to improve their mobility immediately post-procedure compared to baseline. So we did this first in 10 patients, 5 in Pompidou, European Georges Pompidou Hospital in Paris, and 5 in Amphia Hospital in Netherlands. And after we get the authorization for 40 patients, we just finished, with now some patients already to 12-month follow-up. And this was 19 patients in Amphia, Netherlands, 11 patients in Paris, and 10 patients in Serbia. And in Serbia, the regulatory asked us to do systematic brain MRI before and after to look for even asymptomatic CVA. So we published the first 10 patients with the 1 month follow-up in circulation in 2021, and we are able to show in some patients, responder patients, a decrease of the significant decrease of the mean gradient and increase of the AVA, about 23%. We came from very severe aortic stenosis patient. It was about 0.5, 0.6 centimeters square. And we're quite happy to have some improvement and even some improvement in NYHA and KCCQ. This is the baseline characteristic of the 40 patients that we are just now submitting to publication. They are quite old, 83 years old. 10 patients are above 90 years old patients. The mean AVA was 0.57, so very severe patient. The mean gradient was only 40 because 57% of these patients have a low flow, low gradient aortic stenosis, and about 80% of the patients are class 3 or class 4 anyway. What we find out on these 40 patients, no death per procedure, and a discharge at 1 month, no life-threatening event, no stroke, we're afraid to the stroke, but no stroke, no myocardial infarction at 1 month follow-up, no major adverse event for the patients that already reached the 12-month follow-up, MMSC stable, we never use embolic protection, and in the Serbian studies that just accepted in European Heart Journal Cardiovascular Imaging, the brain MRI systematically done before and after didn't find any new CVA. In terms of efficacy, I show you only the 3 months because the 6 months are under publication. We get an AVA improvement that was statistically low improvement at 3 months, about 19%. It was about the same at 6 months. We have a stabilization or improvement of NYHA in 92% of the patient and a significant improvement of the KCCQ, the questionnaire at 3 months. We now start, thanks to this first in-human study, a CE marking pivotal study. We start this in March 2023. The inclusion criteria is about the same. It's severe symptomatic calcific aortic valve stenosis, but we include patients that are not recommended by the local heart team for immediate TAVR or SAVR. That means a patient that have intercurrent infection or he has to have extracardiac surgery can be involved. And in Germany and in Netherlands, we can even involve patients that refuse TAVR and SAVR. And we know that it's about 10 to 15% of the patients that refuse TAVR and SAVR. In France, we cannot include such a patient. And exclusion criteria is low EF, very severe aortic valve stenosis. And if you have an acute MI stroke in the month before the inclusion criteria, the inclusion time, the primary endpoint is the rate of MACE at 30 days post-procedure. Performance, it's clinical. And secondary endpoint, it's the hemodynamic parameters, safety, and the clinical also performance. The international PI is Christian Spalding, and the national French PI is Hélène Enstelinov, and we have Alain Cribier in our scientific committee. Here, an example of the therapy. It's an 82 years old female, 0.6 centimeters square, mean gradient 43, Vmax 4.3, LVF at 40%, Frailty score 5, was not recommended for TAVR because of vascular fragility. And you see the machine here. We are in ambulatory operating room. You see here the device on the thoracic of the patient. She is only very lightly sedated. You see the anesthesiologist speaking to the patient during the therapy. And you see here the bubble of cavitation in long axis and short axis view. So what is the potential future of this new technology? First, we would like to have this CE marking for this patient that is already treated. That means the ones that are contraindicated to TAVR and SAVR, that is not recommended for TAVR, and the one that is refusing the TAVR or SAVR. Future potential indication, and many key opinion leaders tell us about moderate aortic stenosis patient to delay the natural history come to moderate to severe patient. Perhaps young patient with severe symptomatic aortic stenosis to delay the first TAVI. Some also tell us about to prepare the valve for TAVI, and also for a bioprosthetic degenerative valve to delay again the TAVI into valve. We are not the only ones that are thinking about moderate aortic stenosis patient. As you know, obviously there is many study ongoing for testing a TAVI on moderate aortic stenosis, and also, as you know, Novartis developing a new drug targeting the lipoprotein A, the pelacarsen, and my hospital is part of this study, to also targeting moderate aortic stenosis to slow down the progression from moderate to severe aortic stenosis. So it's completely new non-invasive ultrasound therapy. We have done so far more than 70 patients, France, Netherlands, and Serbia. We demonstrate, at least with what we have done, that it was feasible, safe, in very frail patients. On these 70, more than 15 patients and above 90 years old, with severe comorbidities and severe symptomatic calcified aortic stenosis, not eligible for valve replacement. We find out some improvement of functional and echocardiography. We are now submitting the 6-month follow-up, and we are collecting the data for the 12-month follow-up. We didn't have any major device-related major adverse events because of this therapy. And our thinking is this new technology can be complementary to TAVR. We need to work on the strategy, how many times we can do. Some patients we did already 2 times, 3 times, and it went very well. And we have to optimize the treatment probably on less severe patients. We need to see longer follow-up and to exactly determine which population will benefit from this. Thank you.
Thank you. So we move from the knife to the wires and towards to the non-touch techniques. I was sitting at 10 years ago. I was sitting here at the same congress, supporting as a surgeon, supporting TAVI, and now 10 years after, TAVI is a very, very strong treatment. And hopefully, after 10 years, the non-touch technique will be the first treatment, the treatment of choice. Professor Toutzouzas, can you present the next speaker? And any questions?
Before that, I would like to congratulate Dr. Mesas, and I would like to make a question. It's a very interesting approach, the ultrasound. A month ago, we published in JACC Basic and Research an article in which it is the first article now, another also is upcoming, regarding the mechanisms that we propose related to progression of aortic valve disease, especially calcification. And we point out some key, at least according to the underlying literature, some key points regarding the spongiosa and the ventricular side of the calcified leaflets. Do you have any data in this very intriguing technology that you alter in a protein synthesis or in a pathway of pathophysiology in these layers? Do you have any data? Because this would be really helpful.
Yeah, so I am one of my fellow, because I was fellow in Mass General. He is now in the fellow in Mass General Hospital right now. And he is working, because we have difficulty to understand the mechanism of this therapy, working in vitro cells of valvular intracellular, VIC and VEC. The valvular intracellular calcification of the valve and the valvular extracellular calcification. And we are now sending this ultrasound and to see if we improve the phenotype. That means we try to see that if the process of calcification is slowed down by this ultrasound therapy. So it's in process. We try many experimentation to try to understand this, but it's very difficult because you cannot compare before and after, by definition, because you have to send the ultrasound and after to analyze the tissue, and you don't have the tissue before. What we find out that we from big block of calcium, of calcification, we go to multiple block, and we have a technology called shear wave imaging technology that is able to give you the stiffness of this tissue, and we did this echo before and after, and we really think that the stiffness decreased. So our idea is that the stiffness decrease because you make from one big block multiple small block. And we are quite happy that the ventricularis and the endothelium was not completely destroyed by this therapy. Sometimes we get some thrombosis, a little bit. So we did, I didn't say that, we did two groups of pork, one with aspirin and clopidogrel versus nothing, do the therapy. We did the outcome 1 month after and we analyzed everything, we published this. It was not necessary to put aspirin and clopidogrel. So up to now, all these patients, we keep what they have. And to be honest, most of the time they have aspirin at this age, with all these comorbidities, they have aspirin in their treatment.
Okay, this is very interesting. I would like also to see some experimental data in vivo regarding the break of the large calcification. This would be really helpful and nice.
We'll try.
Thank you very much.
Thank you so much. Thank you.
Dr. Kotoulas, you continue. Yes.
Thank you. Next speaker is Dr. Olympios. Dr. Olympios was the president of the Greek committee of TAVI and structural valves treatment in Greece. And he will speak about TAVI and M-tier outcomes in Greece.
Thank you very much, Mr. Chairman. Mr. Chairman, dear colleagues, it's a pleasure and privilege to participate in this year's conference, and I would like to thank the organizing committee for the honorary invitation. This year marks 16 years, 2007, from the first TAVI implantation in Greece by Kostas Parias and colleagues at Onassis Cardiac Surgery Center, and almost more than a decade that the first mitral valve repair, again by Kostas Parias and colleague, this time at Aegeas Hospital, who is organizing this excellent conference. Since that time, the implantation, the transcatheter intervention for structural heart disease has been on the rise, especially for TAVI, and less often for mitral insufficiency. Concurrently with the introduction of the method in our country, given its innovative form and cost, of course, the Ministry Regularity Authorities published terms and conditions for carrying out this intervention through a committee assigned with examining and controlling their consistent implementation. This committee, under its current composition, based also on work and contribution of colleagues who have been its previous member, throughout this period till the present time, has collected and analyzed implantation, morbidity, and mortality data, published them, and is able tonight to this session to present them. As far as for TAVI, a total of 4,606 patients have undergone TAVI by the third semester of 2012. This is the very recent slide. It's just yesterday that the statistical office of our committee gave me this information. The rate of implantation, except during the pandemic era, has been remarkably, steadily and remarkably increasing. As you can see, someone could predict that this rate is about 25 to 30% every year. The rate of implantation, the need for implantation of pacemaker, coexistent with coronary artery disease and its treatment, is also reported in percentages
corresponding to the international literature. And as you can see, for example, we started, as for pacemaker implantation, with some devices as Lotus and Portico with important rates of need for implantation. And actually, with newer devices, as Accurate Neo or Evolut Pro, this number is very, very low. For example, and also to see for coronary artery disease, approximately 50% of this patient has also coronary artery disease, and in 90% per case of patients, this coronary artery disease is treated before TAVI and 10% approximately simultaneously with TAVI. Mortality was measured during in-hospital, first month, 6 months, and 1 year, and is reported in percentages corresponding as in the international literature. And in the next slide, we'll present each evolution depending on the year of the application of the method. And you can see that 10 years ago, we started from something just around 7%, and actually, for in-hospital mortality, we are below 2%, and for 1 month mortality, just a little more. And in the same scenario, the 6-month mortality is started from something around 30%, and actually is less than 4%. It is obvious that with the acquisition of the required experience, these percentages steadily decrease for each assisted period. Examining data centers, we observed that the volume per cases per hospital is inversely proportional to the observed mortality. As you can see in this slide, centers with less than 20 cases per year show higher mortality than those with more than 20 cases per year, and this during all stages of the follow-up. And we were therefore forced to discontinue the TAVI program in these centers. Actually, there are 22 TAVI centers in Greece with excellent results, and the number of treated patients, it's now the average of high-income European countries. It's just like about 1,000 per million patients, even more, 1,200. And I must note that this number is the lower limit of current indication for TAVI, and this number could rise up to 4,000 patients per year if the TAVI indications are extended to low-risk patients. So to conclude, as for TAVI, I would say that the course of TAVI intervention in Greece follows a satisfactory growth rate and has reached the European average. Centers with a high annual number of operations outperform survival rates compared to centers with a low annual number of operations. This confirms the expert opinion, the setting of a minimum number of TAVI implants per center, which imposes the suspension of TAVI in centers that do not maintain the minimum required limit of a certain annual TAVI number. As for MT concerned, this is the same scenario. Again, Kostas Parias and colleagues performed the first mitral repair, this time at Ygea Hospital, which organizes since more than 10 years, I think, 10, 11, this 11 years, this excellent congress. Here, as you can see, the course of implantation fluctuates more sharply, since you can see that we have more fluctuation. Even in the last 2 years, there seems to be a steady upward trend of, again, as for TAVI, about 25–30%. Mortality, again measured in hospital, 1 month, 6 months, 1 year, 12 and 2 years, is also equivalent to the data of international literature. As such, you can see it's exactly the same pattern. Here we start for in-hospital mortality of around 5%, and actually we are just a little more than 2.50. For the 30 days mortality, of course, we speak about patients that are very, very sick, okay, that's well known. We started from 12%, actually we are at 4%, 25% at 6 months, and actually 8%, exactly the same scenario, even for 2 years, starting for almost something like 40%, and actually we are below 10%. Until 2021, the number of MTR implantation was relatively low, even if a lot of patients, mainly who were treated mainly by Costas Pavlias and Vlasis Pagnos from in the registries of Reshape, CLASP, PAFI, IREM, and Carry-On are not included in our analysis. But anyway, this number is relatively low until 2021 and corresponding to about 40 interventions per year and 5 to 4 interventions per year and per center. Happily, since 2022, I think that there is a strong upward trend begins to appear. And as for TAVI, proportionally to TAVI, you can see that actually the number we perform in Greece is again the average of high-income European countries, about 10 patients per 1 million of patients. One good question is, what is the number we need what's the number that patients need MTF in Greece? For example, the United Kingdom, who is 6-fold above the Greek population, we calculate that we need about to perform 400 patients per year. Poland, with 22 million, so the double of our country, it's about 186 patients. So transferring this data to our country, about 100 patients per year can be candidates for the method. In order to maintain the experience of the center, it seems also that 10 to 15 implantations per year are required. Regarding transcatheter interventions for structural heart disease, valid data and information show that although the request for TAVI and MTF is equally distributed between the public and the private sector, in practice, long TAVI delays in the public force some patients towards to the latter, to the private sector, probably also because the one condition, aortic stenosis, is considered more urgent than the other one, mitral insufficiency, while the absence of a dedicated DRG for MTF is also a factor who favors the private sector. It's therefore not surprising that only 28 for TAVI and 36 of MTF are carried out in public hospitals. So to conclude, this is my 2 last slides. To conclude with, as concerned for MTF, the clinical interpretation in our country follows a steady upward slow course. The introduction of a dedicated DRG is likely to trigger a clear upward trend. Just to say that our committee intends to move in a balanced step between the early approval of new transcatheter procedures, but in a selective environment, quantitative and qualitative selection of centers in order to maximize the benefit for patients. And as already mentioned, only 36 of TAVIs and 28 of TIVs are performed in public hospital, although requests are 50-50. And this is my final slide, my final conclusions. It's obvious that there is a discouragement of TAVI and TIV in the public hospital, the lack of DRGs for mitral repair, the delay, of course, is very important in conducting a central tender for the national-wide supply at lower prices of these devices, of these materials. And I think that the above statements are the most important of them, and the ministry should resolve them as soon as possible so that a greater number of heart patients can benefit from the favorable results of their implementation. Thank you very much for your attention.
Thank you, Dr. Olympios. Actually, My last action as the president of Cardiothoracic Society, Greek Cardiothoracic Society, was to apply in the Ministry of Health about the DRG of mitral clip. And I don't know, it happened in 2020, 3 years ago, and I don't know why there is no in 2023 a DRG for...
Probably it's your last, as you say, action as the president of your society, but I must add that not even my commission, but also the commission before me, I mean, Dr. Sionis, when he was the president of our commission, I think there are 3 requests for the central, for the minister, and of both governments, before and now, to create DRGs for mitral repair. This request is still without any response.
And I think that the DRG, the cost of the DRG was about something less than 30,000.
No, it's actually we have...
I remember something like this.
We have also, because we have done a study before, give our propositions, we proposed, I think, DRGs for mitral repair. It's not our work. It's a work of another commission, and you know, when there are a lot of commissions, there's no result. But anyway, I think that our proposal was 22,000 euro as DRG for MT, considering economics of our country, regarding other countries as France, as Switzerland. But I repeat, after 5 or 4 years that we are demanding these new DRGs, there is no response.
Okay. Any question from the audience, please? Okay, we can move on because we're very late, about 35 minutes. Thank you very much.
Go back in business in the last session of the day, which I think is the most interesting because it has case presentations one after the other. We have the panelists join us up here, Dr. Giakas, Danias, Konstantinidis, Zagre, and Dr. Davlouros via video connection. Do we have that? You can go ahead. Καλησπέρα, Περικλή, αν μας ακούς. We're going to start with the first presentation. It's going to be on Ό,τι θέλεις. Ό,τι θέλεις. Να και ο Περικλής εδώ πέρα. Καλησπέρα. Τώρα σε βλέπουμε.
Καλησπέρα.
Τώρα σε βλέπουμε. Dr. Samargandi, is she ready? Oh, yes, here you are. Great. Interesting Navitor TAVI with left main stenting. And Dr. Gifa and Dr. Giakas to get ready, please. Everyone has to get a quick turnaround and a very pointed presentations here. Go ahead, Dr. Samargandi. Thank you for joining us.
Thank you. Good evening, everyone. Thank you for having me. Could you put up all the slides? Okay, so without any further ado, we'll go just through introduction. So all the morning or in the afternoon, we've been going through TAVR lifelong management, and the main concern in the last at least 2 sessions was coronary accessibility. We talked about Evolute self-expandable valves. We talked about Sapien and also Accurate, but no much talk about Navitor or Flix from Abbott. So let's have a quick touch on it. So as we know, in addition to the planning of the first aortic valve intervention according to the guideline recommendation and anatomical and technical consideration, the ability to evaluate the feasibility of future valve intervention should become and became more increasingly important. So I'm going to fixate on more coronary reaccessibility. We have multiple things which has been discussed this morning. And just to keep in touch with the data from the cohort studies that we have, that accessibility after TAVR has been an issue. And commissural alignment is very important to have a favorable alignment in order for you to get an access to the coronary. Suboptimal alignment has been seen with the blue and optimal alignment in the green. And also we have been discussing this since morning. And why is it important? Because we are talking about coronary accessibility and long-term impact of durability is still unknown, and increasing the halt or the gradient with misalignment still unknown there. And leaflet modification strategy, which is basilica or shortcut, not feasible if commissural post faces the coronaries. So this is the patient of a 75-year-old man with multiple comorbids, old CVA, who presented with severe symptomatic AS. It was discussed in the combined meeting, and decision was to go for a PCI for a subtotal occluded LAD and go with a porticus at that time in 2018, size 27. And as you can see, it has a large open cells, minimizing the obstruction for the coronary. It's a nitinol self-expanding stent and recapturable, repositionable, and retrievable. And early valve functionality for hemodynamic stability throughout the deployment is giving a plus over Navitor's. A quick comparison in terms of the cells and the cylindrical valve, you can see it in the portico, how is it big, and even it can fit up to 20.8 French. So they tried to go for the subtotal PCI, and just for the sake of time, I'm going to cross it. And they were trying to deploy the valve under 120, 140 pacing, and they had a bit of lower implantation, and as you can see, a constriction in the middle, so they did the post-dilatation. This is the final images after the implantation, and it was successful. We brought the patient 1 month after that, and they did the stenting to the proximal LAD. This tells you how assured of the operator that of the coronary accessibility. Then the patient presented 3 years later. This is like after starting the things to open up after the COVID pandemic. And we can see significant progression of the left main disease and end-stage restenosis in the mid-LAD. Out of the back, you can see significant easy accessibility to the coronary. And due to the age and the comorbid, the decision was to intervene with this left main. So they put 2 wires in the circ and the LAD, and they went with the provisional stenting to the left main, and that did not hinder them from going and protruding in the main stent frame, going for the pot technique, and even introducing of an IVUS catheter to see optimization of their stenting. So they have a successful intervention, successful good imaging with IVUS, and even they ballooned the diagonal, but I didn't, for the sake of time, didn't show it. 1 year later, in December 22, again he presented with symptom of shortness of breath and chest pain, and he went into elective angiogram. His ECG is still left bundle branch block since he's been did the procedure 5 years ago. He has a good ejection fraction with mild regionality in the LAD area, but the valve was doing great over the course of 5 years with a mean gradient of, or peak gradient of 5. So you can see how easy we can access the cell for the right and the left. The new thing is happening now. Again, there is restenosis in the LAD, and now the involvement of the ostial circ. So at this stage now, the patient is 80 years old. So we elected to go for intervention with drug-eluting balloons in the ISR segment of the LAD. And we went with the reverse tap 2 stent strategy now, stepwise, let's say it, in the circ and the left main. So a wire was crossed in the circ and ballooning of the struts. And we implanted, can we play them? Sorry. Can we go backward, please? Can we play the last videos? Go back, back. Oh, play this video, yes. Play them, please, from your side. I cannot. Just play them. Play the video from your side. Yes, click it. So we're doing optimization of the left main now, and we did the final kissing between the LAD and the circ. Next, please. And it was successful. So as you can see, in the course of 5 years, the patient has presented with intervention at least in 3 different occasions with no issue with accessibility and good functional valve after 5 years. So aortic stenosis treatment should be approached as a lifetime management strategy, considering all aspects, ranging from the patient's anatomy, device characteristic, to the patient's preference. Currently, despite most of the patients prefer, of course, less invasive approach, there are several factors should be considered, and sometimes they might be difficult to predict, because who will predict that the patient will need at least 3 interventions afterward in an 80-year-old gentleman? The choice in the best approach and the prosthesis remain particularly difficult, not only because it requires comprehensive evaluation of the patient, but also it requires a projection into the future. And by that, I thank everyone.
Yeah, this was great. Thank you so much for joining. Dr. Zifa should getting ready with a presentation. Dr. Dagre, what's your preference? Fix the coronary work before or after? Given there's always ways to fix it after, but is there a choice? Is there a preference? Maybe you and Dr. Davlouros is going to give a comment about this.
Okay, personally, I think I prefer to fix the coronaries before the TAVI, because, as a matter of fact, I don't feel very comfortable to try to reach the lesions through the cells of the valve and all these things. I certainly prefer before.
Dr. Davlouros?
Yes, I totally agree with Dr. Dagre. It is more convenient for the interventional cardiologist to finish with the coronaries before the implantation of the valve.
Yeah, very well, very well. Well, that makes 3 of us. Professor Avouranakis joined us in the panel. Professor Alexopoulos, do you mind joining us as well? We would like to have a greater panel for these discussions. Costa, push the button.
George, I think it's important which type of the valve also you're using. If you're using a balloon expandable, probably it doesn't make a lot of difference. But if you use a Medtronic valve or a self-expandable valve, you might run into troubles when you try to do ostial, or right coronary artery with acute takeoff. So you have to consider that too.
Very well. Let's go ahead to a totally different subject. Hybrid implantation of tricuspid valve in a pediatric patient with complex congenital heart disease. No wonder I asked 2 professors to join on the panel here for comments. Complex. Thank you. Dr. Zifa.
Thank you. Well, thank you, Dr. Sparias, for the invitation. Well done, HiGEA team, for this wonderful conference. And I apologize for the change of the valve. I'm not going to talk about the tricuspid valve. I cannot show this case. I've been asked not to because it's going to be submitted for a publication. Let's go on to another fascinating case. We're going to go to the pulmonary valve. It's a 44-year-old patient that Professor Davlouros was involved and is involved. Tetralogy of Fallot with pulmonary atresia, VSD, interrupted inferior vena cava, hemiazygous continuation to the left SVC, left upper pulmonary veins to the left SVC, a whole lot of stuff. Initially, he was operated in the US. You see here that there is azygous continuation, so one cannot approach his right heart from the femoral vein. He had unroofed coronary sinus and was very desaturated because of that. He went back to the Harley Street Clinic when he was 17 years old, and he had redirection of the left SVC venous blood to the right atrium, and he stopped being desaturated. He then had arrhythmias, and in 2011, he went to the Onassis, where they found that the left SVC was obstructed at the superior end. The problem started when he had significant atrial flutter fibrillation, and he had an MRI by Dr. Danyas that showed an ejection fraction of the left ventricle of only 38%. He's a fallow patient, so now I started talking about the left ventricle. His right ventricle was dilated at 109 mL per meter square, also hypocontractile. His New York Heart Association 2 to 3. He was also under alcohol consumption, and then his left ventricle started dropping further with ejection fraction of 33%, and suddenly he was found to have endocarditis, no surprise, and so he had a pulmonary homographed vegetation. This is his transesophageal echocardiogram, where you can clearly see that he has biventricular failure. On CT performed at our center, we've seen that there is a vegetation in the pulmonary homograph, and and also stenosis, so we started talking about what's best for this patient. He was referred to us after having been to a tertiary center where they were considering him for heart transplantation because of his biventricular failure. The CT showed calcification, as you see, of the pulmonary homograph. His MVO2 was low at 20 mL per kilo per minute, and liver elastography showed that he had hepatic stiffness, 9 kilopascal, no surprise. His right heart catheterization was reasonable. And these are the injections from the left subclavian vein, and this is the azygos with continuation to the coronary sinus. This is left ventricular angiogram, where you can see the dilated ascending aorta, which is usually the case in fallow patients, and his coronary arteries. Why we check in the coronary arteries? Because we don't want to compress them when we put an RVOT stent. So we first do balloon interrogation, as you see on the right low panel, and the coronaries were far from the site of implantation. We optimize the patient because of the biventricular failure with the therapy. We obviously ask him to stop drinking, stop smoking, and we plan to do a pulmonary valve implantation. Now, I told you earlier that he had SBE on the pulmonary homograph. SBE, chronic SBE in the non-acute phase is actually not a contraindication for pulmonary valve implantation. So you see here, in order to do that, we first implant a covered stent because we don't want the calcium to give, and we don't want RVOT rupture. And then within that new covered stent, we implanted an Edwards size 20 because he had a smallest pulmonary homograph. That went really well. This is his final injection. The patient had significant improvement. The medication decreased. He has good valve function 2 years later, and his left ventricular ejection fraction has improved to 46%, with the right ventricle end-diastolic diameter of 28 millimeters, having been 36 millimeters before the implantation. So when we have fallow patients, we usually think of the right ventricle, but the left ventricle, through ventricular-ventricular interactions, can also go down. Other factors like male gender, duration of shunt before repair, history of arrhythmia, QRS duration, and others can actually bring these patients to biventricular heart failure. And so when we see them, we need to fix whatever anatomic lesion can be fixed. So tetralogy of Fallot can be a very complex entity. The aging patients have coexisting congenital heart disease variants like him. He didn't have just the Fallot problem. And although RV failure is the primary problem, this patient LV requires also equal attention. So we have to optimize RA, RV, and pulmonary valve physiology for these patients. Thank you very much.
Well, this is an incredible case. Let's have Dr. Danias, who is an expert in cardiac MRI and actually participated in this case, give us a few comments about this. And, you know, Dr. Davlouros was, again, you said, involved. So he'll give us comments right after.
I think this case really demonstrates how complex anatomy can be. And you certainly deserve kudos for treating this patient using all the medical information, the imaging data to optimize the medical therapy, but also the interventional approach. I'm going to pass on the discussion to a more specialized person than me. Periklis, you go ahead and make your comments, please.
Thank you, Peter. The only thing I can assure you about this patient is that he did not quit alcohol. In any case, this was a fascinating case, and I'm very happy that we have physicians like Dr. Zifa and her colleagues to give solutions to these patients. It was a surprise for us when we discovered that there was infective endocarditis, and we were very, very concerned about the way of approaching such a patient. But then as Dr. Jifa mentioned during her presentation, chronic infective endocarditis is not a contraindication for implantation of a biologic valve. So that was done, and as you saw, the patient at the moment is very stable, and he's having a regular exercise, and he's enjoying life. Thank you, Dr. Jifa.
Well, thank you very much.
Great. Thank you very much. This was a tremendous case and great comments. Dr. Giaccas will be next to TAVI embolization into the aorta. We're going for another interesting situation.
Yes, καλησπέρα.
From Democrition Hospital, and a colleague of my...
Thank you, Dr. Spargas, for the kind invitation. Well, this is... okay, let's start. This is valve number 23 in our center 1 year ago. It was a case of male, 83 years old, with a severe stenotic aortic and some mild reduced ejection fraction with 50%. Their functional status was NA3 and 2 syncope episodes, and that's all. It's the mild reduced renal function, G2A1. That means, according to the British Renal Society, that has a GFR between 60 and 90, and no albuminuria. Peripheral arteriopathy, hyperplasia of prostate, and hypertension. Euroscore 6.32 and STS score 1.27. Normal weight, and nothing to notice about his exams. This is the echo summary. The echo summary was a VP of 4.3 and a mean pressure 42 and max 73, AVA 0.9 and AVA index 0.4 and DVI 0.21. There is no video over here, so let's go to the CT. This is the CT angiography, STJ, and this is the measurements according to the CT. We're in a dilemma to choose a 29 or 26 plus valve, Sapient, Edward Sapient 3, and finally we choose this 29. Well, this is the first orthography, and take a look at the pacemaker. After that, after the first valvuloplasty, that you have noticed that we have a loss of capture and some ups and downs of the balloon into the ascending aorta. When we try to inflate the valve, as you can see downstairs, there's a loss of capture one more time, and the valve moves up. After that, we are trying to get another valve into the first valve, because the patient has a quite severe aortic insufficiency. The pressure was not quite well, so we tried to move into the first valve, another valve, and to implant it. And after that, we'll see what we can do with the first valve. We tried to get another valve in the annulus, and 29 valve, and after that, some efforts. And when the first valve stuck out the ascending aorta, we tried and we released the second valve. With the help with a pigtail, I tried to move backwards the first valve, and when we realized we are in the level of the large vessels of the arch, and especially after this left subclavian, we try to inflate this and to make an ectopic valve over there. And this is the final result. Well, and this is the CT 1 day after that, and the other CT is here 6 months after the implantation. Well, some definitions now when we talk about valve malpositioning and valve migration. Well, valve migration is when, after initial correct positioning, the valve prosthesis moves upwards and downwards within the aortic annulus from its initial position, with or without, usually with consequences, of course. Valve embolization, in our case, moves during or after deployment such that it loses contact with the aortic annulus. And ectopic valve deployment means that the permanent deployment of the valve prosthesis in a location other than the aortic root. And TAVI is TAVI. Well, we have a case of valve embolization, and we treat it with ectopic valve deployment. Well, in the current literature, and the Edward Sapiens has the less cases of the embolization and migration. In this series, in 1,500 patients, only 2 had this valve embolization and migration, according to the others. The main mechanisms for this is the spontaneous embolization, the migration, the incomplete release from the delivery catheter, the embolization during post-dilatation, and the loss of capsule. And where these valves go usually, the 80% of them go to the ascending aorta, and only 7% to the aortic arch. That's in our case. This some regression analysis on some risk factors who are responsible for this migration and embolization. This is the left ventricle, the ejection fraction, the low ejection fraction, the use of cell-expanding valves, and the horizontal aorta. We had known ejection fraction, low ejection fraction. We use the balloon expandable valve, and the aorta was not horizontal in our case. And another series cases, approximately 30,000 cases, the rate in the 30,000 cases, the rate of migration and embolization was approximately 1%. And the use of self-expanding or first-generation prosthesis, and of course the presence of the bicuspid aortic valve, were independent predictors for the onset of embolization and migration. And many of these cases may have been preventable. In case that the valve goes to the aortic arc or ascending aorta, etc., the main causes are the malpositioning, the manipulation, the post-dilatation, the pacing failure, just in our case, the sizing error, and other unknown factors. And the bailout procedure is repositioning in approximately half of these cases, the valve, 89% of these cases, and the surgery, 30%. In cases that the valve goes to the left ventricle, that the repositioning is much less, it's 20%, and the surgery is 40%. And the other frame is the mortality. At the 30 days, 70% in case of aorta and 30% in 1 year, and 26 and 38 in the case of left ventricle migration. This is in a case of Japanese and one of ours, Dr. Panoulas, with 5-year follow-up images of balloon expandable valve placed in descending aorta. That's all.
Great, that was a tremendous case. Thank you. Thank you. I mean, this happens is because of the miscapture, no question about that. It was very masterful that you were able to fish out and pull the valve with a pigtail. And somehow you nailed it right after the left subclavian. That was very good. That was excellent. If you had obstructed the left subclavian and worse the carotid, we maybe have more problems. The other problem is if you pull it too much, then you end up causing a descending aorta dissection that would also be pretty bad. So considering all these possibilities, you did a great job. Professor Alexopoulos, any comments here, please?
Very nice case. You were
Dr. Mezilis, get ready.
Unlucky at first stage, but you were lucky at the second stage. It happens 1 in 1,000, and you were the second case in 1,000, yes, probably.
A big
now,
success.
My question is, in retrospect, is it something that you could have done differently?
No.
Having in mind all this,
no.
like
well,
better,
I had
more
great...
rapid pacing, for dilatation, something like that?
When it happened, I had a crazy idea to get the second valve into the first valve and make a TAVI in TAVI, if it was possible, but it isn't, because the second valve, the first valve moving all the time up, downs, up, downs. This was the problem.
Got it in the perfect position. That was really great. Thank you. And let's move to Dr. Mezilis from Agios Lukas Hospital, TAVR, when all conventional routes or roads are blocked. And please, let's stick with, from now on, we'll stick only to the case presentation. We no more slides with data. Only presentation of the case and comments from the panel. That's it. We move ahead. Dr. Mezilis and Dr. Leontiadis to be coming up next.
Thank you, Dr. Dangas. Dear colleagues, this is a rather conventional TAVI case through an unconventional route of implantation. I would like to thank the organizing committee for inviting me, and especially Kostas, in this, which is what I think one of the most important annual valve meetings in our country. I'll present some clinical data about the patient. He's a 78-year-old male, hypertensive, hyperlipidemic, heavy smoker, and he suffered with progressive dyspnea over the last 6 months. He has a long and sort of very dense history. Started in 2005, where he underwent cabbage with cabbage by 3. And then in 2015, he had 2 stents in both iliac arteries. He diagnosed with a big aneurysm, calcified aneurysm in the thoracic aorta, which, for which he received no treatment. He also had a localized chronic dissection in his ascending aorta near the arch. He has one kidney and also suffered from bronchiectasis. The reason for his dyspnea was severe aortic stenosis with a peak gradient of 62, mean 37. The aortic valve area was 0.5 square centimeters, and he had a sort of mild left ventricular dysfunction with an ejection fraction of 45 to 50. He underwent catheterization. His grafts were patent, and this is the ultrasound in the parastellar view. You can appreciate the hypertrophy and his left ventricular function, and this is the Doppler, C4 millimeters through the aortic valve, and this is the apical 4-chamber view. Again, a rather good ejection fraction in the aortic valve area, which was 0.5. Now we're coming to the interesting part, which is the CT scan. And this, the left image at the level of the valve, you can see a lot of calcification there. And at the sanotubular junction here, the measurements were quite big. Actually, the average was 30. I don't have the other measurements, but really we're talking here about a big, large valve. And this is a video from his CT scan. It's a coronary planes moving from front to back. And you can see 3 interesting findings here. If you look, this is the localized dissection here. Then as we're moving back, this is the large, huge aneurysm calcified with thrombus. And here you will see in a minute, this is at the end of the aneurysm. Here you will see the 2 stents here. So when we assessed any possible routes, this became rather complicated. We obviously excluded the femoral implantation. You see the 3D rendering of the aorta here with all the bends and the stents. And the second route we assessed was the transaortic, and this also was excluded due to heavy calcification, the presence of the grafts, and also the dissection higher above. Then we're left with a, sorry, I have to book, sorry, move back, sorry, here. The subclavian artery, which was heavily calcified again, here, and it was a small diameter, so this was excluded, and we left finally with the two carotid arteries. The left carotid, which you see here, was a rather sort of calcified and small vessel with a lot of disease. This was excluded also, and I have to mention that in most of the cases that were done through transcarotid approach, the left is more convenient due to the trajectory of the whole system. But finally, the right carotid artery here was a decent vessel with mild calcification and sort of a diameter which could accommodate the valve. So this is the sort of comparison left to right. Right is much better vessel. So we decided to implant the valve through the right common carotid artery, and we had to implant a big valve. So a few words about the procedure. This was obviously a surgical procedure done by two surgeons, Dr. Tsolakis, who you all know here, and Dr. Bakas from St. Luke's Hospital. The right common artery was exposed through a longitudinal incision, which was done above the sternum. They pushed away the sternocleistomastoid muscle, and the procedure was done not with an incision, but with a Seldinger technique. So the cross-clamping time was much less. A few slides about the procedure. Here you see it was pre-dilated with a 25 millimeter balloon. And you have to understand that it's not a very convenient way to implant valve. We are behind the patient's head, and the implantation is done by holding the whole system in the air with a little help of a table. So this resulted in a couple of failures trying to deploy the valve, which dived here rather deep to the left ventricle. A second attempt was also a failure, and have to retrieve the valve. And the third attempt, sorry, was successful. The valve was implanted rather slightly deep, but nevertheless, the result was good. I'll show you the ultrasound. And then the surgical closure followed by using a 6-0 Prolens sutures, and the cross-clamping of the carotid artery, which was about 6 minutes. This is the ultrasound immediately after the procedure. You see good left ventricle. There's a minimal paravalvular leak, as you see here. There was no post-dilatation of the valve. We thought that this was a decent result. The velocity through the valve was almost 2 meters, but when we checked the patient a month later, he was doing fine. He was in class 1, and it was less paravalvular regurgitation, and this was the Doppler through the valve, which was good. So to conclude, the numbers of the transcarotid implantations are growing. This is one of the first publications with 50 patients. And it's interesting to see that the results are totally comparable with the transfemoral route. And this is the second, quite bigger, from both these studies were done, are coming from France, 100 patients. And as you see here, the valve which is most used is the Edwards Sapien due to more conveniency for implantation. So transcarotid approach is safe alternative when all other conventional routes are unfavorable. The numbers are growing. left common carotid is the most favorable choice, and the results are comparable with transfemoral TAVI. Thank you.
Great. Thank you. One comment. Professor Voranakis is very experienced with the Evolute valve. You think these neck procedures you end up kind of misplacing and have to do like a few times? I think I would say with this kind of highly calcific patient, all this up and down with a non-self-expanding valves must be something, some kind of risks, no?
Yes, it is. To tell you the truth, this is a procedure that we have not performed in patients. I know there's a lot of experience with surgeons and in France. My question is, you said the left is the preferred approach.
Yeah.
Usually, the right carotid might be more actually and avoiding this angulation. But still, it's I would say very high risk procedure for embolization. And what size of sheath? You had a 6 French at the end.
6 French at the beginning. That's standard
At the
procedure,
beginning,
which
the
ends
beginning,
into
no,
10 French.
because the size of the valve definitely higher. Yeah, 14 French. Yeah, it's a big.
I guess we're a bit lucky, but there's no sort of, chance of having a protection here.
Yeah, I mean, you got to, as you say, open it up and see which one is the bigger, and then, you know, if there's some strange angulation, absolutely. But you do a great job. Excellent. Let's move on, Dr. Leontiadis. Transcatheter therapy in a heart transplant patient. And I see one empty chair there. Dr. Iakovou, why don't you join us up here with the, for the discussion of this case from Onassis Heart Center. Let's go ahead, please. Dr. Niños, getting ready, next. Dr. Janis, getting ready next, please.
Okay, good evening. Thank you very much, Dr. Spargas and the organizing committee for this kind invitation. This is the case of a 62-year-old male who has had a history of a dilated cardiomyopathy. And he underwent BIVAD ventricular assist device implantation in 2006 due to end-stage heart failure. But some months later, he had an outflow cannula infection, and he had to be transplanted almost 15 years later. And the intraoperative findings showed adhesion and mediastinitis, so severe infection. The graft came from a 44-year-old man with intracranial hemorrhage, and this is the first echo of the transplanted heart. We can see a bicuspid valve with a fusion of the non and left coronary cusps, which puts him in the type 1 classification by the Zivers classification of the bicuspid valves. 14 years later, we see a progression of the calcification, and the patient had severe stenosis, also severe aortic regurgitation. The left ventricle was dilated with an ejection fraction of 40–45%. And these are also the numbers, moderate severe stenosis with a peak gradient of 50 and a mean gradient of 33 millimeters of mercury, and also severe aortic regurgitation, as we can see by the short pressure half time on the aortic valve. So this is the aortic valve index was 0.6 square centimeters per square meters. He had pulmonary hypertension, as you can see by echo and in the right heart cath. He had moderate calcification of the raphe and the leaflets, according to the paper of Yoon from California from 2002. We can see here from his CT scan the non and the left coronary cusps. And what we can also appreciate on this echo here, apart from the stenotic valve, is this aneurysm which is on the side of the membranous septum, as we can see here on the transthoracic echo. So this is adjacent to the membranous part of the interventricular septum. This is a zoom view from his transthoracic echo. We see the valve, the aortic valve. We can see this bulge, this aneurysm, but there's no flow going through this. So this is an aneurysm which is spontaneously closed, an aneurysm, ventricular septal defect, which is closed with tricuspid valve tissue. And this is from another patient. I just want to show you the pathology. You see the thickened, elongated leaflets, the septal leaflet of the tricuspid valve, which go and close this gap, which is the perimembranous ventricular septal defect. This is also an intraoperative finding. You see it's closed, so it's a perimembranous VSD, which is closed with a tricuspid valve tissue. It's the most common VSD form, complicated with aneurysm formation and aortic regurgitation. And we should keep in mind for the next few slides that the membranous part of the septum lies under the right and the non-coronary cusp, and it's in vicinity with the bundle of His. So according to the Hartam, this was a symptomatic patient with moderate to severe aortic stenosis, severe aortic regurgitation with a high Euroscore score, already twice operated on, especially the last time with infection of the mediastinum, on chronic renal failure, atheromatoxic lesions, and coronary graft vasculopathy, had a CTO, instant CTO of the mid-LAD, and slightly impaired ejection fraction of the left ventricle. So the decision was to go ahead with TAVI. This is the multi-slice CT, once again showing the aneurysm I just showed before. And the next question is which platform we would use. In our hospital, we have the greatest experience with the Evolut platform, but for this particular patient, we thought that the Evolut R has an increased radial force at this part, and it would protrude too much under the annulus, so this would be a problem at this region where the VSD was located. So in order to avoid any possible injury in this region, we went for the Edwards valve. We made all the measurements as we know them. It was a tubular configuration according to the Bavard registry by Toulouse. So we used the mean aortic diameter to size, and also the circle method provided to us. And the rest was not complicated. We performed a balloon valvuloplasty because, as I said, it was a bicuspid valve. You see here the occluded left anterior descending artery. And then we put in a rather high position with 17 cc's of volume inflation. The tricuspid, the aortic valve with a very good final result. And this is 1 year after the TAVI. You see the ventricle is already smaller, the smaller hypokinesis at the apex, but the ejection fraction is 50%. And continuous Doppler, where the patient has 15 millimeters of mercury gradient on the valve, and on a CT scan we see this elliptic configuration of the valve, which is rather often in bicuspid anatomies. Thank you very much for your attention.
Okay, excellent. Excellent. Dr. Iakovou, any comment about the planning and decision-making of this procedure?
Well, I think it was an interesting case. I don't remember, Vangelis, when was that? It was maybe
2-3 years ago.
Yeah. So what we do in our In our practice, we always discuss in the heart team these cases, and of course, we are doing meticulous sizing, and we interact with the imagers. And I think this is the way to go. I think we discussed a little bit about since this is Edwards valve, but the predilatation necessity, but still it's bicuspid, so we played safe, and we discussed, and that's what we did.
Yeah, it was good, the predilation, and you did the aortogram as well at the same time. That was really good. Great, thank you so much. It was very good. Let's move ahead to Dr. Janis from Metropolitan Hospital, transcatheter valve migration during periprocedural cardiopulmonary resuscitation. And next presenter, Dr. Rubelakis, please to get ready.
No.
Yeah, let's go ahead, please. That's why I announced who is next, so we can have a very fast turnaround of the slide set. So Dr. Rubelakis is next. Please locate already the presentation.
Thank you.
Go ahead, Evgeny.
Okay. Thank you very much for the kind invitation. I will present a case about the transcatheter valve migration. So this is a TAVI complication case. It's about a severely diseased 78-year-old man with previous CABAs, now presenting with heart failure symptoms and severe aortic stenosis. He has also COPD, chronic kidney disease, and the Euroscore and STS score is really high. From the echocardiography, ejection fraction is 35, and it has biventricular dilation with pulmonary artery hypertension. Aortic valve anatomy is also dilated, and the ascending aorta is porcellanoid. Mitral valve has also moderate to severe insufficiency, but we decided to go, because the patient is severely diseased, to TAV implantation and then to reevaluate the mitral valve for possible mitral clip procedure. So here is the sizing. The area is 8.6, so we decided to implant an Evolutart 34 millimeters valve. Coronary ostial acceptable height. Here is the orthography. Here is the TAVI implantation of an Evolutart 34 millimeters. During the implantation of the valve, a patient was unconscious, and we started cardiac arrest, so we started chest compressions and gave inotropes. When patients recovered from the cardiac arrest, the first image we had, if the orthography is a valve migration higher in the LVUT in the ascending aorta. So we decided to implant a second TAVI, same Evolutart 34 millimeters. We recrossed with a pigtail, and then we implanted the second valve. We implanted the valve. During the second implantation, patient became again unstable and had cardiac arrest, so we proceeded with compressions with Lucas device and inotropes. When the patient recovered, we removed the stiff wire to assess the result of the second implantation, and we did the echocardiogram. The echocardiogram showed a mild to moderate paravalvular leak. So we decided to recross with a pigtail and to cross with a stiff Landerquist wire again. Then we tried to do a post-dilation to improve our result. But we see here in the image that the balloon didn't expand well in the proximal part. We haven't noticed this, we haven't evaluated really good during the balloon inflation, and then we tried to detach the balloon, and here is what happened. When we tried to remove the balloon, both valves embolized in the ascending aorta. Then we had the problem to detach the balloon catheter, and we started to do rigorous attempts. The first attempt was just inflating the balloon and trying to detach it. That was didn't have a nice result. We couldn't detach the balloon. The second attempt, we tried to pass a second balloon from the radial axle in order to detach the one valve from the other, while simultaneously snaring the second TAVI from the femoral axis. And again, we couldn't detach the balloon. Then we tried the body balloon technique. We tried to cross with a second balloon between the two prostheses, and then we inflated the second balloon while snaring the second TAVI, again without any result. Here we see how strong were the attempts with no results. Again, nothing. And then the final last resort was to try to do the mother and child technique. So we took the risk to cut the shaft of the balloon catheter, and then we advanced a long Cook 10 French catheter over the balloon catheter. In order to do the mother and child technique, we were pushing the Cook catheter while retrieving really hard the balloon catheter, and this was an attempt that has a nice result. We finally managed to detach the balloon between the two valves. But we don't have an image here. We see now the orthography, how the kinking of the left femoral artery. That was because the patient was hemodynamically unstable, and then we decided to implant Impella to be stable. Here are the attempts to recross. And here we see the attempts to pass the Impella from the aorta. We couldn't, so we placed a body balloon to straighten the aorta, and we finally managed to advance the Impella. And finally, the patient was hemodynamically stable with Impella in the intensive care unit. The patient was intubated, and finally, hemodynamically, he improved the second day, and we removed the Impella. But at the third post-procedural date, we released that at the CT scan that he had a large ischemic stroke. So here, the follow-up of the patient 3 months later was in a rehabilitation center with a large stroke. So the take-home message is in critical scenarios, as in our case, we can accept even suboptimal results. We had the mild to moderate paravalvular regurgitation. We could leave it like this without trying to improve our result. Another advice would be to, when we do post-dilation, we have removed the Landerquist wire from the left ventricle when trying to recross, and when trying to pass the balloon catheter, we can try to pass the balloon slightly inflated just to be sure if the catheter passes in a suboptimal place between the crowns of the TAVI. This is a complication that can happen, and we need to know how to manage it. Thank you.
Well, yeah, but why the patient was hemodynamically unstable every time you implant the valve? Is this because of a prolonged pacing, or why was the patient unstable, requiring CPR the first time, and then again the second time, same thing happened? Is the patient so sick in general? That's why? What?
From the beginning, he was a fragile patient with biventricular, left ventricular failure, and every time we tried to do a post-dilation or implantation of the TAVI, we should do after a more fast pacing, probably that was the reason, or we should do more quick release of the valve the first time, because the second time the patient was already unstable with intra-aortic balloon pump, so
yeah.
This,
Dr. Professor Voranakis here, sometimes we implant the core valve just with not very fast pacing. If you think that initial days, actually, they were recommended no pacing. Patients like that were very sick, and you think they're going to arrest and go to CPR with a fast pacing. Well, old school. You can implant, accept a little dip, and implant it at 80 or 100 or something.
Actually, as you said, George, this is when you have a patient who is unstable, you don't want to rapid pace anyhow, and a poor left ventricle. So you should concern about that. The other thing is, there are several things that you cross your mind. Second is whether you are hitting a papillary mask and get hypotension, what happens to the right coronary artery. It doesn't look that it shows well on the initial attempt, but it was a very complicated case. I mean, things went wrong on everything you tried, so, yeah.
Dr. Agre, any idea regarding maybe why even do the procedure in that case like that? Did that cross your mind, or maybe the patient too sick in general to attempt it, or what do you think?
Not think of anything else. I had exactly the same. I was wondering the same thing. Why that happened?
All right, great. Thank you so much. It's a very challenging case, very interesting. And let's go ahead with, TAVI in challenging valve anatomy. Let's see from one challenge to another. Dr. Belakis from the 3rd Department of Cardiac Surgery, Athens Medical Center.
Dear Professor Dangas and the rest of the panelists, I would like to thank Dr. Sparias and the organizing committee for giving me the opportunity to present this case, and being one of the 2 surgeons that present cases amongst well-known cardiologists. So I have the opportunity and the honor to be part of TAVI teams in 2 different hospitals, but this case is coming from the newly founded TAVI team at the 3rd Department of University Department of Cardiac Surgery at Soteria Hospital. So I'm just going to go straight ahead and present this case. It's an 87-year-old male with severe aortic stenosis, with a past medical history of hypertension, dyslipidemia, hypothyroidism. He has some mild coronary disease and a previous PCI to the RCA with a good result, and a history of abdominal aortic aneurysm repair with a tube graft, for which he has been operated on in 2010. He had a history of TIA and a Euroscore of 4.4. I've put this echo. He has preserved left ventricular function, 50%. The velocity across the aortic valve being around 4 meters per second, mild AR and trivial MR. And you can see here some echo videos which didn't clearly show that this valve was probably a bicuspid-like type of valve, but had clearly severe aortic stenosis. Now, going to his CT scan, the calibers of his vessels were okay. He had good distance to the coronaries, he had good angles. However, we noticed that on the images that show the cross-sectional area of the valve, there was some calcification, but there was also a raphe between the left and the non-coronary cusp. It was not a complete raphe, it was not a calcified raphe, but it was something that we're concerned about. The other thing that we see was the LVOT calcification that you can see at the middle picture at the sinus height, which also was a bit of a concern for this particular case. The third thing that we were concerned about was the tortuosity that this patient had at his iliac arteries. And also, apart from that, he had the tube graft at the abdominal aorta to make things a bit worse. So we were trying to decide whether this patient should go better for surgery or whether we should carry on with TAVI. So we decided to carry on with TAVI and play it safe, conscious sedation, the pacemaker lead, and we did a surgical cut down to assess the right common femoral artery. And in order to try to deal with the tortuosities, we used the long sheath of the centroid of Medtronic and the Landerquist wire. So you can see on the left side of the screen, as we're trying to advance this long sheath, which we managed actually to advance the whole way, so we could actually introduce the Landerquist after that. And that's the initial injection that we done to see that was the level of the aortic valve. Now, following that, we did a pre-dilatation with a balloon, which was successful, and then we started dealing with the expansion of the valve, which was a bit of a struggle, because as you can see, there is some under-deployment of the nitinol stent. So we did this nice and slowly and gradually by checking every now and then and how the valve was expanding. But the end result was not really successful, as you will see, as the patient had some significant aortic regurgitation. And also, as you can see on the right side of the screen, it was a string sign effect, which means that the nitinol didn't expand properly, and that's what caused the paravalvular leak. So as a next step, what we tried to achieve was to try to use a balloon, a post-dilatation balloon, which was 25 millimeter, 45 millimeter in length balloon of Medtronic. And you can appreciate on the left part of the screen how the valve expands towards the area away from the LVOT calcification, which is something that we had to worry about because we were worrying that we might have the rupture of the aortic root. The end result was quite good, however. We managed to have no significant paravalvular leakage, and you can see the valve working well. There was no significant gradient. There were good end-diastolic pressures on the ventricle, and the patient had an uneventful recovery. He was discharged on the third postoperative day with a good pre-discharge transthoracic echocardiography, which showed some trivial aortic regurgitation and very acceptable velocities across the aortic valve. So the TAVI with self-expanding valve can be done safely in patients with bicuspid-like anatomy, but we have to take into consideration calcifications of the valve and the RAFI and the LVOT. Cautious post-dilatation can treat string side effect, and tortuous electrotrosis can be dealt with long sheaths. Thank you very much.
Yeah. Yeah, this was like borderline infolding of that under expansion. Very good that it expanded. Sometimes it doesn't expand. Any comment from Professor Alexopoulos, Vavranakis,
Make a comment since I know the case also. This is what we have described in the past, the string sign. That's why he called that. And sometimes it doesn't unfold totally if it's actually calcified RFE a lot. This one, that's why he mentioned it was moderate calcified, so we decided to proceed, and actually went fine at the end. So, and also the tortuosity with the long sheath of the Medtronic, you are able to go up high, and if you are able to straight up things, that makes it.
Great, thank you. Thank you, great. That was a great case and a great save. Let's move on. TAVR in horizontal aorta from Mediterranean Medical Center. Dr. Psathas, and presented with Dr. Manginas, the director over here. Thank you for coming, Thanas.
Much, dear panel. Thank you for the kind invitation to present this case we did with Dr. Psathas. And this is a female, 81-year-old, with severe aortic stenosis, with chronic kidney disease, pulmonary hypertension, COPD, several comorbidities, thyroid disease, thrombophilia with history of pulmonary embolism, and a Euroscore, as you can see, high enough. And we did this case, and we made measurements for the aortic valve and the annulus. The coronaries are fine. The sinus of Valsalva are okay, satisfactory. We made several measurements. You see that this is a possible bicuspid valve. And here you can appreciate with two different valves the severity of the horizontal aorta and the 65 degrees angle. You see here on the left, you see the left ventriculography, good LV function. You appreciate again the horizontal aorta, aortic root, pre-dilatation with an 18 by 40 millimeter balloon, and an attempt to place a self-expanding Navitor 26 valve. We used this valve and we did several attempts to put it in a good position. We actually exhausted all the attempts of the valve, this particular valve. And at the end of this, we were puzzled of what to do next. Should we open another Navitor valve? We should go ahead with a different self-expanding valve. And actually, we decided to use a different valve. The reason for the next valve was to have a different valve with a better radial strength, a better stability with the same wire, and we used the Evolut R 26 millimeter valve. And with the first attempt, we were able to place it in a good position, satisfactory position, to actually leave it. And you see here the final position of this Evolut valve, which is actually satisfactory without AR, without paravalvular leak. Horizontal aorta presents several tips and tricks that one should know. to direct the valve to the proper position. I'm talking about self-expanding valves. One can use snare techniques, as you can see here. There are different techniques to orient the valve in horizontal aortas, to put it coaxial and leave it in a good position. There are other techniques like the balloon nudge technique, where you put a balloon next to the valve and actually direct it to be at the proper position so that it doesn't move away or pop up. And the reason for this presentation is actually the question of which kind of valve to select, which is a serious question. Previous studies, as you can see here, talk about the difference between balloon expandable and self-expandable valves. Of course, associated, there was an association of increased need for a second valve and post-dilatation in horizontal aortas, and previous studies like this one suggest that increased aortic root angulation actually adversely influences acute procedural success following self-expandable but not balloon expandable. So there was a preference for balloon expandable valves. You see here in this slide that self-expandable valves, when the aortic angulation is above 48, they have lower success, higher percentage of post-dilatation, more PVR, and of course, trend for more pacemaker implantation. In contrast to these studies, later studies, more recent studies, using again in different third-generation valves in 841 patients, as you can see here, suggest that aortic angulation no longer presents any role or no longer